anatomy of the area. So, through VATS, we can perform all the operations inside the thoracic cavity, as well as minimal invasive cardiac surgery. The benefits of it, first of all, that it's minimal invasive. We have a panoramic view, enhanced surgical precision, and for the patient that it involves small scars, less pain, less rehabilitation time, and shorter hospital stay, and generally reduced complications. So the complications are the same as every other operation in the thorax. What I want to note is that we have a specific complication, which is the conversion to open surgery. So there is a very small probability that we may need to open the patient if things go wrong immediately, because you can understand that in the thorax we have major vessels. So if something goes wrong, for example, if we have an uncontrolled hemorrhage, we need to open the patient immediately. Our experience is ranged for 3 years. So we performed 20 uniportal VATS lobectomies to 20 patients. 16 were males and 4 were females. We performed 8 left upper operations, 4 left lower, 4 right upper, and 4 right lower. All of them, as you can see, were heavy smokers. The operative time ranged from 4,000 minutes to 3,000 minutes. For the management of the post-operative pain, we used epidural analgesia, paravertebral block, intercostal nerve block, and intravenous analgesia. I need to say that we had one operation, which was a redo operation, actually. So it was a redo operation after 20 days, and it was very complicated, the operation. So after 9 hours of surgery, we decided to open the patient due to a hemorrhage, which was actually controlled. For the histological tests of our patients, we had 10 squamous cell carcinomas, 6 adenocarcinomas, 1 Hodgkin lymphoma, 2 large cell carcinomas, and 1 neuroendocrine cell carcinoma. So I have a video here again. So this is the pulmonary artery. The forceps from the behind is called the snake, while the forceps in front is called the peanut. And you can see how the surgeon is trying in order to dissect it. So imagine that if something goes wrong here, it will take a lot of time to fix it, and it will be life-threatening. Again here, you can see that we have the bronchus. This is a stapler for the bronchus, and this red thing is called a vessel, and we use it in order to manipulate the structures that we want to dissect. So now, I also have some pictures with my team from the Athens Naval and Veterans Hospital here. And in conclusion, lobectomy operations are very basic and significant operations, but despite being difficult, they can be completed minimally invasive with less pain, fewer complications, and better quality life for the patient. The decision-making process of the operation should focus on patient's overall health, the extent of the disease, the type of the procedure, the surgeon's expertise, and the hospital resources. And because it's an issue of competitiveness and advertisement, I believe that it's very important to mention that from my personal experience, a VATS procedure can be modified significantly fast to an open formal thoracotomy, much more faster than robotic-assisted thoracoscopic surgery for safety reasons, because we need approximately 15 minutes to remove the robot from the OR in order to operate, to gain access and operate on the patient. And we don't have this time in the operations of the thorax if something goes wrong. Okay, we must act immediately. Thank you very much.
Thank you very much. In the interest of time, we won't be able to take any questions now, but anyone has a question can talk to the speakers later on after the session. Okay, so we're moving, thank you very much. We are moving on to the next presenter for today, Athanasia Zambeta from the Cosmetic Derma Medicine Clinic, Nicosia. The title of her presentation is Biology of Skin Aging and Sun Damage.
Hello, good morning. I'm Dr. Athanasia Zabeta. I'm dermatologist venereologist, and today we will discuss about biology of skin aging and sun damage. Our skin is the largest organ of our body, and it's a unique biologic universe with its own blood, innervation, muscle, immunity. It works as an endocrine system with its own psycho-emotional reactivity, and of course, it is the environmental barrier that protects us. Let's talk now about aging. It is a total of progressive physiological changes in an organism that lead to senescence. It's actually the decline of biological functions and the organism's ability to adapt to metabolic stress with time. Here it is a very interesting picture that contains all 9 hallmarks of aging as were described in 2013, respective article published in Cell magazine. These are the genomic instability, telomere attrition, epigenetic alterations, loss of proteostasis, deregulated nutrient sensing, mitochondrial dysfunction, cellular senescence, stem cell exhaustion, and altered intercellular communication. Actually, there are 2 theories about aging. One theory says that aging is a preordained process that is genetically determined, and it is called intrinsic aging. This theory is supported by telomere lengths, actually the last portion of a chromosome that gets shortened after every cell cycle. As this telomere gets shorter and shorter, it gets in a critical length, and after that length, apoptosis is starting on the cell. There is also one other theory about aging that says that aging is largely due to cumulative environmental damage. This is the extrinsic aging that is caused by reactive oxygen species that affects some cellular defense systems and reduces the activity of antioxidant enzymes and non-enzymatic antioxidants. In this picture, we see that skin aging is both intrinsic and extrinsic. We will talk more elaborately about these 2 types of aging. About intrinsic aging, it is a cellular aging and shortening of telomeres. It is caused by mutations of mitochondrial DNA, of genetic mutations. It can also be caused by decrease of estrogens and androgens. That's why in menopausal women, when we have excessive excessive reduction of sex-specific hormones, we experience deterioration of skin structure and moisturization of the skin. How skin with intrinsic aging looks like. We experience flattening of the epidermis, loss of subcutaneous fat, and reduction of dermal mast cells, reduction in the production of melanin, of collagen and elastin, and sebum. And now let's talk about the extrinsic aging, when the most important environmental factor of extrinsic aging is photoaging. Ultraviolet radiation is divided into 2 types, UVA and UVB. UVA radiation is absorbed by cellular chromophores and produces ROS, so causes more increased risk for skin cancer. And UVB radiation is responsible for sunburn, tanning, and causes a direct damage at the DNA through inflammation and immunosuppression. In this picture, we see how UVA and UVB exposure produces this reactive oxygen species and induction of matrix metalloproteinases. ROS and MMPs cause degradation of the extracellular matrix and inhibition of neocollagenesis. So we see destruction of the elastic fibers and the formation of wrinkles. In general, UV-induced damage lead to non-melanocytic skin cancer, which is the main problem in photoaging. In this picture, we see how photoaging affects each cell in our skin. And now let's discuss the clinical appearance of intrinsic and extrinsic aging. Intrinsic aging makes our skin look uniformly pigmented with rare hair follicles and gentle sweat glands and sebaceous glands. The skin gets less elastic, fine wrinkles appear, and the expression lines are more exaggerated. On the other hand, photoaging causes coarse wrinkling in our skin. The texture gets rough, we experience sallow complexion with mottled pigmentation, there is loss of skin elasticity, we start to see some fine telangiectasias on the skin, there is increased fragility, purpura formation, impaired wound healing, and of course benign and malignant growths. In the following pictures, we will see some aesthetic concern about photoaging, but the most important concern is about medical complications. On the first picture, we see some precancerous lesions, which are called actinic keratosis, and on the next pictures, we see skin cancer, both basal cell carcinomas, squamous cell carcinomas, and on the last picture, there is a melanoma. This is a viral picture at the social media. It's, here we see a truck driver with 28 years of working, and we see how the cumulative UV radiation has damaged the left side of his face because he drove from this side of the road. The important thing about photoaging is not only the cumulative UV radiation from the sun, but also the skin type that we have. People with fair skin tones, 1 and 2, according to Fitzpatrick, experience atrophic skin changes, focal depigmentation, epidermal atrophy, and ephyllites. But people with with darker skin types will see on their faces diffuse irreversible hyperpigmentation, leathery appearance, and deep wrinkles. Apart from photoaging, there are also other environmental factors that cause extrinsic aging. These are tobacco smoking, infrared radiation, which is actually half of total incident solar energy that we receive, and pollution. Pollution causes damage which is worsened by solar radiation. UVA radiation combined with environmental pollutants like cigarette smoke can increase the risk for skin cancer. So how can we prevent or even reverse skin aging? Of course, we should use lots of sunscreen. There are 2 types of sunscreen, inorganic and organic ones. Inorganic reflect, scatter, or absorb UV radiation depending on the particle size and the wavelength of the light. They do not cause any skin irritation or skin sensitivity, but they cannot penetrate into the layers below the stratum corneum of the epidermis. And there are also the organic ones which absorb UV radiation, whereby the agent's electrons reach an excited state. Last but not least, we can prevent or even reverse skin aging with the use and consumption of non-enzymatic antioxidants like ascorbic acid, coenzyme Q10, vitamin E, niacinamide, B-carotene, and of course polyphenols like green tea, polypodium, leucotomos, and silymarin. And lastly, let's have a take-home message. How can we protect ourselves in order to prevent skin aging? At first, we can drink a lot of water, eat good food, sleep well, exercise regularly, reduce stress, if possible, and use SPF. Thank you very much.
Thank you very much, Dr. Zabeta. It was very interesting. So we will move to the next presenter. Thank you once again. Dr. Maria Zandi from the Biostatistical Unit of the Cyprus Institute of Neurology and Genetics will present the analysis of more than 400,000 women, provides case control evidence for BRCA1 and BRCA2 variant classification.
Good morning. I would like to thank the organizing committee for giving us the opportunity to present our work which is on the analysis of more than 400,000 women to provide case control evidence for BRCA1 and BRCA2 variant classification. So a brief introduction. So breast cancer is the most common malignancy, affecting around 8 million cases in the last 5 years. There are many risk factors contributing to an increased risk of the disease, including age, sex, lifestyle factors, sociocultural factors, reproductive and hormonal factors, as well as family history. So around 5 to 10% of all breast cancer cases are familial cases of the disease caused by predisposing variants in the germline DNA. So BRCA1 and BRCA2 are one of the high penetrance breast cancer susceptibility genes, conferring 5 to 10 times increased risk of developing the disease. Genetic testing for these genes is offered to individuals who have a higher likelihood of carrying a pathogenic variant, for example, individuals diagnosed at an early age of onset or with many family members with the same cancer. So genetic testing identifies variants, and these can be classified into 5 classes. The benign and likely benign ones, which are the ones that do not require any clinical interventions. The likely pathogenic and pathogenic ones, the ones that require clinical interventions, such as closer surveillance at an earlier age, prophylactic surgeries, chemoprevention, and targeted therapies for the individuals that already have cancer. However, we have an intermediate class called variants of uncertain clinical significance, for which, unfortunately, we don't have enough evidence to conclude to a variant class. Variant classification is dependent on multiple lines of evidence, and it's performed according to the ACMG-AMP guidelines. And these evidence include the variant's nature and position, results from functional studies, the variant co-occurrence with another pathogenic variant, disease co-segregation within families, family history, and of course case control data. So these evidences are preferably measured as likelihood ratios and then weighted to code-strength categories, which are then combined together to provide the variant classification. So case control variant frequency is currently used under the ACMG-AMP guidelines and the PS4 criterion, which states that using logistic regression, an odds ratio higher or equal than 4 and a confidence interval not including 2 can provide strong pathogenic evidence. However, using logistic regression, we cannot derive any criteria for benign evidence. That's why we tried to develop the case control likelihood ratio method, which actually uses a survival analysis framework and compares the likelihood of the distribution of the variant of interest between cases and controls under the hypothesis that the variant has similar age-specific relative risks as the average BRCA1 or BRCA2 pathogenic variant, compared to the hypothesis that the variant is not associated with an increased risk of the disease. So, in collaboration and equal contribution with my colleague Denis O'Mahony, we analyzed 3 large data sets: the Bridges dataset, the Bridges panel sequencing data from the Breast Cancer Association Consortium, the panel sequencing dataset from the Carriers Consortium, and whole exome sequencing data from UK Biobank. We had in total around 97,000 female cases and around 305,000 female controls, and a sequencing data from around 11,000 BRCA1 and BRCA2 variants, of which around 7,000 with encoding sequences plus minus 5 base pairs flanking the exons. So we used this data and analyzed it using the case control likelihood ratio method and logistic regression. And following many validation steps, we finally derived case control evidence for 686 BRCA1 and 1,035 BRCA2 variants. As you can see from the pie chart, the majority of these variants were variants of uncertain significance in ClinVar or variants with conflicting submissions. So more details on the result. We derive evidence in favor of pathogenicity for 116 variants, whereas evidence against pathogenicity for 488 variants in BRCA1. Using logistic regression, unfortunately, we derived the PS4 criterion only for 13 variants. Now, in terms of the classification of these variants, you can see on the right-hand side that we have many variants VUS for the ones assigned evidence in favor of pathogenicity, and we have a 95.4 concordance with ClinVar. On the left-hand side of the chart, you can see for the ones that we assign evidence against pathogenicity, we have more than 50% VUS, and we show a 99.1 concordance with ClinVar. For the 13 variants assigned the PS4 criterion, only one was VUS, and the remaining 12 variants were classified as likely pathogenic or pathogenic in ClinVar. So now, in terms of the consequence of these variants, for the ones assigned evidence in favor of pathogenicity, the majority were protein truncating variants, followed by missense and synonymous. For the ones assigned evidence against pathogenicity, the majority were missense, followed by some synonymous intronic, inframe, and some protein truncating variants, whereas the 13 variants assigned the PS4 criterion using logistic regression, 10 were PTVs and 3 were missense variants. Similar results for BRCA2. We derive evidence in favor of pathogenicity for 150 variants, whereas against pathogenicity for 701 variants. Using the logistic regression analysis, we only reached the PS4 criterion for 18 variants. In terms of the classification of these variants, I guess we have a large number of VUS. We showed a high concordance with ClinVar. For the 18 variants assigned the PS4 criterion, only one was VUS, and the remaining 17 were variants classified as likely pathogenic or pathogenic in ClinVar. And in terms of the consequence, again, we managed to provide case control evidence for a large number of protein truncating variants, missense, synonymous, intronic, and inframe variants. So to briefly discuss these results, up to date, we only had case control evidence for only 111 BRCA1 and BRCA2 variants. Our results strongly correspond with ClinVar classifications, can be used for evaluating the consistency of other findings and other lines of evidence for variant classification. We managed to cover 21.3% of the ClinVar curated variants and 23.5% of the ClinVar unclassified variants. And finally, as you can see from the chart, we managed to provide case control evidence for 785 unclassified variants. Finally, this is a collaborative work. I would like to thank collaborators within BCAC, Carriers, and Enigma Consortium, of course, UK Biobank, my supervisor, Dr. Kyriaki Mihailidou, who supervised this work, my colleague, Dennis Mahoney, who equally contributed to this analysis, and of course, all of the collaborators who contributed to the development, application of the method, and analysis of these results. Thank you so much.
Thank you very much. So our next speaker is Orsalia Duduzaf from Imperial College London School of Medicine. The title of her presentation is A Step-Up Approach for Preoperative Malnutrition Assessment in Patients Undergoing Surgery for Gastrointestinal Cancer.
We have the wrong slides. The slides are wrong. The slides are wrong. Yeah. The slides are wrong. Wrong. In the wrong. Elena. Good morning. My name is Arcelia Tutuza, and I'm very happy to present the work of my team on a step-up approach for the preoperative malnutrition assessment in patients undergoing surgery for gastrointestinal cancer. Malnutrition in gastrointestinal cancer surgical patients is a very important issue, as we see that 1 in 2 patients undergoing surgery are presenting with malnutrition status before their surgery, and that has a large impact on their survival, recovery, functional status, and systemically on hospital stay. On assessment, there is an availability of several tools to assess malnutrition. However, there is an important and considerable variance in the reported diagnostic and predictive metrics. This is why we have identified the research gap in their comparative diagnostic and predictive accuracy, which we felt it was poorly established, and we wanted to delve into further. And therefore, we wanted to see how these different metrics might differ between the different tools available. There are different tools that we have. The first 2 are malnutrition assessment tools, and the latter are scorings of nutrition. And they take into account different aspects. We see that PGCSA, for example, is for triaging and has a multitude of patient, professional, and global assessment key criteria, whereas a scoring system as the CONET take into account lab-based parameters and are more robust into establishing the nutrition state rather than a malnutrition risk. Therefore, our aim has been to evaluate their predictive accuracy for postoperative outcomes in patients operated for gastrointestinal cancers. We have developed a cross-sectional bi-center observational study, which ran from March 2022 to October 2023 in 2 major university surgical departments of Athens. We have enrolled and studied 480 patients undergoing surgery for either colorectal, hepatobiliary, or upper GI cancer. And we used all those tools before their operations and analyze their performance metrics of sensitivity, specificity, a positive and negative predictive value, and area under curve with regards to 5 postoperative outcomes, including overall complications, major complications under the Clavier-Tinto classification, length of stay, advanced disease stage, and mortality. And this was for the entirety of their hospital stay and for 30 days post their surgery. Our results, first, with regards to malnutrition risk identification, have identified that higher rates were seen with PG, SGA, and GLIM, in contrast to lower rates with CONAT and GNRI, and with the only exception for hepatobiliary cancer, when GNRI was found to identify a much greater risk in a larger proportion of our cohort, and it was the only tool to also follow an inconsistency with regards to this cancer type. And when moving on to their comparative predictive performance metrics, we have seen that the image was reversed with CONT and GNRI, demonstrating a very high specificity to lengths of 80 and 90% for predicting overall complications, length of stay, mortality, and advanced disease stage. And CONAT specifically reaching specificity of over 97% for colorectal and upper GI cancer. However, owing to the lower specificity, we have also seen that PGCSA and GLIM, we had better sensitivity, but lower specificity, followed the completely different image. On a further analysis of the performance metrics, we've seen that the CONAT criteria were the ones presenting with the highest measures of specificity and had even a 100% positive predictive value of most outcomes, which was consistent across all cancer types studied, which means that it's a very valuable tool for identifying non-at-risk patients and decreasing false positives. On similar lines, GNRI with a very high specificity as well, but with a lower sensitivity, means that it might miss some at-risk patients which CONAT wouldn't. And then on GLIM criteria in PGCSA, these are tools that have moderate to high specificity and lower sensitivity, which means that they're most useful in excluding non-at-risk patients with a considerable risk of including false negatives, however. And because they are very significant in having a very higher sensitivity in mortality, they do remain very valuable for patients who are at a recognized risk. And with regards to our findings for area under curve, it was moderate for all the tools studied. That's a table that provides a comparative summary of the key performance metrics, for which we have felt that the most appropriate recommendation of our research to put this into the clinical context was the recommendation of a step-up approach. So currently, under the most international guidelines that are present for malnutrition assessment of oncological patients, it's recommended that CLIM criteria take first place and then another criteria. So there isn't a clear and direct indication of which criteria should follow CLIM. And based on what we have seen from our comparative analysis, we propose that CLIM or PGSGA can be used as a primary step to identifying all those who are at high risk, so also excluding those who are not at low risk, because that's also very important in the context of oncological surgical patients to ensure that we perform a fair resource allocation and also that timely operations take place without putting on a further risk and oncologic burden on patients who do not present with a high malnutrition risk. And then on a second basis, for the patients who have a recognized malnutritional status, we can perform CONAT and GNRI. So this would be as well in line with guidelines that are present, but giving a further direction, as they are much more specific to and predictive of postoperative complications, which if recognized, we can act upon clinically. So as future directions, and given what we have found and what we appreciate in the literature, we believe that it's very critical that in the next years we validate the accuracy of those metrics across clinical settings and patient populations. And we continuously develop our tool assessment tools in order to refine their cutoffs and provide a better certification of patients. And finally, the inclusion of nutritional assessment into the broader perioperative care framework, which is very important, as we've seen that it's critical to establish optimal clinical outcomes, but also to ensure that we are identifying the risk appropriately and acting upon it. Our conclusions: CONAT and GNRI exhibit high specificity and therefore hold value in confidently ruling out non-at-risk patients for postoperative complications and minimizing false positives. However, tools such as GLIM and PGCSGA, which have superior recipient sensitivity with slightly less specific, are more effective at identifying those at risk, especially for mortality. Therefore, owing to their comprehensive assessment criteria, they can complement high specificity tools in a balanced approach to enhance overall screening efficacy. A step-up approach is recommended, starting with PGSGA and GLIM, as also suggested under current guidelines, but then followed by a complementary evaluation of CONAT and GNRI, which can further guide us in how we triage nutritional intervention and how we prevent postoperative complications for those at high risk of them in specific. And this approach remains down to further evaluation and validation in future studies to be tested across different clinical settings, cancer populations, patients, ages, with more to come on a very exciting field on how nutrition can truly revolutionize surgical oncology and progress of oncological patients. Thank you for your attention.
Thank you very much.
Good morning. The next presenter will be Emilia Grasou from the European University of Cyprus, and she will present the presentation with the title Resting Heart Rate and Mortality Risk in Hypersensitivity Patients with No Atrial Fibrillation, Adjusted for Cardiorespiratory Fitness and B blockade.
Good morning to all. My name is Emilia Maria Grasso, and in collaboration with Dr. Kokinos, Dr. Vaselis, Dr. Grassos, and Dr. Pitaras, today I'm going to present to you the correlation of resting heart rate and mortality risk in hypertensive patients with no atrial fibrillation, adjusted for cardiorespiratory fitness and beta blockade. So, to start off, the European Society of Hypertension guidelines recognize resting heart rate as an independent cardiovascular risk factor for hypertensive patients. Furthermore, it is well known that increased physical fitness significantly influences both overall mortality rates and specific resting heart rate levels, so much so that studies have shown that regular exercise lowers resting heart rate and is associated with improved cardiovascular health. However, despite its importance, the relationship between resting heart rate and mortality risk remains inadequately explored till this day, particularly when adjusted for cardiorespiratory fitness, age, comorbidities, and medication usage. So this extensive study evaluated resting heart rate and mortality outcomes in a large cohort of more than 400,000 hypertensive patients with a diverged mean age of 62.5 years old. Each participant completed a standard exercise treadmill test, which serves as a reliable tool for assessing cardiovascular fitness and endurance capacity. Key exclusion criteria for this study involve the presence of atrial fibrillation or any overt heart disease. These criteria were crucial to maintain the integrity of the data collected during the exercise treadmill test, thereby ensuring that underlying heart conditions did not skew mortality risk results. Participants were categorized into 6 distinct resting heart rate categories defined by 10 beats per minute intervals, ranging from less than 60 beats per minute to greater than or equal to 100 beats per minute. This systematic categorization allowed us to observe more clearly the comparisons across different heart rate elevations. Moreover, the study implemented extensive statistical adjustments for a multitude of variables, including age, body mass index, pre-existing cardiac risk factors, exercise capacity, and medication effects, particularly beta blockers. As I mentioned before, and as you can clearly see in this slide, the sample included more than 400,000 patients with a wide range of heart rates and varying medical characteristics, reflecting therefore the real-world hypertensive populations. To be more specific, the average age was around 62 years old, and the study participants had an average weight of 89 kilograms and an average BMI of 30. Also, the observed average resting heart rate was 75.4 beats per minute, indicating a trend towards elevated heart rates within the cohort, reflective of potential underlying cardiovascular concerns. And lastly, the study reported significant comorbidity prevalence, including smoking habits and diabetes, both of which exacerbate cardiovascular risks and mortality outcomes. So, the median follow-up duration for mortality data collection was approximately 10.6 years, so around 11 years. Throughout this period, a total of more than 107,000 deaths were recorded, providing a robust and comprehensive data set for analysis. The analysis revealed that mortality risk escalated by 15% for individuals with a resting heart rate of 80 beats per minute or greater, and significantly increased by 41% for those exhibiting rates of 100 beats per minute or higher. More importantly, as you will see in the next slide, these mortality risk trends were consistent across various age groups and were observed in patients on beta blockers, indicating therefore that elevating resting heart rate is a pervasive influence on mortality risk across diverse patient demographics. As I mentioned before, here we can clearly see the 15% increase in mortality risk for individuals with a resting heart rate of 80 beats per minute or greater in the dark blue bar, and also the 41% increase in mortality risk for individuals with a resting heart rate of 100 beats per minute or greater in the light red bar. Lastly, here it's easy to understand and observe that these mortality risk trends were consistent across various age groups, and more specifically for those that are 60 years old, for those 60 to 69 years old, and for those who are older or 70 years old. I would like to also point out that these findings achieved statistical significance, as you can see by the asterisk at the top of the slide, underscoring therefore the reliability and relevance of the data. Notably, we observed that for every 10 beats per minute increase in resting heart rate, there was an associated 11% increase in mortality risk, even after adjusting for various confounding factors such as age and exercise capacity. Moreover, it was observed that analysis without the inclusion of fitness data consistently overestimated mortality risk. This finding highlights the importance of incorporating exercise capacity into cardiovascular risk assessments to achieve a more holistic understanding of mortality risks among hypertensive individuals. Detailed analysis provided adjusted hazard ratios for mortality risk associated with multiple variables, including age, resting heart rate, body mass index, smoking status, diabetes, and exercise capacity, measured in metabolic equivalents, METs. Each variable was documented with respective coefficients and significance levels, illustrating the complex interplay of these factors in predicting mortality risk. Non-adjusted hazard ratios for mortality risk were calculated based on resting heart rate categories in subjects receiving beta blocker treatments, utilizing initial rates of heart rate under 60 beats per minute as a baseline control group for accurate comparison. Looking at this table, we can clearly see that the risk is lower when adjusted for METs in comparison to those not adjusted for METs, highlighting therefore the importance of physical fitness in cardiovascular health. To sum up, we noted a progressive increase, 15% to 41% in mortality risk, with increased resting heart rate at more than or equal to 80 beats per minute in hypertensive patients with no atrial fibrillation, and that the association was independent of comorbidities and medications. Furthermore, we noted approximately 11% increase in risk for each 10 beats per minute, and that the mortality risk was consistently overestimated when fitness was not considered. Thank you for your attention.
Thank you very much. The next speaker will be Fanny Kusuyani from the Department of Pharmacology, Faculty of Medicine, University of Thessaly, and she will present a presentation with the title of Studying the Potential Role of TMEM97 PGRMC1 sigma 2 receptor in pancreatic ductal adenocarcinoma development.
Hello, thank you. Good morning to everyone. I'm Fanny Kusuyani. Today we'll present you our work with the title The Potential Role of TMEM97 PGRMC1 sigma 2 receptor in PDAC development. Let's start with a short introduction part. Sigma proteins were thought to belong to the opioid family, receptor family, until 1976, and later they were identified as an independent class of receptors, divided into two subtypes, sigma 1 and sigma 2. They have high affinity for DTG and haloperidol members of non-opioid family, and their distinction was firstly happened after silencing of the gene of sigma 1 receptor, which showed the existence of a different gene of sigma 2 receptor. TMEM was lately characterized as the sigma 2 receptor. It is a near resident protein involved in homeostasis of cholesterol, and also it acts as an NPC1 interacting protein. PGRMC1 previously was thought to be the sigma 2 receptor, but it's not validated anymore. There is a mystery between the theories, where studies with sigma 2 ligands didn't show the nuclear localization of the sigma 2 receptor. So Hugh and his team suggested that the binding site of sigma 2 receptor may belong to PGRMC1, so they may act as a complex. That's why we aimed here to study both single size RNA, silencing of PGRMC1 and TMEM97 separately, and in the double silencing in the same time. Siramesine is the basic sigma-2 selective agonist, ligand of sigma-2 receptors, which through bibliography has shown a variety of anti-cancer properties, both in vitro and in vivo. So the aim of this study is to see the role of TMEM97 and PGRMC1, and subsequently the role of sigma-2 receptor in the carcinogenesis of PDAC, and moreover the role of these receptors in the anti-cancer activity of siramesine, as the literature suggests that some sigma-2 ligands act independently of the existence of sigma-2 receptors. The methodology we used is shown in this slide. I should highlight here that the cells that we use are a primary ex vivo pancreatic cancer cell population, which we isolated in our lab using patient-derived xenografts. In order to study further and to clarify the role of TMEM97 and PGRMC1, we transfected the cells with siRNA. Firstly, we wanted to see the efficacy of this siRNA that we used, so we performed the Western blot to investigate the protein levels of TMEM97 and PGRMC1. The results here show that the silencing was quite efficient for TMEM97 and PGRMC1, but it was not quite efficient when we attempted to silence both proteins in the same time. Next, after the successful silencing of the receptors, we tried to see the effect of siramesine, the ligand, on these primary cells. The results here shows that siramesine can inhibit the proliferation of the cells at low micromolarity levels, as you can see also in the table. And generally, here you see that the presence of TMEM97 and PGRMC1 is not important for the proliferation, as you can see the concentrations that provoke 50% of growth inhibition are approximately estimated to be the same for all the conditions tested. Next, we wanted to see the effect of siramesine and the silencing of this role on the colony formation using clonogenic assay. While TMEM seems not to affect the colony formation of these primary pancreatic cancer cells, PGRMC1 seems to affect the colony formation, so it might have an involvement in the aggressiveness of PDAC. Moreover, through this procedure, we show that siramesine induces a reduction in the number of colonies in a dose-dependent manner without any connection with the presence of the receptors. We subsequently wanted to check the impact of siramesine on the cell cycle of these cells, expressing different levels of TMEM97 and PGRMC1. Siramesine in the wild-type cells, without silencing here, shows a dose-dependent GO1 cell cycle arrest. And interestingly, that happens also when TMEM97 and PGRMC1 are not present. So this might, we can conclude here that the effect of siramesine does not depend on the protein status of TMEM97 and PGRMC1. Now, in an effort to see if and how siramesine affects these proteins, we studied cells treated with siramesine after 48 hours, and we see no impact, no significant alterations on the protein levels TMEM97 PGRMC1, a conclusion that emphasizes the hypothesis that siramesine may act independently of the presence of sigma-2 receptors. To conclude, the silencing of TMEM97 or PGRMC1 or both has no impact on the proliferation and the cell cycle of PDAC cells. PDRMC1, but not TMEM, may affect the aggressiveness of PDAC based on a clonogenic assay. And another important thing is that Siramesine seems that it's not affected by the presence of these receptors as a thing that supports the theory that some sigma-2 ligands are not influenced by the presence of this receptor, even if they are characterized as sigma-2 ligands. So, to clarify more this hypothesis, future experiments are planned in our lab, both in vitro and in vivo, also to see the role of these receptors and also to see how Siramesine acts, the mechanism of action of Siramesine, and its correlation between sigma-2 ligands, sigma-2 receptors, and the whole chemotherapeutic outcome in PDAC development. This is some bibliography. This research is supported by HFRI and DECA of University of Thessaly PhD fellowships. I want to thank my team that work on that project, and of course, thank you all.
Thank you very much, Mrs. Koussougianni. We now move to the final presentation for this session from Dr. Haris Mihailoudis from the School of Medicine of the European University Cyprus with the presentation topic on the role of eosinophil mitochondria function in severe eosinophilic asthma.
Okay, good morning. I'd like to thank the organizing committee for allowing me to present this work today. So asthma is a chronic inflammatory lung disease that involves extensive structural changes in the airway wall, leading to a narrowing of the airway lumen and therefore airflow obstruction. So asthmatic airways also show hyperresponsiveness to constrictor agonists, which can be induced by inhaled allergens or pollutants, leading to bronchoconstriction and asthma attacks, which further reduce the lumen. Therefore, patients with asthma are treated with corticosteroids, which reduce inflammation, and bronchodilators to protect from bronchoconstriction. However, 5 to 10% of patients with asthma suffer from severe asthma, where the symptoms persist despite the patients taking high doses of inhaled and oral corticosteroids, as well as bronchodilators. And these patients show a lower lung function and have more frequent attacks, and also side effects because of the high doses of oral corticosteroids they take. Therefore, they have increased mortality, lower quality of life, and a high cost to the national health system. Therefore, more effective treatments are required. A stumbling block in developing new therapies for severe asthma is the heterogeneity of the disease in terms of its causative factors, the genetic predisposition, as well as the underlying molecular and immune mechanisms. So a precision medicine approach is required in order to classify patients according to their cellular and molecular mechanisms. And this kind of approach has yielded biologic therapies that are currently used for severe asthma, such as the anti-IL-5 monoclonal antibodies. So in asthma, we have damage of the airway epithelium from inhaled irritants like allergens, pollutants, and smoke that trigger an abnormal immune response that consequently drives the remodeling of the airway wall and the bronchoconstriction, therefore driving the pathology. So there are 3 well-defined phenotypes of severe asthma according to the immune response they entail. The allergic and non-allergic eosinophilic asthma, which involve a Th2 type immune response and pronounced eosinophilia, as well as the neutrophilic asthma, which entails a Th1 and Th17 type response and neutrophilia. So in this study, we focused on severe eosinophilic asthma. So in severe eosinophilic asthma, or CEA, as I'm going to abbreviate it in this presentation, we have increased numbers of eosinophils in the lungs due to increased movement from the blood in response to chemoattractants, as well as due to increased survival and activation by Th2 type cytokines like interleukin-5. And eosinophils drive severe asthma pathology by promoting epithelial damage, remodeling, inflammation, and bronchoconstriction through the release of lipids and other types of inflammatory mediators. So in order to identify new treatments for severe eosinophilic asthma, we need to understand the mechanisms underlying the abnormal eosinophil function in this disease. So SEA patients that are not well controlled with standard treatments are prescribed biologics, such as mepolizumab, which is a monoclonal anti-IL-5 antibody that neutralizes IL-5 and therefore disrupts IL-5 signaling and survival of eosinophils. And studies have shown about 80% reduction in blood eosinophil counts and about 50% reduction in the exacerbation rates annually, which means that some patients still experience exacerbations after treatment, and this could be due to the persisting eosinophils. So another important aim is to understand the molecular phenotype of these persisting eosinophils following the treatment. So cellular metabolism is an important determinant of immune responses. This is the glucose oxidation pathway with glycolysis in the cytoplasm, producing acetyl coenzyme A that is then metabolized in the TCA or Krebs cycle to produce electrons that are then transferred across the electron transport chain to oxygen, driving the production of energy in the form of ATP. Mitochondria also regulate the intrinsic apoptotic pathway and therefore the survival of immune cells. And also glycolytic intermediates are used as nucleotide and fatty acid synthesis precursors. Therefore, immune cell activation and survival is often accompanied by reprogramming of glycolysis and OXPHOS. So in this study, we hypothesized that eosinophils from patients with severe eosinophilic asthma have dysregulated glycolysis and OXPHOS, which may drive their abnormal survival. So we determined these metabolic parameters in healthy subjects, patients with mild, moderate asthma, SEA patients on standard treatment, and patients on mepolizumab treatment. We also investigated the role of IL-5 in driving these metabolic changes and whether these metabolic reprogramming may promote the survival of eosinophils. So subjects from the above groups I just mentioned were recruited at the Royal Brompton Hospital, London, and eosinophils were isolated by Perkel centrifugation and negative selection by magnetic labeling. So firstly, we measured OXPHOS and glycolysis activity using a Seahorse XF analyzer, which permits the sequential injection of OXPHOS inhibitors to treat the cells, and at the same time can measure oxygen consumption rates in the extracellular medium, allowing the calculation of basal, ATP-linked, and maximal oxidative phosphorylation. At the same time, it can measure extracellular acidification rates to calculate glycolytic activity. So using this method, we've shown that the SEA eosinophils, shown here with purple, have significantly higher rates of OXPHOS compared to the patients treated with mepolizumab, as well as mild, moderate asthmatics and healthy volunteers. And that was the same across all three parameters of OXPHOS. At the same time, SEA eosinophils also showed a higher glycolytic activity compared to the other three study groups. Therefore, the eosinophils of severe eosinophilic asthmatics have a metabolic reprogramming that involves higher glycolysis and OXPHOS, which is not seen in patients that were treated with mepolizumab. So based on this mepolizumab data, we then went on to see the effect of IL-5 on this metabolic reprogramming. And 10 nanograms per mil of IL-5 for 4 hours increased both OXPHOS and glycolysis in healthy eosinophils shown in blue and SEA eosinophils shown in purple. So we show here that IL-5 may be driving this metabolic reprogramming in severe asthma. We then went on to look at the effect of IL-5 on the survival of eosinophils using annexin-5 propydium iodide staining. On the left-hand side here, we can see that at baseline, there's no significant difference between the survival of eosinophils between the two groups. But on the right-hand side here, IL-5 increases the survival of both healthy and SEA eosinophils. In order to try and link the metabolic reprogramming with the survival of eosinophils, we treated healthy and SEA eosinophils with a glycolytic inhibitor 2-deoxy-D-glucose and the OXPHOS inhibitor rotenone. So both inhibitors reduce the IL-5 dependent survival of healthy eosinophils. However, the same metabolic inhibitors had no effect on the SEA eosinophils, and this resistance may be because of the heightened glycolysis and OXPHOS that we observed due to the metabolic reprogramming. So to conclude, we have shown that eosinophils from severe eosinophilic asthma show metabolic reprogramming that entails increased OXPHOS and glycolytic activity, which may be driven by IL-5, which is also supported by our data from mepolizumab patients. We also showed that this reprogramming may be associated with the increased survival of eosinophils. Therefore, these initial findings will be continued, and there will be further studies involving transcriptomics and metabolomics in order to specifically see the mechanisms driving the reprogramming and maybe identify biomarkers for predicting or diagnosing this phenotype. So just some acknowledgements. I would like to thank my collaborators at Imperial College London, specifically Dr. Bravzar and his group at the NHLI and the Royal Brompton Hospital. And this work was funded by an NHLI Foundation scholarship, which covered our PhD student, Giannis Korateng, who carried out most of this experimental work. Thank you very much for your attention.
Thank you very much, Dr. Mihailudis.
For our next session, the satellite session by Cambridge Medical Academy, featuring a series of 12-minute lectures followed by 2 minutes question and answers for each presentation, we're pleased to invite our session chairs, Dr. Konstantinos Stylianou and Dr. Stefanos Christodoulidis, to the stage.
Good morning, everyone. I want to welcome you to our next session for today with the theme Satellite Session by Cambridge Medical Academy, One Health Personalized Medicine. I want to welcome to the podium our first speaker for today, Mr. Takis Skotis. Mr. Takis Skotis graduated from the University of Minnesota, Twin Cities, with the bachelor's degrees in Health and Economics and a Master's of Business Administration, MBA. In healthcare administration management. With over 40 years of experience in the healthcare industry, he specializes in transforming healthcare organizations through information and communications technology, focusing on strategic management, business intelligence, and healthcare KPIs. And today he's going to talk about innovation and entrepreneurship in One Health Personalized Medicine.
Thank you very much for the introduction, and I would like to welcome you to this session, Personalized Medicine, and also I would like to thank the organizing committee and especially Mr. Yannis Patrikios, who invited us. And also I would like to, before I start, I would like to ask you, how many of you attended Professor Adonarakis' presentation last night? Okay, great. So I believe that what you heard Professor Adonarakis mention yesterday and what we are going to present to you today, it's a continuation of this great talk that he gave. I'm not going to attempt to analyze his 4 kilos chromosome 21 book, but what I'm going to do is concentrate in 2 areas that he mentioned. Number 1, he said personalized and precision medicine. He didn't like those words. He didn't think that expressed exactly what those two words mean. So, for all practical purposes, let's stick with personalized and precision medicine, and let's see where technology is going to drive us. Here, let me tell you a personal story of another terminology that we use. It's called telemedicine. In 1995, we were invited to participate at the Royal Brompton Hospital on a project to study congenital heart disease remotely, utilizing telemedicine. And everybody was saying, why the term telemedicine? Well, telemedicine gave us the opportunity to study medical cases, not only like by that time we used to use as a telephone, but to utilize images. The term telemedicine today is called e-health. So we hope that what you hear today, personalized precision, is going to be transformed in the coming years into something new. But I'm going to stick with what Professor Donarakis closed his presentation last night with very important quotation from Sophocles, the tragic poet, from 496 to 406 BC. In Greek, τι να κάνετε τη γνώση εάν δεν σου χρησιμοποιεί σε τίποτα? In English, what to do with knowledge if it's no use? So, today we're going to present to you our knowledge, how it's going to be put into use. And I'm going to start with a definition of what is personalized medicine and how we define personalized precision medicine. Personalized medicine tailors healthcare to individual patient characteristics to improve treatment outcomes and reduce adverse events. This is what we think is our base of personalized or precision medicine. So what is the core idea of this? Is to customize health guidance, diagnosis, and treatment to each person's unique genetic, clinical, and lifestyle profile. And we have a vision. Imagine health guidance selected just for you, minimizing side effects and maximize outcomes. Imagine receiving precise diagnosis based on your unique situation and having this ability to predict and prevent illnesses before they develop. We believe that our approach is unique and it does transform the healthcare systems. Personalized medicine, it's not just about prescribing the best drugs. Imagine a system where diagnosis is not only more accurate, but tailored specifically to you. Picture predicting the likelihood of developing a condition before it even arises. Having the tools to prevent it from progressing. So our approach is intersectional. And what do we mean intersectional? We interact with 4 important areas that we believe are crucial to the personalized precision medicine. Number 1, the genetic profile. DNA. Number 2, phytotherapy, herbs. Number 3, artificial intelligence. Number 4, your social and behavioral profile. So this is our holistic perspective to considering individual and population level data to understand health and illness symptoms. What is our approach to this initiative? The concept of personalized medicine includes selective genotype-based prescription of drugs to individuals for whom the drug should be safe and effective. Traditional medical treatments have been designed as a one-size-fits-all approach. But while these treatments can be effective for some patients, they may not be for others. Precision medicine takes into account individual differences in genes, environments, and lifestyles. In this way, doctors can select treatments that are most likely to help based on a more complete picture and understanding of their disease or ailment. What is the innovation and what is the business model, the entrepreneurship on this initiative? Personalized medicine uses molecular insights to create targeted treatments, linking natural compounds to gene targets. This approach advances drug discovery and offers innovative therapies for today's health challenges. So what is the foundational concept? By having a complete understanding of the molecular effects of chemical compounds, facilitates strategic selection of candidates for advancement in modern drug discovery. And what is our future direction? By examining those gene targets for herbs ingredients and link herb ingredients to various modern diseases, we believe that hasn't been considered before, and this is our aim. So, our One Health journey unites expertise to make individual and population health more proactive, predictive, precise, and personalized. The most important thing is what Sophocles was saying, the use. This is how we are going to apply it, by empowering individuals and communities as partners in their own wellness, by training the next generation of data-fluent and multidisciplinary health professionals. We call it the new generation 21st century general practitioners. This is how we started. In April 2024, with our first event at the University of Cambridge. The University of Cambridge has 125 Nobel Prize winners. One of those 125 is Francis Crick. And his discovery was the structure of the DNA. It wasn't by accident that we selected the same building that Francis Crick was teaching, the King's College, because we wanted to give a message that what we're attempting to do is something that DNA is the strong base for it. So the next events, November 27th, we're going to be in China, in Banan, 29th in Xi'an. Why Xi'an? Xi'an is known for the terracotta warriors. Xi'an is the second most important city in China after Beijing. And the saying goes that close to 35 years ago, a Greek sculptor worked together with the Chinese in order to produce the terracotta warriors. For us, it's very symbolical. And of course, in March, we are going to be again in the eastern part of China called Ningbo, and then we're coming to Nicosia, and we are going to attempt, for the first time, to bring the Balkan herbal experience into the map. So, 2 days ago, it was the opening of those conferences in China, but also for the rest of the world. As you can see, it's called One Health, One Road. Why did we choose the personalized medicine to call it One Health, One Road? We started with the term One Belt, One Road. Belt refers to the proposed overland routes for road and rail transportation through landlocked Central Asia along the famed historical trade routes of the Western regions. In other words, it starts from China and it ends in Rotterdam. And the road is short for the Maritime Silk Road. We felt that One Belt, One Road was an excellent vehicle for us in order to transform our initiative from east to west. But in 2017, I visited a small place in China, a hospital that was called Changzhou First People's Hospital. And as I entered the hospital, on the left side, it was a wall painting, the one that you see in the middle. And what is there? It's a Greek physician examining a child. On the bottom left, traditional Chinese doctors. On the bottom right, you see the Western doctors. And in the middle, you see the Hippocrates Oath. For me, when I saw this, the whole medicine history went through my mind. That's why I call it One Health, One Road. So, One Health, One Road's novel approach promotes a universal model of healthcare delivery through innovative means of training, experience sharing, and technology transfer, aiming to unite the practices of traditional Chinese medicine, ancient Greek medical practices, and contemporary Western medicine. We know that this journey is long, but we're just starting. Thank you.
Thank you so much. That was an amazing presentation, and I agree with Mr. Takis that precision medicine is the future, and this is the way to go. We have only time for one question only. Do we have a microphone that we can pass?
Thank you very much. As you walk up there, I was very impressed last night by the major presentation that we heard, but I'm not quite happy that I agree with Sophocles, where you said, what's the knowledge if it has no use? I actually believe any knowledge has some use. So he's actually wrong in the second part of the equation. So even if you develop knowledge today, it may be useful sometime somewhere. So every knowledge has a use. But in general, the precision medicine is right, but it's also wrong. If I have a sore throat and I have a fever, I go to see my GP, give me some penicillin, within a week I'm better. He doesn't care about my DNA, about my environment, the drug works, and I feel great. And also, if you look at vaccination, we recently had a vaccine called COVID, that has saved 20 million people, if you look at the analysis. None of us know anything about their DNA, their environment, They could be in Africa, they could be in China. So precision medicine, I think, is much more important for difficult diseases. And I will actually say something when it comes to cancer. And I congratulate you on what you have created. I have some concerns with your close contact with the Chinese because, of course, they have one China themselves. And it may not go down very well with the new American president.
Thank you for your question. Very valuable. Yes, I do agree that knowledge, any knowledge, should be put into use. But I do believe very strongly that we should put knowledge into practical use. So I have been in healthcare business for more than 45 years, and I have seen a lot of research being done, a lot of money being spent by the European Union, and nothing happens. So my purpose is to take some good ideas, good knowledge, and turn it into practical use for the citizen to be assisted and to be making their life better. So when we talk about precision and personalized medicine, yes, there are some cases that maybe doesn't apply. But consider cases where, like third age, how precision medicine can help in order to make the third age citizens a little bit better quality life. So as I said again, as I close my talk, it's the beginning, it's the start. But we believe that we have a good foot on the start. Any other question?
Thank you so much.
Thank you very much. So good morning, everyone. So I would like to introduce our next presenter, so Dr. Dimitri Sikas. Dimitri Sikas is a remote sensing and surveying engineer. He received his degree from the National Technical University of Athens in 2010, where he also received his PhD in hyperspectral remote sensing in 2016. Dimitris joined Claudio as the Chief Technological Officer of the group. Dimitris is also the founder of the GEO University, an online learning platform on GIS and Earth observation. So the title of his lecture today is One Health Herb Registry System, a New Frontier in Herbal Medicine. Dr. Sikas, the floor is yours. We cannot hear you.
Yes, can you hear me?
Yeah, we can hear you now. Thank you.
Second. Can you hear me now?
Yes.
Yeah. Okay. So first of all, thank you very much for the invite. It's an honor to present in this conference. So today I'm going to present you our initiative about the One Health Herb Registry System. So in terms of the way that we are thinking about the herbs, on how they're revolutionizing herb medicine, we introduce a cutting-edge herb registry system to bridge the ancient wisdom together with modern science. At our core of our design is the standardization. So we want to create a uniform platform, a database for herb profiles from botanical details to medical properties, and combine this with individual clinical details. Then, as part of also this initiative is the intelligent data processing module, as we say it, which utilizes advanced large language models in order to parse and extract patient information from different scientific studies and sources. And of course, this will really enhance the research capabilities by taking into account all these different varieties of sources. Yeah. So in terms of, in order to be able to do this, we need the database architecture. So we have already performed structured data storage. So we have organized the database in a way that it is system, we have introduced different kind of concepts and properties within this system, and connected all the different types of connections between them. A very big importance was given to the dynamic synonyms. So, because as probably most of you already know, herbs do have different namings and very often get confused with each other. So a very elaborate and detailed cross-reference work has been done in order to ensure that the naming and the connection between the names is done properly. Within this platform, I would say we already included different types of information like active substances, including the chemical types and compounds within each herb in order to facilitate the research that is going to be needed. Also, we have included different geographical insights in order to be able to cross-correlate the herb properties together with some environmental impacts and the potential impact also of climate change. And of course, we are building some community engagement functionality in order to be able for the users of this platform to be able to interact with each other and exchange information. So in order to be able to facilitate this process, we have really focused on the standardization, so to have a uniform botanical nomenclature. So when each scientist refers to one specific name to ensure that everybody understands exactly the same thing. We have also introduced different kind of quality control mechanisms in order to maintain the quality of the input data within the system. And we have also defined a herbal lexicon in order to facilitate this process. On top of that, we have been, this standardization process supports the healthcare decisions. So to assist, the whole scope is to assist the healthcare professionals in making informed decisions when providing standardized and comprehensive herbal profiles in order to ensure the data integration. So the whole point of this data is to be able to be integrated with other systems and AI algorithms in order to be able to extract information that really wasn't known before. And as part of this process is to also facilitate the educational outreach. So having this type of platform, we can also provide, we can also facilitate the educational, let's say, aspects of physicians. Now, let's say the herbal medical products are something that is not so much, let's say, integrated into the medical system in the EU. We have been working closely to follow the directives that are in place in order to ensure compliance and be able to help and facilitate the researchers in the process of the monographs that will help the future medication. Now, from one part of the AI part of the system is the intelligent data extraction module. So this focuses on a process that reads different kind of scientific materials and understands it. And based on the structure of the platform, it really maps the specific interests that are exposed within its scientific paper and maps them within the structure of the database in order to be able to automatically or semi-automatically extract the knowledge from its purpose. This is really important because thousands of papers are published every year this vertical, let's say. So a process that really not just catalogs but extract all the structured, meaningful information from this is quite essential. So, so first of all, this is a scalable process. So, by design, we can apply it to hundreds or even thousands of different documents simultaneously. It can dynamically enrich all these documents with specific nomenclature and the specific things that we want to have. And import all these aspects with inside the platform. Now, as we see the Herb registry, we see it as a tool for physicians, so to empower GPs actually to introduce the GPs to the Herb registry system for an extensive reference in herbal medicine, helping the decision support. Of course, always the physician is the expert and they know how to decide, but as a tool to help them and facilitate this process by providing them accurate references and suggestions on potential treatments. It's something that it's of use. It is very easy to access, and we have been working also with clinical integration, and we continuously update the process. Now, another part that it's really important, as Mr. Taki said before, is the personalized medicine with the Herb registry. We can have individual profiles, target therapies, and predictive analytics, so we can really track the outcome of the treatment that is needed. And this is something that really empowers also the patient in order to be able to better understand the treatment and what's happening. And something more on this, we have been working also in the Greek, let's say, use case. So how to adapt, let's say, the traditional Chinese medicine to the Western medical system. So we have started with a data collection process, an initiative that we will examine 5,000 people from ages from 5 to 18 as a first step. We're going to sample DNA with saliva samples and gather all the medical history and both individual and the family history, and also measure cardiovascular measurements in the field for each person that will be examined. And the scope of this is to detect the murmur in the early stages and combine them with the DNA and clinical measurements. And having all these, let's say, profiles together with the genomes and all the active chemical substances from the herbs, we can help research in order to provide some more elaborate treatments in the future, of course. Thank you very much.
Thank you very much, Dr. Sikas, for the excellent presentation. I think we have time for only one question.
Yes.
I have actually one question. Thank you so much, Mr. Sikas. I'm very interested in this topic as an integrative oncologist myself, and there is already some herbal or in the market databases, for example, about herbs from Memorial Sloan Cancer Center, which we have been using for a couple of years. So I'm wondering, what is the difference between your platform and how would that change with the already existing ones?
Yes, so if I actually did well because it had a small gap in the connection.
Thank you so much. I want to welcome on the podium our next speaker, Mr. Lars Manter. Mr. Lars, he's a dedicated champion for health literacy in Europe. He holds an MA in rhetoric and natural science from Copenhagen University. As part of his professional work in Scandinavia and Europe, his skills of combining communication and science has led to knowledge sharing and joint platforms to promote self-care, empowerment, and citizen action, including corporate social responsibility, and has been seen core of daily activities across sectors and borders for 20 years in Danish, Nordic, and European initiatives and projects. He will talk to us about personalized medicine, the future of health and dignity. Thank you so much.
Well, thank you for having me. It's a pleasure to be here in Cyprus. I am, in this particular context, not just a traveler in geography, but also a time traveler, as you'll see in a few minutes, or within 11 and 4 seconds or so. But personalized medicine, the presentation yesterday sort of stole one of the core elements of my presentation here, but to sort of just to add to that reflection about the differences that we have. How many of you in this room identify as a man? By raising of your hands. How many identify as a woman? Any that are brave enough to identify as something else? Okay, so basically though, the pointer works slowly, but it works. Who are you? You have different identities. In addition though, who really likes a good romance when you go to the movies? Showing of hands, who likes a good romance? Okay, some. Some that would maybe prefer a sci-fi movie? None? That's amazing, considering the room. But maybe more an action movie? No? Some? Yeah? So, okay, cool. You have different tastes, too. What about if you think about if you were to go out to go shopping for clothes, if they only had the size large, would you be satisfied? Or would that be a problem? Showing of your hands. Do you? Aha. So you have different needs. And if all you actually had as an opportunity for your future was to become a plumber, would that be a good sort of career choice for you? Raise your hands. None. Not that surprising given the room. But so, you have different priorities in terms of your future. Essentially, of course, on a microbiological level too, you are unique, but not just sort of DNA-wise, also mentally, physiologically as well. So given that uniqueness in terms of your identity, in terms of your taste, your needs, your priorities, why then do we accept generalized medicine? It doesn't really make sense. So what we've done then also based on that idea, working in the Nordics, is to work with a concept where we also time travel a little bit. The current generalized medicine is not necessarily per se fit for purpose, considering the needs that we have, the priorities that we have in the future, and of course the burden that the current system actually places on our planet and on our system. But what would a future look like? So imagine traveling into the future, 20, 30 years. How would you like the health system to look like? What were the kind of solutions that you would prefer to see? And if you imagine those kinds of elements that fit your taste, that fit your priorities, that fit your needs, how can you then start building systems that would support that future? Because the reality that we're in today is the sort of the sum of the choices that we made 10 years ago, 20 years ago, 30 years ago. The future that we'll have in 30 years are the results of the choices that we make today, tomorrow. and maybe the day after. So be very conscious of the future that we're looking for when we make choices. In the Nordics, then, that leads us to the 5-5 aspiration. No longer should we need use 10% of our GDP for curative services. It doesn't actually lead too much in terms of well-being. It doesn't actually lead to a good use of resources. And it doesn't necessarily lead to an overall well-being for our patients. Instead, we should aspire to use only 5% on curative services and 5% on preventative services instead. It's a profound shift that is, of course, an aspiration in this sense because none of the countries on the earth are using this. But of course, this is the way forward because the point is not for us to be better at fixing problems. The point must be to prevent problems from occurring in the first place. That work then led us to what we call the sustainable health model. It's a balance of a system and a citizen, an empowered citizen that is on par with the system. This is not about a system doing something for people. It's not about a system doing something to people. It's doing something with people. And it's about people, empowered, health literate people, doing something that also enables a data flow between the two opposite poles, if you will, that allows a data model in the middle that sort of supports the research that we also need for it all to happen. It is not an either-or where the data lies. It's a common good for us all. So does that lead to perfection, dignity in every sense? Maybe not. But the aspiration is that we can try. Try, in every sense of the word, to also have a personalized approach, a precision approach, where we try to work with dignity. We also need to work with trust. And as opposed to the slide just before, this is a little bit more data heavy. But we often talk about trust as something that we really want and need in health, in our systems, in our societal systems. And we talk often about how it's really so sad that trust gets destroyed by bad decisions or by bad frameworks. But let's remember that trust is not just something that you can destroy, it's also something that you can build. It requires that you actually, though, think about both the phases of when you collaborate with other people, how you do it. In this particular context, this is, well, it's not stolen because I actually built it myself, but it's taken from a case of the Danish life science cluster, where we think about how do we collaborate, how do we put people together in the assembly phase, how do we then build a partnership, the build-up phase, how do we do the trust-building phase, the short-term and long-term results, and how can we measure on each of these phases so that it actually makes sense and that we're held to account that we're actually doing what we're promising to do, so that we build trust. And if you find this sort of tricky to understand, think about maybe Formula One racing. Some of the engineers are focusing only on engine capacity. They don't care about the driver, they don't care about the wheels, they don't care about the chassis per se. They care about the engine capacity. Because they know that unless they actually figure out how to do the engine capacity, it won't matter what kind of wheels you've got, what kind of chassis you've got, and whether you hired the right driver. But you have to figure out how to build engine capacity to be able to deliver power to transition. That is what we're doing with this model. How do we work with relational capacity that allow us to have the power to change stuff? And for each of these steps, how can we measure whether we are on the right track? This is a more simplified version of the same, but allows you to, within 5 different domains, to assess your progress in a partnership so that you can actually assess whether you have the trust that would lead to transformation. Unless you have the trust that can lead to transformation, it won't happen. Trust, or change, as they say, only move at the speed of trust. In that, then, we should also be humble. One of the key elements to that is to be humble and to have knowledge sharing across professions. This is about involving designers. This is about involving psychologists. It's about involving urban planners. It's about involving professions other than our own. It's about integrating other approaches. Some of them that might be psychological of nature, some of them that might involve civil society, some of them that are beyond, in this case, the medical field, but involves different elements. Geographies, how do they do it elsewhere? Genomes, how do we do it across the different needs of the people? And of course, the cultural approaches. This is cutting-edge technology of 1920. People were really fascinated about it in 1920s. It had the carrying capacity of 1. It could fly, sort of. It wasn't very safe and it didn't fly very far, but it could fly. Cutting-edge technology of 2020 looks like this. A bit more confusing, but it can fly much further, much farther, much safer, and for many more people. It requires a skilled pilot, and it requires a hell of a lot of data to fire that data dashboard. The current system that we're in still relies on us to actually build that data dashboard so that we can fly the technology of tomorrow. It involves a lot of data. It also involves a future care where we are willing, and that's the dignity part as well, willing to listen to the people. What are their tastes? What are their priorities? What are their needs? What is it that we can, as a medical community, motivate and engage them so that they actually take our advice, so that they sometimes take the medicine, so that they, over time, actually work on their own health. We will often only get a very small window of opportunity, the talk, the motivation, the information, to motivate them to do all the real work. We have maybe an hour every year to talk to them. They are left alone on their own devices the rest of the time. So unless we listen, and listen carefully, and give them the right time of motivation, it doesn't actually matter much. It's a future care that integrates technology, integrates the perspectives, integrates other types of profession, and it's one that adapts very much to those different needs, and adapts, of course, to emerging technologies of how smart homes might be, how we deliver health not at a hospital, but at home, or on the go, for that matter, because you are unique. Thank you very much.
Thank you, Mr. Hunter. Technology is becoming a big part of our lives, and we have to get on board with that, whether we like it or not. So we have time for only one question. I see only one hand, so please go ahead.
Thank you. I'm a physician. We all believe that prevention is better than cure. Whatever taste I have and what driving test I do, so prevention is better than cure. And that basically, these boxes that you're saying, whether it's precision or whatever it is. But we cannot always achieve prevention. Even if we spend a lot of money to prevent other medicine, unfortunately some illnesses appear out of the blue, undetected and dramatic, and they need real treatment. Your comment of dignity in your title, I actually find slightly insulting. Trust and dignity. I would have thought physicians over the last few thousand years have been treating their patients with dignity and trust. In other words, it's nothing new to have dignity and trust.
The current development of drugs are one that has predominantly used white men as the guinea pigs to test the drugs. A lot of women, a lot of non-Westerners take offense to that. It is our dignity, but it's not their dignity. So while, for instance, there's a lot of qualities to a generalized approach that have been hugely effective as opposed to the previous method of, middle age, the Middle Ages, the Dark Ages, trial and error and approach, and the modern medicine has done that far better. But it's not been based on individual approach, it's been on a generalized approach. And it doesn't necessarily take very much into account what the individual needs. The sad thing about it, though, is that the way that we use GPs in our modern system is not a very good way for the GPs either. Their key role as a GP and as a beacon of knowledge is not to have 5-10-minute consultations with their patients. It should be as a motivator. It should be as a beacon in their community and not someone that has to hide behind a desk because that's all there's time for. I would hope that the future GPs is one that actually is working in the community. It's a communicator. It's a visionary that actually drives that health, and not just someone that is more or less, and don't get me wrong, used as a machine, a cog in a huge machinery where we are just throwing more and more patients at that individual. That role is one that can be solved more or less by an AI. The role of a motivator, the role of a dedicated individual that can make a change that would allow a community to move from one sort of lifestyle to another, that requires a human being with dedication. And that is one where I see the future GP to do that instead with dignity in the community. I hope that answers your question.
Thank you.
Thank you very much. So I would like to welcome our next presenter, Dr. Fan Chempong. He graduated from Hunan University of TCM, China, with a master's degree in acupuncture. He served as a consultant doctor and a manager of Chongqing TCM Hospital, also a professor of Chongqing University of TCM, China. Currently, he is the deputy director of the medical department of Chongqing TCM Hospital. He is the vice chairman of the Acupuncture Equipment Committee of Chongqing Acupuncture and Maxi Bastion Society, standing committee member of Chongqing Maxi Bastion Society. So the title of his lecture today is Personalized Treatment in Traditional Chinese Medicine. So Dr. Chempong, the floor is yours. Can you hear us?
Can you hear us? Hello? Can you hear?
Yeah.
Yeah. So let's share my screen. Is it okay?
Yeah, we can hear you clearly.
Today's conference. I'm Fan from Chongqing Traditional Chinese Medicine Hospital. Today, the topic I'm bringing today is personalized medicine in TCM. I'm going to share my views from the following two parts. As Professor Takis said, he has explained what is personalized medicine. Personalized medicine refers to new treatment modalities based
Sorry
on
to interrupt you.
Sorry to interrupt you.
Can you share your screen with us?
Can you share your screen with us? Okay.
On the lower button of your screen, there's a share button that you can share your presentation. We're still, yeah, now this is great, thank you. Yes. Can you maximize your screen too?
On different individual predisposition or lifestyle variability. The rise of personalized medicine means that the one-size-fits-all, as Professor Taki said, is being replaced by providing the right medication to the right patient at the right time. As is well known, personalized medicine has been increasingly valued in recent years. It can not only achieve more precise treatment, but also save medical resources, reduce unnecessary side effects, improve efficacy, and increase potency ratio. From the management of blood pressure for hypertension, controlling blood sugar for diabetes, to attend to targeted drugs for the treatment of tumors, personalized medicine has unconsciously existed around us. In fact, personalized medicine in TCM has been practiced and passed down for 1,000 years. You know, the holistic concept and the syndrome differentiation treatment are the two most important characteristics in traditional Chinese medicine. TCM holds that the human body is an organic whole. It also emphasizes that the harmony between human and the society environment, human and the nature. So we think every patient is unique, such as Professor Lars Munter just said. Personal constitution may be impacted by many factors like gender, age, emotion, climate, work intensity, and lifestyle. Syndrome differentiation and treatment in TCM refers to comprehensive analysis of information collected by the 4 diagnostic methods to determine which syndrome type the patient belongs to, and then take different treatment based on this syndrome type. For this reason,
Dr. Fan,
treatment should be based.
Sorry,
Yes.
do you mind following your slides and sharing them with us along your talk?
Yes. Okay. Thank you for reminding me. So, under the guidance of this principle, we can treat the same disease with different approaches, like insomnia, or treating different disease with the same approach. We just use one TCM pills to treat like uterine prolapse and rectal prolapse and so on. So let's move to the second part. Now I'll take the TCM treatment for insomnia as an example to elaborate how traditional Chinese medicine provides personalized treatment. There are many causes that lead to insomnia from the perspective of modern medicine. As it's shown from the table, we can see the life events and social factors like displacement due to traumatic events, traffic noise, owing money, and so on are the common causes. On the other hand, medical and psychiatric disorders like anxiety, depression, post-traumatic stress disorder, and so on also the causes. And most methods for treating insomnia involve the use of sedatives like hypnotic, such as benzodiazepine, which is common use for insomnia. However, it can cause respiratory depression, and long-term use can result in tolerance. Triazolam can cause anterograde amnesia. Actually, hypnotic medications improve sleep only modestly. On the other hand, from the perspective of TCM, we think that causes of insomnia, including imbalance of yin and yang, lack of qi and blood, disharmony in the stomach, invasion of external pathogens, sometimes drinking too much coffee or tea, also the reason. We will conduct a comprehensive analysis based on the patient's medical history, like tongue image and health conditions. Usually, it can be classified into 5 types of syndromes. First, we have syndrome of phlegm, fire, disturbing heart. The causes including long-term consumption of spicy food, greasy food, or fried food.
Dr. Fan, I'm so sorry to interrupt you again, but we're not seeing your we're not swapping your slides, so we can't really follow with the talk. So if you move your slides along with your talk, will be much helpful.
Wake up, toss and turn all night. Erratic.
Dr. Fan,
sometimes
you need to stop sharing your screen for us.
Okay, stop.
Stop. Perfect, thank you. Can you start to reshare your screen? Yes. Can you move it up and down to see if it works this time?
Okay, what you need to do is to share the whole screen, please. Try to move the slides. Yeah, we cannot see that, so I think you need to share the whole screen.
Is that okay?
You need to share the slide view screen. Okay, you can proceed like that.
I'm shifting my slide. Can you see the movement?
No, we can't.
So I can't do this in the whole screen. So I conduct my speech.
Leave it like that, and we can continue like that.
Okay. Yes. Sorry. Okay. So let's look at the symptoms of syndrome of phlegm, fire, disturbing heart. It's including excited, difficult to sleep, easy to wake up, toss and turn all night, erratic, dry and bitter mouth, cough, chest tightness. A patient may have red tongue with yellow greasy coating, smooth or slippery pulse, maybe a little bit rapid. So for this syndrome, we use Huanglian Wendan decoction. It composed of coptis chinesis, dried tangerine peel, Korea cockles, and so on. And the stimulation of certain action points is also recommended. Lifestyle education, including changing dietary structure. So next, we have syndrome of liver depression transformed into fire. We think the liver is responsible for regulating emotional activity and regulating qi flow. If the liver's function of regulating is imbalanced, qi flow becomes stagnant, and prolonged stagnation may turn into fire. And then excessive fire will damage the yin energy, just like range fire that vaporizes water. The balance between yin and yang will be disrupted. The yang cannot enter in at night, so they can't fall asleep. Symptoms including difficult sleep, frequent dreaming, and easy awaking, even stay up all night, accompanied with dizziness, head bloating, headache, red eye, and bitter mouth, chest distension, restlessness. They may have red tongue with yellow coating, taut pulse. So for this syndrome, we use Danzhi Xiaoyao pill. It composed of peony bark, white peony roots, and so on. And we can stimulate action points like He, Tai Chong. And patients should adjusting one's mood. Let's move to the syndrome of deficiency of both heart and spleen. Traditional Chinese medicine believes that the spleen is responsible for absorbing the essence of food and forming qi and blood, while the heart is responsible for providing the power to run qi and blood. Normally, the heart needs to be nourished by qi and blood, and we believe the heart is the lord of the mind. Insufficient endowment, overwork, overthinking, diary deficiency, chronic blood loss. Those situations probably lead to spleen deficiency and obstruct the function of converting ingested food into qi and blood. So the heart loses the nourishment, then mind will lose control. The symptoms including difficult sleep, frequent dreaming, palpitation, shortness of breath, pale complexion, fatigue, abdominal distension, loose stools, and so on. Patient may have pale red tongue, deep thready pulse. So we use Guipi pills to treat this. Acupoint stimulation is also recommended, such as 足三里, 内观, lifestyle education including having nutritional diet. So next we have syndrome of qi deficiency of heart and gallbladder. Causes including insufficient endowment or being startled by horrible visuals or sounds. So symptoms like palpitation, frequent dreaming, easily awaken from dreams, toss and turn sleepless all night, like to be alone, fatigue, hesitation when making decisions. They may have pale red tongue with thin white coating, threading and taut pulse. So we just use 酸枣仁 decoction to treat this pattern. It composed of white jujube, Preococcus, licorice, and so on. Acupoints like 百会, 神门, 内观 is recommended. And we will suggest patient to listen comfortable music, be with family members or friends. Last, we have syndrome of heart-kidney imbalance. In TCM theory, we believe that the heart is located in the superior position, belongs to fire of the 5 elements, while kidney is located in inferior position, belongs to water. These two viscerals are mutually opposite and constraining. If this balance is disrupted by any factor, it will lead to excessive heat in the heart, and the mind will out of control as well. So the symptoms including difficult to sleep, frequent dreaming.
Dr. Champagne, you need to conclude because we are running out of time, please.
Okay, I'll be quick. So for this syndrome, we use 胶肽 pills. So that's this is just some example about treating insomnia. Actually, we have personalized diagnosis and treatment plans for every disease. There are even dozens of treatment approaches for certain disease. Okay, that's all today's presentation. Thank you very much for your attention.
So thank you very much for the interesting presentation. Unfortunately, we have no time for questions, but thank you so much. Thank you.
Thank you. Thank you.
Our following session is the new frontiers, genetics, epigenetics, and molecular medicine. We now call upon the chairs, Dr. Apostolos Zaravanis and Dr. Evi Farazi, to lead this session.
Okay, let's continue to the next session. It's a pleasure to introduce Dr. Yorgos Abidianakis. He is an expert in modeling micrometabolite host interactions leading to dysplasia and tumorigenesis using genetics and intestinal histopathology and physiology assays. Our team, their team studies bacteria and carcinogenesis in Drosophila, mice and humans, and exploits the potential of in vitro systems for preclinical trials. He has been trained for 10 years at Harvard Medical School in biomedical research, 6 years as a postdoctoral fellow, and 4 years as a Harvard instructor in medicine in the field of human infectious diseases and carcinogenesis, practicing research at the Massachusetts General Hospital and the Shriners Hospitals for Children in Boston, in the United States. He will talk to us about young enterocyte progenitor clustering and Notch locus epigenetic instability as biomarkers of Drosophila aging. Thank you very much.
Thank you for introducing me, and many thanks to Ioannis Patrikios, Dr. Ioannis Patrikios, inviting me for one more year in this very nice conference. I will talk about stem cells and how they are leading their way towards tumorigenesis. Our team forms the Drosophila Biomedical Research Unit. We're doing a lot of research using Drosophila. We also run the Cyprus Intestinal Health Study, which aims towards colon cancer prevention. We try to get clues from basic research. Basic research is indispensable. It's the basis of all knowledge. And then we move on to applied stuff. The question I'm going to ask and try to answer today is when and why stem cells malfunction upon aging. We know that stem cells malfunction upon aging. Sometimes they stop to divide, but other times they overproliferate and they give rise to cancers. So when and why stem cells malfunction is something we don't know, even at a very basal level. So the common assumption is that there is cellular signaling that goes wrong, or the homeostasis of tissue goes wrong, and that's how things go bad for the cells, the tissues, and organs. When you compare young and old stem cells, you see a lot of differences depending on the tissue, but we don't know when this starts and why this starts. Here I'm going to show you some data regarding a different idea that stem cells are already flowed to begin with. We notice some signaling instability, not signaling instability, in young stem cells, ones that are supposed to be very healthy. And this leads to stem cells of mixed identity, and these in turn aggregate and they form dysplasias, and dysplasias are predisposing for bona fide tumor formation, for example, from mutation of tumor suppressor genes. So we propose, I'll have the proposition in the beginning, that stem cells are inherently flowed and that their aggregates can be a biomarker of intestinal health and overall aging, I would dare say. So we use Drosophila, and this is to show you that they are analogous structures. There is the pancreas, insulin-producing cells in the brain, actually. There is muscle, there is the dorsal vessel. There is, does this function as a laser pointer? No. So, yeah. Pretty much all the basic organs of humans, kidney, liver, lungs, and the digestive system, of course. You see here the analogies between the Drosophila and the mammalian gastrointestinal tract, and the stem cells, ISCs. If you learn one acronym, that would be it, ISCs, intestinal stem cells. You see that intestinal stem cells are the basis of producing the enterocytes and the enteroendocrine cells, and these types of cells exist also in humans. Drosophila is an insect. The insect belongs to arthropods. Arthropods are the simplest organisms that have intestinal stem cells. So studying them in Drosophila, we combine simplicity with functional analogy with that of humans. Humans would be in the chordates at the very bottom of this tree. A stem cell, intestinal stem cell, gives two progeny. Whenever it divides, it gives two cells. One cell divides, gives two cells. Most of the time, it produces itself plus an enteroblast, EB. Other times, it produces two stem cells, two EBs, or one stem cell and one pre-E, that is the pre-enteroendocrine cell. And this is what everybody states in many different organisms. Pretty much stem cells divide either symmetrically and they give two similar cells, two stem cells, for example, or two different cells. Most of the times, the stem cell reproduces itself. If it doesn't, then it's lost. And this is the canonical progeny, but what we find is that a stem cell can give rise to cells of mixed identity, which tend to cluster. And although this has been noticed in all the flies and all the organisms in general, this is something that we notice in very young ones. And we measured that with 3 different markers. Delta here is a stem cell marker, delta GFP, delta LAC-Z, and IC GFP, that is intestinal stem cell GFP. You can see the tall bars are the ones of the old flies. There is roughly an analogy between the days of flies and the days of humans, roughly. So in old flies, in relatively old flies, we see a lot of those, but you may appreciate that even in the first bars, that's in 4 days, that's pretty young flies, very young flies. They have a significant number of these clusters, that is abnormal stem cells clustering. And we then asked what exactly is wrong with these cells that they cluster. Clustering is already one problem, but we also noticed that they have more copies of DNA, sometimes up to, you can appreciate in the graph here on your left, that the ploidy goes up, the copies of DNA in the nucleus, extremely high, which is not typical of any stem cell. Plus, they have some increased admixture with markers of more differentiated cells, the enteroblasts, to a great percentage of them. That's the small graph at the bottom. So more DNA copies, other cells identity, and clustering are the basic characteristics of this abnormal progeny of the stem cells. Where does this lead to? Overall, to more mitosis. Sometimes senescence drives stem cells to die or be hyporesponsive, but in the gut, the opposite is happening. We have overactive stem cells. So mitosis goes up. You can see the tall bars over there is the increase as in older flies, in older stem cells. The mitosis goes up. More stem cells, we have more stem cells, second graph. And the third graph, more importantly, is that also the mitosis per stem cell goes up. So every stem cell is more active. Not only we have more stem cells, but every one of them is more active too. And another interesting feature is that why are these stem cells more active? At least one reason is that when they cluster, they help each other, probably because they produce cytokines and growth factors, which spread to each other and they help each other undergo mitosis. So you can see that the more the bigger the clusters of stem cells, the more mitosis each and every one of them has. So clusters of a lot of cells have a lot of mitosis, not because the cells are a lot, but also each one of them is more active. Another interesting feature is that we can stop that through chemotherapy drugs. I'm not insisting that we should be taking chemotherapy drugs in a very young age, but doing so, it reduces the clusters. We gave rapamycin, for example, and fluoxuridine. Fluoxuridine is just for 5 days in the beginning of the fly's life, and these tend to reduce the mitosis and the clustering in the colored bars over there. Reduce the clustering, and interestingly, the effect is stronger if you provide the treatment in young flies as opposed to older ones. Now, what is the basis of that? I described some features, some impact. What is the base of that? We think that the tumor suppressor gene, NOTS, is a very conserved gene. In this case, it acts as a tumor suppressor, so when it's mutated or when it's lowly expressed, stem cells over multiply, for example. and they lead to tumors. And one feature is that the posterior midgut, especially that of females, is overactive and produces many of these abnormal stem cells, and it's in this part of the female gut that NOTS is lowly expressed. So NOTS has to do with that. We try to explore more. We devised a tool, it's blurred over there, doesn't matter. So we made a detection system that GFP goes up if the overall locus, NOTS locus region goes down. So whenever there is genetic instability that blocks that region, the GFP goes up. And we see a high correlation between the stem cells, the number of stem cells we see in the gut, and the GFP marker that lights up, and also different levels of NOTS itself. It's not stable, but some cells express more of it and some less. So there is an instability also in very young flies. And this, oh, again, this is blurred. We notice a lot of differences in tumor formation. Now I'm not talking about aggregates, but bona fide tumor formation, which is caused by mutations in tumor suppressor genes and make massive tumors in the fly gut. Very similar to what might be happening in mammals. And we see that different genotypes, these bars over there represent different genotypes, have different percentages of such tumors, and the different regions in the gut, that's the pie chart, have different frequencies of that, in quite fair analogy with what is happening with the human gut. And in the bottom graphs, although they are blurred, pretty much there is a tight correlation between the clusters a young one exhibits and the tumors that they develop in old age. So yes, these clusters can somehow predict the old age bona fide tumorigenesis. And this is just one slide to say why this might be happening. It has to do with DNA replication stress. So the more mitosis, the more DNA replication stress you have. And we have the red marker for this over there. So when we create these tumors, either intentionally through genetics, that's the upper graphs, or spontaneously, underneath is a spontaneous tumor that happens spontaneously during upon aging. DNA stress is increased in these cells. And importantly, if we have aggregates of stem cells next to the tumor border, these are more stressed too in terms of DNA replication stress. And the farther away they are from the tumor border, the less stressed they are. So definitely we have a lot of DNA replication stress inside the tumor, but also in clusters of outside the tumor that generally predict tumor formation. And they are not mutated yet, but eventually they become. And that's the final slide pretty much. The model is like this: a young stem cell, or a stem cell in general, has some signaling instability in tumor suppressor genes, in this case NOTS, and along with mitogenic factors, and these can be many, can be sex, can be drugs, can be diet, we tried many different things that affects mitogenic process, and it affects this process in general. This leads to increased DNA replication stress, more mitosis, more replication stress if you force the system to divide too much. And then we have these abnormal cells that are hyperactive. They group together and they're hyperactive, they are stressed, and they produce more of these cytokines that accelerate their pace. What we don't know is the last part, is that how this leads to DNA mutation, how this increases the frequency of DNA mutation, because we know it happens, but we don't know the mechanism by which this specific thing is happening. And we are very eager to answer that, because that's a universal question, I think. And with that, I would like to stop and thank the people, especially the three people in the top, Konstantina, who is doing her second postdoc now at UCY, Sava Stelloni, who is in the audience and is now in the SINS, Cyprus Institute of Neurology and Genetics, Maria Koumouri, who works now in CCRI, Cyprus Cancer Research Institute. And thank you all for your attendance.
Thank you very much for this very interesting presentation. Are there any questions from the audience? Yes, there's a question over there.
Very, very impressive presentation. I'm fascinated. I love Drosophila, the fruit fly.
Thank you.
I'm mainly interested in the antenna of the Drosophila because it's very interesting protein antennapedia, which I will talk a little bit later on. But you are saying the intestinal stem cells of Drosophila have some unstable flows to start with. And that eventually, presumably, that's the mechanism that Notch switches on at some point. As you know, Notch is an important mutation in human cancer.
Yes.
The question is really, does the human intestine is equally flowed as the Drosophila? And could that be another mechanism for that?
That's the assumption that we have, but we have no proof of that because we study flies in order to find new concepts, basic concepts, that some of them might be preserved in humans, considering the overall analogy of organs and cells and signaling pathways.
Because
so
people use Notch inhibitors, as you know, for cancer treatment, and some of the Notch inhibitor side effects is significant small bowel toxicity. So obviously the anti-Notch drugs can be toxic to normal bowel in humans. I don't know if that gives you any hint. You haven't worked with John Astor at Harvard?
No, I haven't worked with mammalian stem cells, although we do preventive medicine in humans now in Cyprus. So yes, the equivalent systems might work in humans, but first we need to establish that through basic research, move on to human cell lines, and then try to apply it to humans. So the answer is it would be very interesting to explore that area.
Very exciting work.
Thank you very much.
Thank you very much.
Okay, so the next talk is from Professor Dr. Evangelos Manalopoulos, the Chairman of the Board of Directors of EOF. He is a Professor of Pharmacology, Pharmacogenomics, and Precision Medicine, and the Director at the Department of Pharmacology of the Demokritos University of Thrace Medical School in Alexandroupolis, Greece, and at the Clinical Pharmacology Unit of the Academic General Hospital of Alexandroupolis. He obtained a PhD from the Medical School of Patras University, and he did postdoc at the University of Wisconsin. His current interests include research and clinical applications of pharmacogenomics and epigenetics in drugs used for cardiovascular diseases, diabetes, anticoagulant therapy, and psychiatric diseases. Dr. Manalopoulos, the floor is yours.
Okay, good morning. Good morning, everybody. First of all, I would like to thank Professor Patrikios for inviting me and to congratulate him also for organizing one more excellent European University of Cyprus Congress. It's always fun and pleasure and scientifically interesting to be part of this endeavor in this meeting. Now, today I will talk to you as a professor in university, not as the president of the National Drug Organization, and I will present you our work on anticoagulant therapy, which spans several years, so just some snippets of it. And you can see here in the hospital in Alexandroupolis. And, well, this is an old story, starting from Hippocrates already 400 before Christ, year before Christ. He coined the term thrombus, and already by that time there was suspicion that by thinning the blood, and later on other philosophers and scientists were about the same at the older times, was suggesting that thinning the blood may improve certain conditions or prevent certain conditions like thrombus formation and what we know now as thrombotic event. Well, I'm go through that. I will not analyze that. This is from how he perceived the body and the fluids of the body and how correct many of the things he perceived were, well, keeping the analogy. Now, coming to the modern era of anticoagulant drugs, starting from the 50s already, when warfarin and the other vitamin K antagonists were at first discovered and used and saved millions of lives worldwide. Now, the field, and there were some problems with them. They're difficult to stabilize. They have a large heterogeneity in their effect. They interact with other drugs, with food. So they were very effective drugs, difficult to use. So there was a need for newer drugs already at the end of the 21st century, the first decade of the 21st century. They started emerging, first dabigatran, and quickly after rivaroxaban, apixaban, and doxaban. This is kind of the situation. We have 4 new direct oral anticoagulants. This is the situation. As we said, warfarin is a vitamin K antagonist. The other drugs are directly inhibiting either factor 10 or thrombin, as you see in the slide. And as I said, there is heterogeneity in the effect of vitamin K antagonists. A lot of research has taken place there. One of the major areas where pharmacogenetics has been developed was on uncovering genetic factors contributing to this heterogeneity. And it's been established now that cytochrome CYP2C9 and vitamin K, an enzyme involved in vitamin K metabolism, are heterogeneous, and they have phenotypic diversity, and they contribute to phenotypic diversity. Several other factors have been developed. Only the genetic factors contribute about 50% to this variability. So we have made strides there in characterizing the pharmacogenetic variability. We have been fortunate to participate in a European consortium that released the first randomized clinical trials on this issue back 10 years back in New England Journal of Medicine, where sort of contributed to establishing indeed that these polymorphisms are involved. But, well, and then the field developed further. There were more things coming out that you need ethnic-specific algorithms, for example, and we have several years ago published a Greek algorithm as it emerged that you need a specific, ethnic-specific algorithm to better modify the drug therapy. So we published that, but, well, sort of all this became irrelevant, or more or less, because the new drugs have taken over the practice of medicine. Whether that's fair or not, it's another discussion, but somehow very few specialists now are using vitamin K antagonists. Mostly it has been moved to direct the DOACs. So we and many others shifted our attention in looking at the DOACs and finding the heterogeneity there, and there's some studies on the different on the pharmacogenetics of DOACs. I will not go into them, but then omics are coming into play more and more. The personalized medicine that you've been hearing a lot about today involves looking at all different levels, not only at genomics, at genetic level, but also transcriptomics, epigenomics, proteomics, and other levels, even more specific, like metabolomics or phosphoproteomics. And then the field is emerging from going from a single biomarker, like the cytochrome I was telling you, to a signature set of biomarkers that are predicting the right response and adverse drug reactions, and then even networks that are involved in these processes. So we've been interested in that, this multi-omics approach, and we created a project, several projects to look at the epigenetic contribution to the diversity of responses to anticoagulants and to atrial fibrillation. Just here to remind to students here that when we talk about epigenetic, mostly it's about DNA methylation, histone modifications, and microRNAs, which are, well, practically they're not modifications of DNA, but they also contribute indirectly to DNA expression regulation. And in principle, when a gene is methylated or hypermethylated, it's turned off. So it's another way to control. And microRNAs also have regulatory functions on the expression of genes. So looking what has happened, in the field of coagulation and DOAC treatment at the epigenetic level, very few things have happened. However, there are some indications, for example, that atrial fibrillation there is epigenetic factors contribute to atrial fibrillation. Not much, or if anything, has been done on the different DOACs and how they affect, they are controlled by at the epigenetic level. So we established a clinical protocol entitled Circulating MicroRNAs and DNA Methylation as Regulators of DOAC in DOAC response in atrial fibrillation. And actually, our goal and the goal of all the projects we have in this field are twofold. One is to identify biomarkers of the DOAC response in total, but also biomarkers of heterogeneity between the three different drugs used, because we still think there might be differences, although they're treated by clinicians now as one uniform group of drugs, and then they look at different clinical factors, how to choose which of the three different ones to use. We think that maybe there is some under background, some genetic or epigenetic background that could help specify the dose and target the dose better. So this is the idea behind our project. So actually the design of the study has been published already, and two departments are contributing the samples from Athens, Professor Trika's group, and in Alexandroupolis, the cardiology clinic from Professor Giakas. And that's where we are so far. The idea is we have newly diagnosed patients with atrial fibrillation, so we sample them before starting therapy, a week after starting therapy, and 4 weeks after starting therapy for all three different drugs, and we have also a control group. And we have looked at methylation, but I will not talk about the methylation results today. I will more concentrate on the microRNA results and some proteomic results if I have time. So our approach is we're using the Tachman assay, which includes 754 microRNAs, and we studied them at the same time on this scientific platform. So we can see, essentially, these are most of the RNAs known to be involved in human reactions. So we look at the myrinome of the organism. Those are the 12 patients at which we have looked at initially. This is an agnostic approach to see what microRNAs may be affected by the drugs. And of course, they have other diseases, and so we'll analyze also, we are analyzing also other phenotypes, but looking at the comparison here, we find that each drug drives different changes in myrinome. And so we have rivaroxaban, dabigatran, apixaban. You see anything that's top left above the line is overexpressed. Anything that would be above the line but on the left is underexpressed, or on the right is overexpressed. And we're analyzing these results. Well, when we pull together for all the three drugs and analyze, we find 2 microRNAs, and we correct also with Bensamini fast discovery rate. We find 2 microRNAs that are significantly correlated with DOAC response, the microRNA 204-5P and the 20A5P. Well, then when we use the remaining patients as a validation cohort to see if this difference holds, and we find for one of them, actually the microRNA 20A, that this indeed holds, so there's a 1.4-fold increase in all the cohorts, so we think there we have one potential marker for DOAC response, and microRNA that is involved in the effect of DOACs. And looking at what this microRNA does already from the literature, we see that it's involved with regulates several of the coagulation pathway factors like apolipoprotein 3, the receptor 3 and 4 for thrombin. So it's an interesting molecule to analyze further. And for the other microRNA, we did not, at the validation cohort, there was no significant increase, but we noticed something else interesting that we're analyzing now, that there was difference between the different DOACs used. So In the case of rivaroxaban or pixaban, the direct factor 10 inhibitors, we see an increase, which is not statistically significant. But in the case of dabigatran, we see a decrease. So when you compare factor 10 inhibitors with thrombin inhibitor, there's a difference, and actually in different directions. So this is a hint of heterogeneity in their effect, which we analyze further, because, as I told you, on the back of our mind, heterogeneity in responses is something we're interested in. Well, a few things about our proteomics approach at the same cohort. And you see proteomics is going for, you can fish many fishes at once and not just, well, the guy on the left has a better time, I'm sure, but the guy on the right is much more productive, and this is the case with proteomics approach. And it's important because if DNA tells us what could happen, RNA tells us what very possibly will happen. At the protein level, when we find something, we know what actually happens as a result of the previous steps. So the project to look at the proteomic level is to look at endothelial cell cultures, HUVECs, and then we stimulate them with DOACs and see how the different expression protein at the protein level. Of course, we do the same also in other, we do analysis, proteomic analysis also in other projects, but this is the one for the different DOACs. And well, this is a protocol, I will go through it quickly as time is finished. This is all the protocol we do, the proteomic approach. And then we look at common proteins expressed by 4 DOACs. And we have, if you look at this, 4 proteins that are commonly overexpressed in, after DOAC stimulation. And when we start looking at them, what they do, well, at least one of them, this APP, is an important regulator. Well, the RSU1 is correlated with APP, which is an important regulator of vein thrombosis and controls coagulation. And it is, interestingly, it's also regulated by MIR20A, which I was talking before. So we are also looking at this, how these pathways connect at the 2-dimensional level, because the idea is a multi-omic correlation. And then we have these 4 proteins. When we look at the literature, they have anti-inflammatory, cardioprotective actions, anti-stress, anti-fibrotic, anti-atherosclerotic. But so we are looking at potential pleiotropic effects of DOACs here, and what do we find so far is mostly on the positive level. So it seems that DOACs have overall we're enhancing a positive effect on cells, which is also the clinical experience so far. And then underexpressed proteins, we have found 14 that are underexpressed in all cells. Again, with the bioinformatics analysis, we pinpoint out potential proteins of interest to study further. So, well, to summarize, this is a multi-omics integration for precision diagnostics that we are looking at, using all these omics connected together, co-analyze with the clinical phenotypes, environmental factors, all the profile of the patient, and then this could lead to endotype-based diagnosis, different subgroups based on all the factors, and also omics. We don't say omics is the most important. We think omics can contribute at several levels together with other clinical factors that are already known or are being discovered at different fields. So the idea is that all this information goes in the system, and then correct diagnosis and correct prescription comes out, and this is personalization at the clinical level. We have expressed our ideas recently in a commentary with my colleague, George Raya, and I think this is, I will close here. I say that much of this work is part of the PhD, ongoing PhD work of Mirya Palikar, who is in the audience also, and has an interesting poster with our work on the proteomics at the atrial fibrillation level at a different project. So if you're interested in proteomics, please be invited to talk with her. And I would like to thank all my collaborators. Thank you.
Thank you, Dr. Manolopoulos. Questions from the audience? No? We have one question.
Thank you, Vangelis. Would you please kindly comment on the clinical applications, daily clinical applications of the various actually pharmacogenomic testing, because there is a hype on the use of these assays, and what would you expect in the coming years?
Well, yes, this indeed, if we look at what is happening with pharmacogenomics, which is a simpler concept, it's still, and there's established biomarkers, for example, clopidogrel, CYP2C19, still there's resistance at the clinical level to be accepted. So if you look at that, one should be very pessimistic on what will happen with these omics markers. However, I think at some point there will be a shift in the mentality at some level, and all these accumulated markers, genetic markers, will somehow get incorporated into the clinical thinking. And I know, for example, countries like in Spain, I was recently there, that they have a nationwide initiative to implement pharmacogenetics for all patients through the hospital system for several years, and to confirm at the real-world level that this is effective, reduces ADRs, is cost-effective, and such approaches may generate data at the level of the ministry, not just what we're talking here, but this is at the level of the Ministry of Health in Spain, at the National Drug Organization also contributes, and that's why I was there. So I think there has to be some approach from top now. There's a lot coming from the bottom. We need something now to come from the top, either from the state or health insurance companies, national or private, or from medical societies. But there is resistance at the medical society level, cardiologists. In oncology, it's even worse for several markers, for example, tamoxifen and CYP2D6, that 15 years now, they are resisting to include it in their guidelines. So, well, I'm optimistic by nature, so I expect something will happen sooner or later on this. Thank you, Achilles.
Okay, thank you very much. So, the next talk will be rescheduled for later by Professor Rami and Kailan. There will be no coffee break, and we will proceed with the next session.
We would now like to invite Dr. Georgios Ioannis and Dr. Maria Epitaka and Dr. Christiana Gosparou to chair the continuation of this session.
So good afternoon, ladies and gentlemen. My co-chairs and I welcome you to this next session titled New Frontiers, which covers a wide range of topics on cancer treatment, including immunotherapy and integrative approaches. Unfortunately, our first guest speaker couldn't make it, so we're having only two lectures, two presentations today. So, Dr. Epitaka, would you like to introduce?
Good afternoon, and from me. I would like to introduce Dr. Konstantina Stylianou, Dr. Konstantinas Stylianou is a pioneering integrative oncology specialist who has made significant strides in the field by establishing the first integrative medicine department in Cyprus at the German Oncology Center. As the official ambassador for integrative oncology in both Cyprus and Greece, Dr. Stylianou is dedicated to advancing integrative cancer care approaches. Her academic journey began in London, where she completed her studies in Chinese medicine. She furthered her experience with a master's degree in nutrition and earned her doctoral degree in the United States, specializing in integrative oncology. Her lecture title is The Science of Living Well with Cancer, the Role of Integrative Oncology in Cancer Care. Dr. Stylianou.
Is Dr. Stylianou here? No.
Okay, we will try to find her, possibly for her to give us her talk later on in this session, however. So if you guys agree, it gives me great pleasure to invite to the podium Professor Agamemnon Epenetos, who is my scientific father, which is different to biological father. Professor Epenetos has been my tutor for almost 30 years now. We have together worked in cancer and stem cell biology, both at Hammersmith Hospital, Imperial College, and also now in Cyprus. I would like Dr. Ioannidis to share a little bit on his CV, and then we can have a discussion at the end. Thank you.
Thank you. So let me remind you that Professor Agamemnon Epenetos qualified in medicine from Glasgow University, subsequently specialized in medical oncology at St. Bartholomew's Hospital in London. He was offered a fellowship at the Royal Postgraduate Medical School, Hammersmith Hospital, Imperial College London, as a consultant and professor in medical oncology and cancer research. He has been a practicing oncologist and cancer researcher over the last 30 years, and a visiting professor at Imperial College London. In 1992, and together with Dr. Achilleoudi, he encouraged senior members of the government of Cyprus and the Bank of Cyprus to create and fund the Bank of Cyprus Oncology Center in Nicosia, which is a state-of-the-art treatment of cancer. In 2022, he was offered and accepted the position of Director of Research and Development of the International Stem Cell and Regenerative Medicine Research and Therapeutic Center in Cairo, briefly called Egypt Center for Research and Regenerative Medicine. So Dr. Agamemnon Epenetos has more than 20 years of experience as a biopharmaceutical industry executive. He founded and served as chairman and R&D director of Antisoma PLC, Lipoxine PLC, can move on. Yes. So Dr. Epenetos has received much international academic recognition and awards, and his very anticipated lecture is under the question entitled Immunotherapy of Cancer, a Dream Becoming Reality.
Well, thank you very much. I don't like this history of many years. People may think I'm old. First of all, I'm very grateful to Professor Ioannis Patrikios for giving me the opportunity to present to this wonderful conference. And I didn't know what to expect. I was actually slightly confused by the word multithematic. It sounded sort of a mixture of Latin and Greek. So I Googled it. I didn't actually Google it. I took one of these new apps where you type in a title and it gives you a picture. And I got this picture. Oops. I got this picture on, I need to, go back a slide. And I'm told I'm pointing at this. That one, okay. Yeah, I got, oh yeah, you can see that. And this is the printout from the internet. Obviously, they're way ahead of intelligence from us because they are telling me that instead of being multithematic, it's actually intergalactic presentation. So maybe Professor Patricios, one time you can give a global can connect us so we can present all of this to China, not only some Chinese present it to us, and we'll make sure that the slides change. So let's start from the beginning. Oh, this is not quite the beginning. The beginning was a boy and a girl. The girl ate an apple, and she was asked with the boy to go to Earth, a planet which could have been paradise. But on Earth, as you know, we have a lot of evils. And for the benefit of this conference, I'm focusing on cancer. I keep pointing. I'm sorry. I'm used to using a laser printer, which is, this is changing, yeah. Anyway, I will talk about it. So we're on Earth, they found all these terrible evils, but Pandora eventually managed to close the box, and a little devil was locked in. And that devil was called Elpis, Elpida in Greek, hope. So my starting point is that never lose hope, especially if you are involved in research and development. Hope I equate to a dream and expectation. And really what I'd like to present to you for a few minutes is this, wouldn't it be great if we could proactively educate our immune system to attack and kill cancer? We already know that our immune system is doing that job against many infectious diseases, and although we use antibiotics in parallel, but you need to use a healthy immune system as well. So really, this is the dream I'm presenting. But also, it's not my dream. It's been around for thousands of years. Last night, we heard about the Egyptians and the genetic family of Cleopatra. But 3,000 years ago, the Egyptians made very interesting observations that tumors could disappear if the patient had an infection with a high fever at the same time. Perhaps it was the first example of hyperthermia in cancer. And many things happened at that time in Egypt. But I think the most important thing is discovering papyrus that we could turn it into paper so they could document all their data rather than keep writing on the walls these hieroglyphics, which now, even nowadays, some of them haven't been interpreted yet. So it's good to document your data. And more or less at a similar time, a very, very impressive Greek physician, Galen, who was not only a physician, but he was a philosopher, he made this very interesting observation and also tried to connect that cancer may evolve from inflammatory lesions. I will show you one slide next to has mentioned that. But the father of immunotherapy was neither an Egyptian or a Greek, unfortunately. It was an American. And worse than that, he was a surgeon. And this American made the same observation, William Bradley Coley. He's the father of immunotherapy. And he was the one who actually made the same observations, but proactively he took bacteria from an infection and started injecting them into tumors. Some of them were also inactivated bacteria. But he observed some changes, some improvements. So I would argue that this is the starting point of cell therapy against cancer, although they were bacteria. And that's a negative control. You can use the bottom line. About 1 in 100,000 people, the cancer disappears spontaneously, which is, again, is a slight mystery. But by the time we discovered those patients, the cancer has disappeared, so we cannot do anything about it. So to go back to Galen, he might have been a fantastic molecular biologist if he was nowadays, because this is the observation that we see when we use this family of transcription factors called NF-kappa B. You can see it's connected to inflammation, and it's also connected to important cancer steps. So there is some connection, and obviously we need to disconnect it, because inflammation, we can eliminate it. The cancer, some of these changes are actually permanently switched on. So to jump into nearer this time rather than a few thousand years ago, for the last really few decades, there have been dramatic progress in understanding the genesis of cancer, immunobiology, and allow us to have a more scientific immunotherapeutic approach. So believe it or not, we're now living at the beginning of a new golden era in biomedicine. Despite all the world having all these troubles around us, this is a good time to be a doctor and a researcher. So cancer immunotherapy is fascinating because it's really the product of reciprocal learning. We're learning from the immune system how it works, and the immune system is telling us, and we're telling the immune system what to do. For the purpose of this meeting, I've divided my talk into 4 sessions, which should take very few minutes each. One is cancer vaccines, as you can see there. Cancer vaccines, I'm using the term as a vaccine. As a vaccine which you give to somebody to prevent them from developing a disease. There is small parenthesis in there, you can have therapeutic vaccines. You can give something that is a vaccine, but the patient already has a disease. Secondly, I'm going to talk about monoclonal antibodies, which is an area of great interest to us. We're the first people to show in the world that these things work. And checkpoint inhibitors, of course, is a family of antibodies. And finish with CARs. I know there is the Grand Prix around, but it's got nothing to do with CARs. So, vaccines. We have 2 wonderful cancer vaccines. One is hepatitis B vaccine. It was the first anti-cancer vaccine. And this can treat probably one of the commonest cancers in the world. Liver cancer is very common in China and in the Far East. It can be eradicated, prevented in more than 80% of patients that will develop the disease. Hepatitis B is a very important anti-cancer vaccine. Followed by the HPV vaccine, human papillomavirus vaccine, which was licensed more recently in almost all over the world in 100 countries. And this is recommended for young children, young adults. Then it should be recommended for both boys and girls, although the main disease that you get is cancer of the cervix. In the boys, it prevents the very rare disease of penile cancer. So, and of course, again, it's been a fantastically successful vaccine, and 90% of cancer of the cervix has been reduced. This is the good news. The bad news, we have other important viruses that we haven't achieved a great deal. Very important virus is the Epstein-B virus, which is a latent infection. It was originally discovered when people were studying Burkitt's lymphoma in Africa, but is now linked to a multiplicity of different lymphoproliferative lesions, malignant lymphomas, etc. There is also evidence that is triggering multiple sclerosis. Sorry, I'm moving towards the screen, but I'm moving away from a microphone, which is very microscopic. I can look something down. And if, although with great pomp and circumstance, a company called Moderna was spun out of Harvard a few years ago with the main purpose, they had the technology of mRNA vaccines, and they wanted to focus on EBV virus. Hundreds of millions of dollars have been spent, but the last time I looked in May, in publications in May 2024, they are still at preclinical stage. I don't feel sorry for Moderna because they made billions from selling the COVID vaccine anyway. But it would be important to have an EBV virus. But it's a fascinating virus because, as you can see on the bullet point of this, it's a dual tropic virus. It infects both B cells and epithelial cells. So, interesting virus, but we're not succeeding on that yet. I will jump in now into an area that I know very little, but is very, very exciting. I thought I knew everything, but I know very little in this area. And when I was doing research earlier years and looking at various vaccines, we were looking initially at the lower paragraph, we were looking at tumor-associated antigens, because you could see at the beginning, there are some antigens, like carcinoembryonic antigen, polymorphic epithelial mucin. There are various cell surface antigens that are expressed at low levels in normal cells, but they are highly expressed in cancer. And we thought if we can try and make vaccines against these tumor-associated antigens, we'll be successful. But we're not really very successful because, first of all, an immune response doesn't really depend on the amount, to some extent, of the antigen. In other words, it cannot discriminate between a low level of antigen in a normal cell versus a high level in the cancer. And that you run the risk of either not switching on an immune response, or if you switch to one, you could also have an autoimmune effect. However, the neoantigens are a different story altogether. They are foreign proteins, totally foreign proteins, developed by patients, which the immune system does not address those antigens They just come on when a tumor, for example, has mutations or goes through various omics, as we said here, but they are neoantigens. They are proteins that are unique to that individual patient. So my definition of individual therapies is something like a neoantigen. These are unique to each patient. So how can you do something for each patient? The next slide is another small parenthesis, because I work mostly in the UK, and I work mostly in National Health Service Hospital. But what was fascinating, the NHS, which the equivalent in Cyprus is called YESI, the NHS, which controls the budget of everything medical in the UK, they had a thought. I never thought that these big organizations have any intelligence. But they had a thought. They wanted to go again into the story, prevention is better than cure, and also for the NHS, prevention is cheaper than cure. They were very money-driven. So they formed this amazing NHS cancer vaccine launchpad, CVLP, and the main purpose of that for the NHS, think of YESI. Can you see the YESI go there? Say, we're now going to develop vaccines against neoantigens. So they took the idea that we're going to use mRNA to develop individual vaccines for every patient. And they thought this will accelerate cancer vaccines as a form of cancer treatment. And they've already taken aim because they can control, they hold the budget. If somebody holds the budget, you do what they tell you to do. They control 30 hospitals in the UK. They're already pioneering cancer vaccines. And of course, what I didn't tell you, they are doing all of this in partnership with industry. The two companies they are working with is BioNTech from Germany, who have the experience of mRNA vaccines, and Genentech from the USA. So there is a partnership of private industry together with the National Health Service, and they're developing internally vaccines, individual vaccines for every patient. And of course, they think they will save a lot of money by doing this in partnership, but I actually think it's quite an achievement for the NHS to start thinking rather than just spending money, and I wish, yes, it could develop also this ability. In parallel, the US, of course, don't want to be left behind. The USA, they have Merck and Moderna doing much the same thing. Everybody's really jumping on the neoantigens. It's an exciting new topic, but let's think about it, because every time you have something exciting, there may be some problems in the process, but it's interesting. So the first topic, the second topic after the vaccines is therapeutic monoclonal antibodies. And again, we were some of the first to demonstrate that antibodies work in humans in vivo and in vitro and therapeutically. Because in those days, we used to have polyclonal antibodies, and everybody kept saying, oh, if you get monoclonal antibodies, they will fall apart. The antibodies need to work as polyclonal. But also monoclonals work very well on their own. And the purpose of an antibody is to target to a cancer cell so that it can kill the cancer cell by drawing in the immune system or by behaving almost like a tyrosine kinase inhibitor, because a lot of the receptors are tyrosine molecules, and the antibody can block it, like the HER2. We still don't know exactly how much is immunotherapy and how much is behaving like an inhibitor. Also, they can carry drugs now. If you can now have like Herceptin, when it becomes a bit weak, then you can conjugate it into a toxic chemotherapy drug that is taken to the tumor, or you can conjugate it onto radioactive isotopes. So the antibody can be a carrier of a therapeutic drug. And they are very effective. You can also have bispecific antibodies that bind to the tumor and bind to the immune system, and that works. So in cancer, there have been more than 24 monoclonal antibodies now on the market against 16 antigens, and maybe out of date because things happening quite frequently. Some of these antibodies, as you can see there, they are selling for more than $5 billion a year. So it's a big market, but obviously is the #1 leading therapy for cancer nowadays, monoclonal antibodies. The third part of my talk is the checkpoint inhibitors. If you look, first of all, at the beginning, this tumor cell here, you can see there is an antigen on the tumor cell, and we're now using T cells. We're now moving towards this theme in the next presentation in a minute. We use the T cells that can recognize, they could recognize even 20 years ago, the antigens that are present on cancers, and yet they couldn't kill them. There was sort of a blockade. And we used to recognize these molecules marked in blue that they had a role to play. We used to call them accessory or collateral molecules. We didn't know what they were, but a couple of groups, and I will show you in the next slide, were able to define that on the cancer cell, there was, in this interaction, there are so-called death domains. In other words, the T cell, to be able to do its job properly, must not bind to this blue receptor, because the blue ligand here developed by the cancer is like barbed wire. You cannot get through it, and that's the problem. So what has been done, which has been dramatically successful, is to develop two different antibodies, one that can bind to the PD-L1 ligand to break the interaction, or one that can bind to the programmed death receptor on the normal T cell. If you disrupt this relationship between these two, then you only have the T cell on the T cell receptor that binds into the tumor, and that can kill the cancer cell. And this has been the dramatic thing in the last few years, actually, very recently. And two wonderful people, James Allison, who has recently moved to Texas, and Tasuku Honjo, they got the Nobel Prize for these observations of these molecules that now have this ability to kill the cancer. And basically, they inhibit the inhibitors. Therefore, the T cell can open up and kill, which tells us immediately that our normal T cells, without us doing anything about them, they have the ability to kill cancer cells. It's just that they're paralyzed by cancer. Cancer is a clever beast. Never underestimate cancer. Cancer is a clever beast. It develops all these inhibitors to inhibit the activators on a T cell. And that has been a great success. And also, what is very important, some of the patients that have been treated have been living very long. In other words, it's almost creating a vaccine effect around this T cell. The T cells, as they destroy the cancer, they may start having a sort of a longer-term vaccine effect. This is a fascinating area for further observations. And these checkpoint inhibitors, they're called checkpoint inhibitors, have been widely used in many different cancer types, but all these cancer types need to have the ligand on the cancer cell that can be blocked by the T cell. So you need to screen them to see if they're suitable for immunotherapy. This has been up to now. But again, a small parenthesis. If we now recently, and this is the work that was presented recently at ASCO in Chicago, up to now, we've been using one checkpoint inhibitor for one type of cancer. But what is interesting, at least from this particular study, which was published in Nature as well, if you take two checkpoint inhibitors, I'm not going to name them, I'll just call them Bot and Ball, two checkpoint inhibitors, they can now inhibit both the microsatellite stable and the microsatellite unstable colorectal cancer, because the ones that were unstable were originally responding to immunotherapy, which is a rare form of colon cancer, but the more common one were not responding. By combining two checkpoint inhibitors, it seemed to be getting very remarkable results, certainly measuring the tumor DNA in the blood, and the patients were, of course, at an early stage of treatment, appears to be very effective. So combining more than one checkpoint inhibitors could be synergistic. And if you look at checkpoint inhibitors, I've only showed you the reaction at the PTL level, which is up here. Joe Allison, who's gone to Texas, is now studying VISTA because he thinks VISTA is very important in pancreatic cancer. But look at all this list of checkpoints and checkpoint inhibitors. We haven't touched, this is the tip of the iceberg. We can make a lot more of these checkpoint inhibitors by dissecting all the parts of the tumor. So there is a great deal of hope, actually, I think, in this area with all these receptors. And the next slide, which is really towards the end of my talk, is the CAR-Ts. This is taking a normal T cell from the patient himself or herself, taking all the blood out, not all the blood, taking blood from the patient that contains T cells, genetically modify them in somebody's laboratory. Originally, it was done in Novartis laboratories. That's why they were selling them at the beginning for a couple of $1 million each. But you modify the T cell ex vivo, You expand them and you give them back to the patient. So now the patient has its own T cells. It's almost reminiscent of coli at the beginning, as I said to you. It has its own T cells that are programmed now to bind to the antigen of their choice. And this has been tremendously successful in rare lymphomas up to now and some myelomas. So CAR-Ts only recognize now cancer cells, only recognize cancer cells. As you can see from here, oops, yeah, pointer is not pointing, but anyway, you can read it. The 6 CAR-Ts have been approved by the FDA. The price has been reduced allegedly to $500,000 per patient, which is not acceptable if you have a large number of patients, but it can be acceptable if you have so-called orphan drug status, very rare diseases. NICE in the UK also recommended it. NICE was the purpose of the Institute of NICE is to be economic, to be use pharmacoeconomics. So to cut a long story short, CARs is the first example of a living cell, human living cell, killing cancer. And you can manufacture it and give it back to the patient. So this is a very exciting new chapter in immunotherapy. So to summarize, we have had great success with cancer vaccines, and it's extremely effective and relatively cost-effective. We have great expectations from mRNA and neoantigens vaccines, which is the ultimate of individualized therapy for the poor, for the rich, for everybody. Because the moment a patient comes into hospital, they have their neoantigen screen, and automatically the NHS gives them a vaccine. So you don't need to worry what you call them, whether it's precise medicine or is for everybody, is public. And that's what attracts me with the ESE. ESE is actually a free care system in Cyprus, which is a great achievement. It just needs a bit of fine-tuning. Monoclonal antibodies, of course, we know they are already very important. Checkpoint inhibitors is a huge area that is expanding dramatically, and CAR-Ts, even if one worked, it opens a whole new avenue that we can use human cells to do something extremely useful. So I would remove the question mark, is immunotherapy a reality or not? I think immunotherapy is a great reality at the moment, and we have shown that our immune system is there and waiting to kill the cancer. For the last couple of minutes, I have 0. Can I have another 2 minutes? The last couple of minutes, I'd like to present to you some new projects that we're doing in Cyprus. I'm at Imperial College in London, but Cyprus is very close. It's around the corner. We want to target tumor cells' survival tactics. Why does cancer survive, and what are the weaknesses? We need to find the weakness of the enemy before we do anything about it. What are the weaknesses of the enemy? We are interested in hitting only cells that have mutations, only cells that have driving mutations. There are mutations that we don't know their purpose, but you can find them in cancer. We don't know what they do because we have no knowledge of it, not because they're not important. But there are some mutations we know what they are doing. They are so-called driving mutations. They are important for carcinogenesis, and even not for carcinogenesis, they are important for maintenance. They may be important for spread, metastasis, drug resistance. Those are the nasty ones that we need to hit. To do that, the concept was that we want to develop a protein that is transported, like a Trojan horse. Think of Agamemnon, Achilles, and the Trojan horse, since we have been using a lot of Hellenistic terminologies in the last few days. The Trojan horse is something that goes in and out unnoticed. So we wanted to develop a protein that goes in and out of every cell in the body unnoticed, so they can go into every cell in the body. And we wanted to carry something that is only deadly to mutated cancer cells. So the protein that we're using is antennapedia. That's why I was very fascinated about Drosophila, because antennapedia, which is really on the antennae of Drosophila and the fruit fly, is an ancient. We've been talking, in fact, recently, Dimis Hassabis and his colleague shared the Nobel Prize, and because they had sequenced all the human proteins around. And they were shared with somebody else, his name escapes me, who made thousands of other new proteins that we know nothing about. We took a backward step, and we went a few thousand years back, and we looked at a protein known as antennapedia. You can see it here on the side. It's a 3.5 helices. And on it, at the tip, we can attach anything we like. The things that we like to attach is some things that blocks only mutations. The first example is we're blocking mastermind. Let me try to see if I can point to. Okay. You can see we're hitting this protein in the middle. This is a notch pathway. Simply putting in a cartoon is a notch pathway. And we're giving this drug here, which we call S4. This drug we have made by attaching another human protein, which is called dominant negative mastermind. And our bodies, we have a lot of actions, a lot of pathways, but when these pathways are switched on, they need to be switched off at some point. And one way to switch off a pathway is to use the opposite protein. Think of, for example, even in cancer, we have breast cancer, and a lot of it is driven by estrogen. One of the good treatments is an anti-estrogen. So our bodies are really yin-yang. You switch on something, you must switch it off. You cannot have a tachycardia of 100 permanently. As we heard already, you may drop dead. So we're attaching onto this protein, this blue ball, which is dominant negative mastermind, because mastermind, as you can see in there, is the MAML, is the last transcription factor in the notch pathway, which tells that cell, if it's activated, you tell that cell, you're going to senescence now, you go to sleep. If a cancer cell goes to sleep, you cannot kill it. Or you can kill it if you can also kill the normal human stem cells. So if a drug adopts a stemness, that's why I was very interested very much on the notch presentation, or the Drosophila presentation, that we need to get the cancer stem cells out of stemness. The moment they get out of stemness, they start differentiating and they are sensitive to treatment. So this drug that we developed blocks the mastermind, the notch pathway. And these are some of the early results. You can see in the control, the tumor is a very aggressive triple negative breast cancer, which is, it responds to chemotherapy initially, but it may relapse and may be problems with triple negative breast cancer. That's how it grows normally in animals. This is a xenograft. But if you treat it with a product called S4, it shrinks, and if, at the very end, when you dissect it, it's a small cyst that doesn't contain any malignant cells. And this drug, which is S4 and TR4, it has no toxicity that we can see because it just simply blocks very precisely the mastermind transcription factor at the DNA level. So we think this, we need to spend some more work here in Cyprus, but we think this could be a candidate for clinical development. And the second product, of course, is targeting P53. P53 is the commonest mutation in human cancer. And there are more than 100,000 mutations of the P53. But all of these achieve one thing. They disable P53. P53 is the guardian of the human genome. If you have P53, it protects you from cancer. If you lose the ability of P53, then it doesn't, you run into cancer. P53 controls P21, which is the final thing that tells you, please kill a cancer. And many people have been trying to develop anti-P53 products. Nobody has worked, but we have taken the Alexander the Great approach, also the Leon de Govonde. So we chop off the thought about P53. We're introducing the wild type P21. This is the work of Christina Kusparu. And she started a great PhD, and look what's happened to her now. She's in charge of everything. So you can see that, I don't know if she's working. So basically, by delivering P21, finishing in a minute, by delivering P21 wild type into P53 mutated cancer cells, they die. And again, this is here, you can see, first of all, in cancer cells, in vitro, it can penetrate every cell and it ends up in the DNA. It's great to have a human protein of your choice to end up in the DNA of a cancer. And,
Professor Benedos, I regret to kindly remind you that we are running out of time, so if you please come to the conclusion.
Okay, you don't want me to talk to you about the European Genomic Center. Okay, I will leave that for another talk. since I'm taking your time. I'd like to thank you and say goodbye to you. I left a picture at the top of a black hole. In case Professor Patricios wants to invite me in the future, I can tell you all about black hole, why they are there, what are they doing, and do they represent senescence or immortality? Anyway, thank you very much, everybody.
Thank you. We thank Professor Panetos for his very lively and comprehensive presentation. I think most of us do share your optimistic view for the role of immunotherapy in cancer management. My only concern is the cost and whether this is a limitation for its widespread use and embarrassment by health systems, national health systems. Are there any questions from the audience?
Here, at this point, we would like to thank you, Professor
Panetos.
Honored to have you. To ask for Dr. Konstantina Stylianou to please share with us her presentation that we skipped previously. Thank you, Dr. Stylianou.
Hello. I want to express my gratitude to Professor Patricios for the warm welcome today. I'm going to try to be quick so we don't miss any time from lunch. So today I will speak to you about a topic that I'm truly passionate about, which is the science of living well with cancer and the role of integrative oncology in cancer care. So during our lecture today, I'm going to try to explain what's the difference between integrative medicine, integrative oncology, in comparison with complementary and alternative medicine. I'm going to explain how does an integrative oncology care looks like in clinical practice, and at the same time, I'm going to review the clinical practice guidelines. So what is integrative medicine? Is this a term that you heard before? Or integrative oncology? Did anyone hear that? Probably not. So it's actually very different with alternative medicine and complementary medicine. Alternative medicine, to begin with, is used in the place of conventional medicine. So that means that the patient will stop any medications they're taking and they will use some form of alternative medicine. Complementary medicine is used together with conventional medicine. However, integrative medicine is also used together with conventional medicine, but in a deliberate manner that is personalized, evidence-based, and safe. So we're not using any modalities that have not been shown in science that are effective. So according to the Society for Integrative Oncology, which I'm also a member, it states that integrative oncology is a patient-centered, evidence-informed field of cancer care that utilizes mind and body practices, natural products, and/or lifestyle modifications from different traditions alongside conventional cancer treatments. Integrative oncology aims to optimize health, quality of life, and clinical outcomes across the cancer continuum and to empower people to become active participants during and beyond cancer treatments. Actually, 40 to 60% of cancer patients are utilizing some form of complementary medicine throughout their cancer journey. And majority of the oncologists are actually not aware of that. This is a study that has been done at MD Anderson, and it states that those patients will likely be women or advanced cancer patients, and they will seek some form of holistic approach of herbs and supplements or even nutrition. So this actually states that patients are seeking for a more personalized and patient-centered approach. So it's crucial to maintain those modalities in a safe environment in conventional cancer treatments. So how does an integrative oncology clinical model looks like? In integrative medicine, we like to view the person as a whole. So we look at their physical symptoms, their social symptoms, as well as the mind-body symptoms. So when a patient comes into our clinic, we assess all their patient's symptoms. We're going to go through their diet. So if the patient is receiving an immunotherapy treatment, for example, we're going to discuss gut microbiome, or a patient has low nutrition or can't eat well, we're going to increase their protein intake. We're going to discuss the exercise, as is crucial throughout the treatment, their psychology, and we're going to go through each of their side effects. And then we're going to review the guidelines. So what is the guidelines telling us about? If the patient has pain, we know that through science, acupuncture has been effective in treating the cancer pain. However, if the patient has insomnia, acupuncture does not work. CBT works better, or yoga works better. Or if the patient has hot flashes or dry mouth, a study that's been done on MD Anderson states that radiotherapy-induced dry mouth can be dealt with acupuncture. So at the German Oncology Center, which I'm the head of the department, we managed to set up the first integrative medicine department in the country. We are currently collaborating with some of the best cancer institutions around the world, including MD Anderson, Memorial Sloan Cancer Centers from Israel, and we try to hear our patients and give them a more personalized approach. So, because I don't have so much time, I want to highlight the guidelines that we have been developing. At the organization, the Society for Integrative Oncology, which is an international organization, collaborated with the American Society of Clinical Oncology, ASCO. And we have created 3 guidelines at the moment, which is pain guidelines, fatigue guidelines, and anxiety and depression guidelines. We review all the guidelines on all the research through all the databases, and we found the most effective and safe approaches to be combined during the conventional cancer treatments. For example, if a breast cancer patient is receiving aromatase inhibitor medications, they will develop joint pain. So acupuncture can be effective for that. So we need to find non-pharmacological options to help our patients deal with those side effects they've been dealing on a daily basis. Or if the patient has chemotherapy-induced peripheral neuropathy, which is a very common side effect and they can last for years. And a lot of times we have to decrease the dosages of chemotherapy, even stop certain drugs because of the symptoms. So again, reflexology, acupressure, acupuncture has been shown safe as well as effective. Our next guideline is the anxiety and depression. We know that cancer is a very scary word. So a lot of the patients go through a lot of traumatic, and actually some of them develop PTSD symptoms and the fear of the cancer coming back, or if they're even gonna survive that, they are dealing with insomnia and depression and anxiety. So we have to find modalities to help them overcome those obstacles. And then we know that during active treatments, mindfulness-based approach is very safe to be used, or even yoga, hatha yoga, like mild yoga exercises, hypnosis, relaxation therapy, music therapy, that we can take that to our patients' rooms. Reflexology has been proven safe. And our last guideline that we have developed is fatigue guidelines. Now with the new cancer advances, we have long-term cancer survivors. And we're seeing side effects that we haven't seen in the past. And we can't give our patients, again, drug after drug. So we have, again, I'm stating, non-pharmacological approaches that are safe to be used during the cancer treatments as well as after the cancer treatments. So what is the number one modality that can be used for fatigue? Exercise. Exercise. When I was at MSK, we used to get patients off the chemotherapy chair and we will take them to exercise. Why? Because of this, because of the guidelines. We know that exercise can help resolve the fatigue. Tai Chi. Tai Chi has amazing data that helps with breath work, lung cancer, fatigue, also balance. It's amazing the data we have out there. Why not put them into clinical practice? Why not help our patients deal with those excruciating side effects? Also, maxipassion that has been mentioned before from our Chinese presenter is another safe modality to be used. Also, American ginseng, a herb in the guidelines. Wow, I'm so amazed, I'm so happy. So American ginseng is actually been shown to be safe to be used during active treatments to manage the anxiety, manage the fatigue that the patients are dealing with. And this is a summary from all the 3 guidelines, which divides the major side effects that our patients are going through: pain, fatigue, anxiety, sleep dysfunction, nausea, hot flashes, which they're dealing on a daily basis. So I want to conclude that patients overall seek a more patient-centered and personalized approach. And integrative oncology only uses safe and effective modalities throughout the treatments. I want to thank you. If you have any questions or if you want to seek any support for integrative medicine, please email me, and I welcome any questions you might have.
Thank you, Dr. Stylianou, for your great presentation. Are there any questions regarding? Yes, please.
The microphone, please.
The microphone.
For one of the attendees.
Thank you. Thank you very much for your talk, Dr. Stylianou. Just a small question. How feasible do you think this is within the Society of Cyprus? Because if I'm being completely honest, I've seen a lot of people who would hear the word Tai Chi and think that we're talking about magic. It is a great thing that it exists, but considering that the vast majority of cancer patients, they're of an older age, they do not have this nuanced knowledge that we have. How feasible do you think this would be to integrate in their treatment without them being scared and become even more cautious of everything that's going on?
I agree with you. The Cyprus market can be very difficult to incorporate all these modalities. But at the General Oncology Center, we're doing that. We have Tai Chi classes every Thursday, and we have advanced cancer patients taking part during our classes, which Tai Chi is a very safe modality. But it's very important for the instructor to have oncology training. And I can't stress that enough. And it needs to be in a safe environment. That actions needs to be taken immediately if a patient gets dizzy, for example. But we're already doing that. And I want to make people not be scared and just get the necessary training and start incorporate those modalities, because actually patients are doing them by themselves and without telling them to their healthcare providers.
Okay. Any other questions?
This one.
Thank you very much for your excellent talk. I wanted to ask if you have any data on the outcomes of these patients. Do you know if they are truly enhanced by this integrative approach, for example, in quality life years or stuff like that?
There is millions of data out there. And at my department, we have a patient-reported outcomes that we do to each time our patient comes, and we're seeing a lot of improvements in comparison to the patients that are not being referred to our department. But there's tons and tons and tons of research, so we can't say that integrative medicine or these modalities do not work, because the research is out there. It's just this ignorance about the topic.
Makes sense. Thank you.
Okay. I think the session is over, so we proceed to the...
Many thanks to the attendees for your attention participation.
Thank you very much.
We will now proceed with session 7, State-of-the-Art Therapeutic Surgical Methods, the Robotic Da Vinci and Case Studies. Please join us in welcoming the chairs, Dr. Stelios Kokoulis and Dr. Panos Huntis.
Hello, everyone. I know it's lunchtime, so we want to start the lecture, so we move on. We're going to hear two excellent speakers, Dimitrios Kibarisopoulos and Dr. Savas Chiridis. We'll start with Dr. Dimitris Kibarisopoulos. We're going to talk about the role of robot-assisted surgery for mediastinal disease. Is this a marketing exaggeration or a game changer? I know Dimitris well. He graduated from the University of Thessaly in Larissa. In 2008, he undertook his residency in cardiothoracic surgery at Herfield Hospital. He was trained and established on video-assisted thoracic surgery lobectomies as standard practice for curative lung resections. In 2020, he was honored to have published an article at the Cardiothoracic Net Journal as innovative robotic surgery performed and presented for the first time in medical journal. Dimitris is currently an honorary consultant thoracic surgeon at Herfield Hospital, Royal Brompton, and at Herfield NH Foundation, London. And this is the only robotic and thoracoscopic minimally invasive thoracic surgeon in Cyprus. And he's our associate clinical professor. He's associate clinical professor at the University of Nicosia. Thank you very much, and welcome, Dimitris.
And Panos, I'm associate professor of robotic surgery here in European, not in Nicosia. I used to be in Nicosia. It hasn't been.
That's why.
It's all right.
Yes.
It's all right. Thank you very much, everyone. Before I start my presentation, I need to say that how grateful I am to Professor Patrikios for inviting me here for fourth consecutive year to talk about what I know best, and this is robotic surgery in thoracic surgery. In previous years, we have literally discussed about every potential pathology. I think it's time now to discuss about the kind of cases that, since I did them for the very first time with the use of the robot, I said, I'm not going back. I'm not going to do this any other way. So before I start my presentation, I need to say that I have no disclosure to make. And all this is mainly done here in ESO Athens, where I'm running. I'm the head of the robotic and minimal invasive clinic, just 2 years of age, and since then we've managed to do double cases than everyone else in the country combined. Just to give you a hint, this is one of the biggest hospitals in Greece, in Athens. I'm sure all women know this is a golden hall. I'm sure every woman in this room knows it. And my office is somewhere there on the 7th floor, where I have clear vision from Iatriko, where Dr. Chiridis is. So I say good morning to him every day, but he never comes back to me. So today I'm going to demonstrate how things are with a robot, and whether this is worth it or this is a marketing exaggeration, because marketing is everywhere. Is on the TV, is on our job, and unfortunately it has taken a very big role in our medical practice. So in my institute, apart from doing what I'm going to present you later, I'm so proud that over the past 2 years, we have hosted medical students from this medical school who not only came there to shadow us, but also they let us assist them. So this is one medical student from European University doing a case, simple case, I appreciate that, and I'm helping her. And this is another medical student who put a stent in and opened the closed airway. And this is the last picture from an operation we did at the beginning of August. And this guy here is sitting on the second row. And actually, he can justify, this is the very first ever robotic NAS bar correction for pectus excavatum done for very first time in the world by my team. And I just wanted to say how grateful I was. And these are members not only from medical schools and other medical students from London, but also people from Spain, England, Switzerland, and literally all over the place to be part of this. And these are some pictures from this operation. So marketing, as I've told you, has been to our everyday practice, and I'm sure you'll be waiting for this and that slides that I always show in this Congress. So I'm sure that people will try to convince you that this is Mercedes and this is a BMW, but I can guarantee you that it's not. So let's crack on now and talk about the mediastinal diseases. What is a mediastinum? There are two classifications. This is the first one, but this has literally 4, let's say, chambers, but I'm not so good with 4, so I prefer the one with the 3. So this is a slice of the human body, and this is the spine, this is the sternum, and whatever is in between is divided in 3 parts. The middle part is occupied by one of the most stupid organs that we've got, and we try to kill it. Is beating for a few trillion times during our lifetime, and we're trying our best to destroy it. This is the heart, and that's why there's not so much space there. However, there are some significant pathologies at this area. And the most important one is the anterior mediastinum, and of course, the posterior mediastinum. I remember as a medical student that the pathologies from the anterior mediastinum are the 4 T's. T for thymus, thymomas, thymic carcinomas that are related to myasthenia gravis, T lymphomas, thyroid, goiter or not, or ectopus thyroid, and teratomas. The remaining 5% is a heterogeneous team counting almost 200 different reasons, different pathologies, but the majority of them are related with germ cell tumors. How should we approach? I've told you before that, since I've started doing my very first case in pathologies like this, I said I'm never going to go back. But am I allowed to do that? And what are exactly the guidelines saying? So if you follow the NCCN guidelines, it actually doesn't say go ahead, man, but believe me, in red pencil, this is the very first time that there is light at the end of the tunnel. The previous one was a definitely no, but now it says, yes, okay, maybe it hasn't been enough data to support doing these procedures with minimal invasive techniques, but due to lack of data. Why is that? This kind of procedures, for instance, the thymectomies, represent 8% of my overall activity. So imagine I'm one of the very few robotic surgeons, not only in Cyprus, but also in Greece. So how can we have enough data to show them that, yes, it's worth it? I will show you later. In comparison to that, it has been officially approved for the past 3 years that the principles of surgical therapy of lung cancer, it has been approved that unless there is any compromisation, and of course, no discussion to the same outcome, a patient should be operated either with VATS or RATS, as well as there is experience. Now, what does experience mean? Who can say that I am an experienced surgeon? I can tell you, I've done 1,000 cases, but Dr. Patricios will come later and say, he's done 2,000 cases. Of course, you're going to believe him, right? So this is how we try to demonstrate what we're doing and how well we're doing this. This is an operation of mine that has been uploaded, it has been submitted, and of course, announced by the biggest, the most notorious journal in my specialty. This is the CTSNet, and I'm proud to present the operation that was done for the very first time with the use of the robot. You can see even the logo of the CTSNet. This is the official web page from CTSNet. And in this video, I'm showing, you can see with the PET scan, the lesion, where it is. It's a thymic carcinoma, extremely rare. I remember since I was in the UK consultant, I think I've done 2, and since then I've done another 2. So it's extremely, extremely rare entity. And as you can see here, this is a robot, these are the ribs, this is a phrenic nerve, this is a heart beating, not very nice place to work there. This is the lung, and this is a lesion. This is a tumor. So the reason I want to show you this is that at some stage, I noticed that the lesion is very well stuck to the pericardium. So I had a dilemma. What shall I do? Play that I didn't see it, or continue and do the unthinkable, which is what? Just opening the pericardium and excise the mass along with the tumor, with a beating heart just underneath, as you can see, with the slightest wrong movement of my hand or my finger, everything would turn red, and patient would be dead. That operation was done, I think, 4 years ago. The patient is alive and kicking. In this particular procedure, there was no compromise at all on the outcome. It was proved that the pericardium was infiltrated by the tumor, which means if I had left it in, patient would have a different prognosis. That was the first T of the anterior mediastinum. Let's go and have a second T, T lymphoma. You see a nasty lymphoma. This young woman had 4 different biopsies and all turned back negative. Why? Because you see how much necrotic tissue is there. It's not rocket science. We get in, we get samples, it's just a biopsy, and they're very happy because this is the only way to establish diagnosis. Otherwise, the other option would be either to have an open median sternotomy or a Chamberlain, which is still an incision. Would we like that? If it was you, if it was your wife or your children, would you like to have this operation? Definitely not. I'm sure you're going to love this. Let's go to another T. This is a CT of a patient. This is a chest. This is a sternum. And look at this. And look what's happening inside there. You see some calcification there inside it. And this is sitting literally at the top of the heart, at the top of the pericardium. So I'm going to ask our medical students. It's big, it's of the anterior mediastinum, and it has calcification in it. What is the diagnosis? Come on, guys, you know it. Very shy. I'm sure they know that this is a big teratoma. This is one of my operations that's going to be uploaded by the CTSNet 2. And the reason I'm showing this is not only that how I removed it, but because during the preparation, there was at some stage an oops that, when you hear a surgeon say oops, it's not a good thing. But here it wasn't actually that bad. But what happened here is, I want to show you. No, I think it's the next, yeah, it's there, sorry for the delay. So what do you think were these white things that we saw on the CT? Can you make an educated guess? So look what's going to happen here now. Come on. Yeah. It was an accidental move. You can never say how thick it is. And what happened is it burst and opened, and teeth and bones and hair, you can see the hair there. So instead of being a thoracic surgeon, I had to be a hairdresser and dentist, remove all the teeth from there. It was excised, patient is absolutely fine. So what was the other way? What was the other option? It's not apparently a malignant, but how else could I do it? By doing a median sternotomy. Would you like to have that if it was you? No. So let's go fast to the middle mediastinum. The main pathologies there are the bronchogenic cyst and the pericardial cyst. My very first ever case as a robotic surgeon 8 years ago, it was when I had to remove the pericardial cyst. It took me just 7 minutes to do it. The woman had insurance. She went to claim the money, and the answer was, we're not gonna cover it because you should have median sternotomy. That was told on a 23-year-old girl.
Dimitri,
yes?
Excuse me for that
Yeah,
sake of time killing.
Fast.
Thank you, sir.
I'm going to be very fast.
Have another 2 minutes.
So here, it doesn't. Anyway, here is a very, very rare case, but I'm going to skip it because it has both the thyroid and a cyst, duplication foregut cyst that I had to remove as well. And I can show you the images. This is the duplication foregut cyst, and you see how easily we remove it with a robot. Posterior mediastinum, literally just neurogenic tumors, and this is a schwannoma. Again, presentation on the CTS net, and just 1 minute video here. Look where it's a schwannoma, look where it's sitting, just on the posterior. And what was the option? How could I take it out? By doing a thoracotomy? No, it's this. It was removed in a few minutes just by encircling it and remove it. This is another amazing case with a posterior mass. It's a very, very rare case with Castleman disease. It's just the 5th in the literature from the posterior mediastinum, and a few minutes later, it was in the palm of my hand. So let's finish now the presentation. Why should we do this? Because apparently there are important benefits. Time effectiveness, no scars, literally no scars. Patients go home on the next day. We avoid foreign bodies like the sternal wires. The tissue damage is minimal, and the most important is the safety of my patients, because this magnifies things times 20, so it's extremely difficult for me to make something wrong. I can do it, but it's extremely difficult. Look at the scars, and look at the wires that the patient would have if he had a different operation, and sometimes these wires move. Of course, there are also disadvantages. The cost, the infrastructure of the institute, the experience of the team, the learning curve, but of course the data collection. So we are optimistic that in the near future, the NCCN will accept all this. And I'm telling you that the next time it's going to be a recommendation for RATS approaches, but every patient should be referred only to specialized centers. And what does that mean? I've told you I've done 1,000 cases. Dr. Patricios said he did 2,000 cases. So the truth is there, and I'm finishing with this. It's on my iPhone. It's an application. So when I sit on the Da Vinci, in order to open it, I put a 6-digit code, like I do on my iPhone. This is only when I can start using it. So at that minute, it calculates, it measures, and justifies that I've done this, and this is my data. It can tell you even how many minutes you used each instrument, how much time it took you, How much time compared to your other cases? How much time compared to other surgeons in Europe and globally? And only by this we can say at some stage that the robot is not Bumblebee and Optimus Prime, but the robot is in our theater, and it's not a marketing exaggeration, but it's something that will stay, and in the future it will be robot and nothing but robot. Thank you for listening. And I'm sorry for your...
Dimitri, thank you very much for an excellent presentation. I will move forward at this point with the next lecture, no questions, and we'll have questions after Dr. Chiridis. So
Good afternoon, everybody. We'd like to invite Dr. Savas Chiridis for his lecture, Challenges During Large Paraesophageal Hernia and Endohiatal Hernia Repairs. Dr. Chiridis is a first Cypriot robotic surgeon. He sub-specialized in robotic surgery and advanced laparoscopic in the General Laparoscopic Robotic and Bariatric Surgical Clinic of Athens Medical Center by Director K. Konstantinidis. From January 2007 to August 2017, Dr. Chiridis actively participated in the first Greek robotic surgical program in the country, while in the same time he completed his training in advanced laparoscopy, robotic surgery and bariatric surgery in centers of excellence around the world: Strasbourg, Grosseto, Houston, Los Angeles, New York, Buenos Aires. His total surgical experience overcomes the number of 3,500 patients. Dr. Chiridis.
Thank you very much. Thank you for the honorary invitation to the organizing committee and Yannis Patrikios, a good friend of mine who always support me with this beautiful organization, this beautiful congress. First of all, in continuation to the previous speaker, I would like to say that we are lucky to have Dimitris in robotic thoracic surgery, both in Cyprus and Greece. He has always been a great enthusiast, and for the younger ones here, I would like you to take from him the message of this enthusiasm about technology, because if you aim to do surgery, please aim towards robotic surgery. This is also my message before even you see my speech. So, in order to become a surgeon, you need to go under continuous education, and that will never stop. It will go to the end of life. In order to aim to robotic surgery, please take in mind that you have to finish with everything else. You have to know very well your open surgery, very well your laparoscopic surgery. You have to be a confident surgeon before approaching any novel technology to offer the less invasive advantage to your patient. So you have to do an extensive training that never stops, and after that, keep learning from other surgeons, from cases, from your own self. Here you can see our experience up to today. Although my main practice, because I'm in the private sector, is laparoscopic, robotic surgery remains my passion. The reason, because you see here in my private practice that robotic surgery is only 10%, is because the indications are very, very narrow still in general surgery. We have to be very careful when we select a robot. There is a debate about the cost of the robot, so there are clear indications, but we shouldn't go into in the pathway to do everything robotically. I disagree with that. The laparoscopy has its main role still in most of the laparoscopic cases in general surgery. So this is our robotic experience. We do mainly hiatal hernia repairs, a lot of reduniscence, which is our topic today, and I had the luck to be last week in San Francisco, where there was a lot of discussion about artificial intelligence in surgery. This will really change what we know about robotic surgery today. If the artificial intelligence component will be added, we'll have totally new robots that will realize what's happening in the operative field. They will be able to assist you, and maybe after 1-2 decades, they will be able to operate themselves. What was fascinating in the exhibition area in San Francisco was the new Da Vinci 5, which has the haptics. We have the haptic, the sensation of touch now in the new robot. We can feel the tissue. Is it hard? Is it suspicious for malignancy? Is it soft? How can we approach it? It gives us more information, and this is really amazing because it is digital. It's digital information of touch. And I didn't know how special this is until I touched it, because there was a rubber band, you pull it with the robot and you can feel the tension increasing in your hand. I think this will totally change our perception of robotic surgery up to today, because up to now we relied on our visual feedback. We didn't have any touch feedback from the robot. So this really is a game changer, and as I told you, artificial intelligence will be the absolute game changer after a few years. Concerning paraesophageal hernias, these are complicated hernias. As you can see, type 2, 3, and 4 hernias. Mainly, what we call paraesophageal is when we have abdominal component coming next to the esophagus, okay? And these are really complicated hernias that are very challenging to complete, and sometimes we have to ask for Dimitris to help. So the thoracic surgeon has to interfere because it's impossible to mobilize these types of hernias, or after previous surgery that we have a lot of adhesions which make things even worse. These are the common symptoms from a patient with a paraesophageal hernia. Of course, they have dysphagia, regurgitation, gastroesophageal reflux, dyspnea, etc. The surgical repair, up to now it was open, then it was laparoscopic. Today, the best way to approach it, and there is a lot of support from the studies you will see later on, is robotic surgery. It's the safest way. You go there, you have a very clear field, 3D field, thanks to the goggles which give you the double visualization. You have the 3D perception of space. You have you feel very, very comfortable and safe to make dissection in between vital structures like the aorta, like esophagus, the vagal nerves, and the pleura and the lungs. We have access through the abdomen to the mediastinum. The areas that Dimitri showed before, we can access them through the abdomen, and thanks to the robot, we can go up high, just below the inferior pulmonary veins. So here you can see the preoperative testing. We usually give this patient an extensive preoperative assessment. You have to exclude other pathologies, for example, achalasia or other pathologies of mobilization of the esophagus. Benefits of the robot are already discussed. The best benefits today are the 3D visualization and 7 degrees of freedom, but I would add to this the navigation, intraoperative navigation, because we have ICG. We can inject this ICG dye to the patient through the vein, through the venous system, and then later on we can visualize the vasculature. We use ICG also for another reason. We can localize the exact position of the esophagus preoperatively with ICG and use it in redo cases in order to avoid injury to the esophagus. So we have a very big advantage with ICG. This is our experience with generally with the GAJ area as well as with redo cases. And thank God we have very good results. Here you can see the initial positioning of the patient for such an operation. We usually use the reverse predictable position. Here is one of our typical cases. We have to visualize the hiatus. We start the dissection from the side with a lesser momentum. We always take care of this, if I can show you here, of this vagal branch towards the liver, we protect this branch. We don't excise it. And here it starts the dissection of the right crura, right crus, and then we will go around to the left crus and then dissect the esophagus. The main point is that in these cases, in esophageal hernias, there is a very big peritoneal sac. And the surgeon has to bear this in mind in order to avoid getting into the wrong plane. If we go into the wrong plane, generally in surgery, we have a lot of bleeding. As you saw in the previous excellent operations from our colleague, and also in these cases, we don't have bleeding because we move into correct planes. So in these cases, the correct plane is difficult because you have the altered anatomy, you have the whole peritoneal sac moved inside the mediastinum. So the trick is to find exactly the plane between the sac and the esophagus and dissect there. If you mobilize the whole sac, then you have a correct reduction of the hernia, and then things go much more easily. Here is our first case in Cyprus. Usually the first case when you go somewhere, it's very difficult. This is what experience shows. I'm called in Hippocrates to do a patient, and I realized that this patient has undergone a previous car accident. He has a terrible adhesions of the upper abdomen because they made emergency laparotomy to save his life, and a splenectomy. So we have a very widespread diffused adhesion field there, very difficult to dissect. Thank God, after mobilizing the structures, we were able to find our anatomy landmarks and move on safely. Here is another phase of another patient, another phase of the operation where we had this minor bleeding, and you can see how easily it is controlled because with the robot you have two different types of energy at your hands. You can easily change instruments with your foot and take over the control of all the operations. So this is a very good tool to have control of your own operation. With the robot, you don't rely so much to your assistants, although bedside assistant is of crucial importance for other reasons. But surgery is a little bit solo surgery, robotic surgery, because you have control of all the factors of the operation. In the modern robot I showed you, Da Vinci 5, you have also control of all parameters of the operating theater, the pneumoperitoneum pressure, the energy level, everything you can control from the console, everything. And another case where we have a small laceration of the liver due to the maneuvers, but easily you can control, you have flexibility of the instruments, so easily you put hemostatic material, you may suture it also there, and it's over. I mean, you easily control any incidents, everything is really well magnified, you have flexibility of instruments, and you can control everything. Here you see the reduction of the hernia. This is another case in the initial stage. You see all the omentum and the 4/5 of the stomach inside the thorax. These are the severe paraesophageal cases. The trick here is to stop reducing the hernia, not trying to pull the whole stomach inside back to the abdomen immediately, because, as I told you, the problem is the peritoneal sac. So if you try to pull the stomach too hard, you will make injury. So you see here, we stop and we start dissecting, as I told you before, exactly to the point where the sac starts. We find where the sac continues inside the mediastinum. We use the sponge. The sponge is the best robotic instrument. The best surgical instrument is the sponge. I said that last year as well. I say it again.
If possible, please, you can.
Yes, I'm almost over. So here you can see that if we put the sponge, we easily dissect the sac and away from the mediastinal structures, away from the pericardium, the pleura, with safety, and we get back. Here we had the surprise of a leiomyoma into the paraesophageal content, so we had to do another operation to remove this paraesophageal tumor, benign tumor, as an accidental finding. I have a lot of cases to show you, but we don't have time. Just this is the ICG injection preoperatively, as I told you, to have anatomically identify the gastroesophageal junction and be able to see this inside the robotic operation for the safety of patient. We use this in many cases. In this case, a patient from Poland, this is the last case, this patient from Poland came after 3 operations who had failed with severe regurgitation, and you can see how extreme are the adhesions and how much the robot helps us to identify the old sutures of the other surgeon, remove them, and slowly restore anatomy and try to figure out what we are going to do with this patient. In such severe cases, I prefer to open the thorax, unfortunately with open thoracic surgery at the moment, but later on we hope to do it robotically, and make another type of restoration here, the so-called Belsey Mark IV. I think it's a mistake to do a third Nissen in a patient who has failed so many times. So in these cases, we were successful restoring the anatomy and making a repair from the thorax. And you see the thoracic approach with the classic way in our team in Athens Medical Center. So there is literature supporting the use of robot in paraesophageal hernias. It shows significantly lower length of stay and lower rate of elongation procedures. You don't need to make elongation procedures like Collis Nissen when you use the robot, because it helps you to make better dissection of the esophagus and mobilization of the esophagus, which is key to these operations to become successful. I know we don't have time, so I will jump to conclusions. The robotic-assisted hiatal hernia repair has low short-term clinical recurrency. With increasing numbers, a wider application of the robot platform for such repairs is expected. It's easier for young surgeons to move to these difficult operations with the robot. And of course, in the rapidly evolving era of artificial intelligence, partial autonomy of robotic systems will bring the true revolution in surgery. Thank you so much for your attention. Thank to my team in Cyprus and Greece.
Okay, thank you very much for your excellent...
This is the house of my grandfather in Kaimakli, because I'm half Cypriot, so this is our house in across Santa Barbara in Kaimakli. Thank you so much. Okay. Thank you very much. Thank you so much. Thank you.
Hello? Okay. Next, we invite Dr. Dimitrios Kaperisopoulos and Dr. Stavros Hiridis to take their places as chairs for this segment.
So are we ready to continue? It is a great honor to introduce to this panel and to this Congress one of pioneers in his field, Professor Hadjipanagis, who is not only a professor of neurological surgery and director of the Center for Image-Guided Neurosurgery. He is a man who has dedicated his whole life in his field, and he has managed to perform the very first ever case in the United States of fluorescence-guided surgery for brain tumors. So, Professor, congratulations, first of all, and I'm looking forward to listening to your presentation.
Thank you very much, Kalimera. Can you hear me okay?
Yes, you can hear you very well.
All right, excellent. Okay, well, thank you. I really appreciate the opportunity to speak today. I'm sorry I wasn't there in Cyprus, but it seems like this is an exciting meeting that's going on now. So as was described, I'm at the University of Pittsburgh, and my focus is brain tumors. Here are my disclosures. I really want to describe a story of mine that I've been working on for the last 15 years here in the United States. I did all my training in the US. I went to the university, I went to medical school, and I did my residency at the University of Pittsburgh. And I've had several faculty positions and was able to work on, developing fluorescence-guided surgery in the US in parallel to Europe, and really kind of understand some of the challenges that we've faced with bringing new technologies to the operating room in neurosurgery, and understanding where the future lies in terms of fluorescence-guided surgery and a new theranostic approach that I'd like to share with you this morning. So in our world in neurosurgery, we try to take out as much of the tumor as safely as possible. We know that the outcomes of our patients are better. Surgery, however, is not the silver bullet that will cure a glioma. In fact, we have no cure for gliomas that are high grade. But we know that surgery is the best first step and gives the patient the best opportunity to have optimal outcome. Even with surgery, however, the prognosis still is limited, and we're looking for other types of treatments that can help us. And one of the big challenges is that we rely on an old paradigm in terms of removal of these tumors. We look at the contrast enhancing part of the tumor, but we know that the tumor extends past the contrast enhancing border on MRI scan. And, this is data that we've known for decades, where the tumor cells reside away from the main tumor mass. And for our experience in the operating room, it's very difficult to differentiate these tumor cells from the surrounding brain. And, the question is, how far can we take the surgery without hurting our patient? This is a view that we see with the exoscope. This is a newer device I use in the operating room that's quite different from the microscope. And the exoscope allows us to see things quite nicely, but the reality is we still have this challenge where we could see this brownish tumor, but we know the cells are all around here, even though we can't really tell what they look like in the operating room. So for us, we maintain a balance between taking out as much of the tumor as possible, but also preserving neurologic function. We know that when we cause neurologic dysfunction in patients with brain tumors, that their overall survival markedly decreases. And this becomes a problem because they already have a limited prognosis. So you're now taking someone with a terminal diagnosis and making their prognosis even worse. So we have to balance things between taking out as much of the tumor, but also preserving neurologic function. So, I've focused a lot of my career on how we can visualize these cells at the margin to more effectively perform surgery. We've had tools in terms of neuronavigation. We have intraoperative MRI, we have intraoperative ultrasound, and these are tools that help us, but they still don't provide the data that's reliably present to give us decisions about how much tumor is left behind and how far or extent of resection should be performed. So this is an unmet need that we in neurosurgery have had for a long time, trying to determine how far out our resections can be performed, confidently taking out that tissue in the invasive margin without hurting the patient, so that we can get the patient to move on to their adjuvant therapies. So fluorescence-guided neurosurgery has been around for decades now, and it's a nice technology that we've incorporated where we use a prodrug. The patient is administered 5-ALA orally. They drink this solution, and then within hours, the solution gets to the tumor where it's metabolized to its fluorescent metabolite protoporphyrin IX, as you see here in the schematic illustration. So the light we use with the microscope is a specific wavelength of light that then excites the protoporphyrin IX in the tumor and around the tumor to allow us to visualize the tumor. Well, we can't talk about fluorescence-guided surgery without bringing up a key pioneer in this area, Walter Stumer, who's at the University of Münster in Germany. And he performed the first ever multi-center study where there was a randomized study looking at how patients underwent surgery for the high-grade glioma with and without 5-ALA. And you can see on the left-hand side, the extent of resection was almost doubled in the red column here with those patients that underwent 5-ALA resection, and then those with versus those that underwent the conventional white light resection. Furthermore, the outcomes of the patients who underwent 5-ALA fluorescence-guided surgery were better. This was a trial that was done before adjuvant therapies were developed, and there's some critiques by that study, but nevertheless, that was the first study that really showcased how important fluorescence-guided surgery could be for extent of resection. The French completed a multi-center study. This was published last year, also confirming kind of the same findings, the German European randomized study. And this was placebo-controlled, which is a little bit different, showing greater overall extent of resection. There are other fluorophores that we have been using in neurosurgery. However, 5-ALA in the US is the only FDA-approved agent for fluorescence-guided surgery for gliomas. Okay, so back to the original picture I showed you in the operating room of a resection cavity, and you can see when we turn on the blue light, there's obvious residual fluorescence present, and this is what we're talking about in terms of seeing more along the margin. And there's no question that 5-ALA has helped us really understand, how far to extend our resections based on the fluorescence. This was the first case we did in the United States, now 13 years ago, where we were able to basically, use the 5-ALA to detect the residual tumor. And you'll see here with the flip of a switch, the blue light then is turned on, and that excites the protoporphyrin IX present in the tumor tissue to allow us to resect that residual tumor. So the profile of 5-ALA is quite nice. It's quite safe. The only thing we've learned is that patients can develop skin photosensitivity within 24 hours. It's metabolized by the liver, and overall, however, it's a quite safe agent that is used in most centers in the U.S. now. It's considered standard of care, and part of why we like using this is because of how it accumulates within tumor cells and tumor-associated cells. And based on the heme biosynthesis pathway, you can see here there's an enzyme called ferrochelatase, where the ferrochelatase basically metabolizes protoporphyrin IX to heme. And in gliomas, this enzyme is present in lower amounts, so the protoporphyrin IX backs up. And then there's some transporters that are changed in gliomas that alter elevate the concentration of protoporphyrin IX. So it's a unique agent that's able to accumulate within cells, which is quite nice to allow us to target those cells. Well, I think we've learned through the years that because of the ability of 5-ALA to accumulate within tumors and confidently show us the tumor, that there is clinical benefit just by itself, providing us a real-time diagnostic imaging agent for us to make decisions during surgery. And this is the concept that we took to the FDA to really let them know that diagnostic accuracy does equal clinical benefit. In the past, traditionally, clinical benefit has been judged by overall survival patient outcomes. This is a tool. This is an imaging tool that allows us to see the tumor better, allows us to resect the tumor better, and that's the basis for what we really defined the clinical benefit in terms of sensitivity, specificity, positive predictive value, and negative predictive value. The challenge in gliomas, however, is as you move into the invasive border, the tumor cells become less and less and mix in with the surrounding brain cells, so the fluorescent signal decays and decreases in this margin, so the specificity that we measure in this region is lower than measuring the sensitivity and the positive predictive value. As you recall here, the sensitivity is really the probability of a positive test result, meaning the testing of tumor presence, versus the specificity is, if we don't see fluorescence, there's no tumor there. But that's not the case in the invasive margin because there are infiltrative tumor cells present. You can see here the diagnostic accuracy of 5-ALA in high-grade glioma surgery is really unprecedented in terms of sensitivity and positive predictive value. The specificity is the area that's been lacking because of the biology of the disease. We performed the first multi-center study with 5-ALA years ago when I was in New York, again confirming the diagnostic accuracy of this tumor. And we were able to show a sensitivity of 96.5% of our biopsies confirmed tumor presence with the visualization of fluorescence. And the positive predictive value was equally high. Our specificity, however, was low, and it's because of what we just discussed. So the ability to understand the tumor microenvironment with 5-ALA has also been very nice and allowed us to do some different things in terms of analyzing different parts of the tumor for research purposes and also other types of studies. And the core of the tumor, because of the densely packed cells that accumulate protoporphyrin IX, are solidly fluorescent, whereas at the periphery that signal weakens and becomes pink in color, and then at some point we lose that fluorescent signal. And you can see also that in addition to the tumor cells, we've now learned recently that there are tumor-associated macrophages and microglia which accumulate 5-ALA protoporphyrin IX, which are associated with the tumor development and repression of the immune system. So these are another component that 5-ALA can target and allows us to resect them. And I will describe shortly some of the other research we're about to do. In terms of false negative fluorescence, we've learned that timing may be an issue, blood in the cavity may be an issue, and now we're developing new tools to really understand how far to push that visualization. In terms of overall efficacy, it's quite nice that we can visualize with high diagnostic accuracy tumor. That allows us to take out more tumor, and then based on the European randomized study, better patient overall outcomes. So you can see the timeline was really a 20-year timeline before we got it approved in the US. EMA got it approved in 2007, and then the FDA was really 2017. And this is, my team at the FDA, where we were able to, present the data and really help with its approval in May of 2017, actually June, and then it became marketed in 2018 in the US. So currently we're using 5-ALA for really high-grade gliomas, both new and recurrent. It's being investigated for a number of tumors, and now the question is, can we also use it for a therapy in the operating room called photodynamic therapy? Even low-grade gliomas are an area that we use 5-ALA for because we know that the lower-grade gliomas also can harbor higher anaplastic malignant portions in the tumor that can be detected on imaging. So we also administer 5-ALA for low-grade gliomas that are suspected to be high-grade gliomas. Meningiomas are another tumor type that we will likely see approval for 5-ALA. These fluoresce quite nicely in the majority of these tumors. You can see here, this is a recurrent meningioma we resected a year or so ago here at the University of Pittsburgh. Very nicely fluorescent, allows us to really kind of guide the surgery, especially in cases of recurrence where, scar tissue is present. This really helps us understand where the tumor recurrent disease is present. We are also exploring pediatric tumors. In fact, we have a multi-center pediatric study we're launching in North America later this year. Head and neck cancer is an area that's being investigated right now in New York. When I was there, we did the first head and neck case, a recurrent squamous cell carcinoma case. That's an exciting area that I think will probably grow in the future. We've also worked on the visualization devices. So you heard about the pro-drug fluorophore-5-ALA, but the other concept that we've worked on are the technologies that we use to visualize the fluorescence. This is an exoscope that I've helped with through the years from Synaptive that really highlights the fluorescent tissue. The exoscope utilizes a camera source that's placed alongside of the surgeon, as you see here, and all the surgeons in the team visualize the high-definition monitor. It's quite a nice apparatus with excellent visualization, magnification. It's even voice-controlled. And you can see here, this is some of the video where the resident and I are working together, looking at the monitor. We can work together, doing the surgery, and it doesn't require just one surgeon anymore. The devices that we're developing also include handheld devices to better visualize the cavity. And there are even loops now that have been developed to visualize the fluorescence. We know that the low-grade gliomas also accumulate protoporphyrin IX. So the question is, can we develop technology to visualize lower concentrations of protoporphyrin IX, especially in the low-grade population, and also in the high grades to see things better? In our world, we have small openings in the skull, and our line of sight and field of vision is limited. So we have tumors that have different geometries. So could we develop technologies that can help us see the tumor better along the periphery, along the edges, to help us resect, these areas where there are satellite lesions that could help perform better surgery? And these are, some of the concepts that we're working on. We've completed a newer clinical study using a newer device called the Spectra, where we were able to use this handheld device that has basically a light at the tip that emits the fluorescent light, the blue light, and allows for excitation of the protoporphyrin IX in a closer proximity. We believe that that can let us see the fluorescent tissue better. You can see here, this is the light. We're holding it here. It helps us light up the fluorescent tissue. I have it in the my left hand here, and this allows us to visualize the tissue to do our resections here better than with the exoscope or the microscope. This is a case that, we couldn't see much fluorescence with the exoscope, but we bring the light in, and it really enhances our view and more robustly showcases that fluorescence. And we're trying to quantify the level of cellularity of tumor cells that we can visualize with this fluorescence device called the Spectra. Okay, so the other concept I want to kind of wrap up with is how we now move from a diagnostic procedure with 5-ALA and fluorescence-guided surgery to more of a theranostic approach now. So can we use 5-ALA also to perform intraoperative therapy? And the short answer is yes. If we use a different wavelength of light, we can actually excite the protoporphyrin IX and create reactive oxygen species that can also cause tumor cell death and vascular damage. And here is the concept here. So the light from the laser device allows us to illuminate the cavity, the tumor, and the protoporphyrin IX is then excited, creating reactive oxygen singlets that then can cause tumor cell damage, inducing tumor cell necrosis or apoptosis and vascular occlusion. So this is the concept that we're now focusing on. Now that we've gotten the fluorescence-guided surgery story established, can we use the same agent for intraoperative therapy at the same time as surgery? The beauty of all this is that 5-ALA, again, is an intracellular agent in tumor cells and tumor-associated cells. So it's an ideal agent to properly target tissues that we want to target and spare the surrounding brain that's not involved by tumor. And photodynamic therapy has been around for a number of years. There's been other types of agents and constructs described in photodynamic therapy in the body. In terms of the brain, we haven't had an agent that has not been toxic until now. And 5-ALA seems to be the next step in terms of intracranial photodynamic therapy. There's also been some study on utilizing fractionation schemes where the photodynamic therapy light session is turned on and off during the treatment to allow for reoxygenation and formation of more reactive oxygen species in order to kill the tumor, the residual tumor better. The concept is take out as much of the tumor as possible with fluorescence-guided surgery and then clean up the cavity with intraoperative photodynamic therapy. There are limitations, however. So one of the biggest limitations is really the penetration of the tissue, by the light. And I think that's where, we have to, really be, we have to really understand how far this light can be delivered. But we believe that there's also an immunologic effect that is possible with this type of approach. We published a study based on the French experience several years ago, really highlighting 10 newly diagnosed GBM patients getting fluorescence-guided surgery and intraoperative photodynamic therapy. And recently, the long-term follow-up results from those 10 patients were disclosed. And what's interesting is that we had 40% 5-year overall survival in this group, which is really unheard of in a survival usually of 14 to 18 months in patients despite all treatments. And you can see here the median overall survival was 23.1 months, and then progression-free survival was 7 months in the Novacure study versus 17 with the Humerion. And here's the concept: is we're placing a balloon in the intraoperative resection cavity to really treat those areas of residual tumor. We initiated our first clinical trial recently at the University of Pittsburgh, and there's a new drug now that will be used in formulation for the intraoperative PDT that also allows us to visualize the tumor. It's called pentalophin, and it's a quite nice drug in terms of highlighting these tumors with fluorescence-guided surgery, and then its use will be for photodynamic therapy. This is our first case that we completed at the University of Pittsburgh. You can see here in the operating room, we're using the exoscope. We place the balloon in the resection cavity, and then we turn the laser light on for a specified time based on the volume of the resection cavity. And this is what we do. We turn the illumination goes on, goes off for a certain amount of time. This is the laser fiber that's connected to the machine that really helps us kind of treat the patient during the intraoperative photodynamic therapy. And this is us, Nicholas Rains from the University of Lille in France, our resident, and myself, with the laser light that we're using to treat the cavity. So I'd like to summarize, what we've done so far. And I think we've been working on these newer intraoperative visualization technologies that we believe are essential for glioma surgery. Fluorescence-guided surgery is here to stay. It really helps us perform more extensive tumor resections. 5-ALA is appearing to be a multifunctional agent that we can now consider for both fluorescence-guided surgery and intraoperative photodynamic therapy. So I'd like to just acknowledge all the groups that have helped me, including Dr. Drapatz, our neuro-oncologist here at the University of Pittsburgh, the University of Lille group, our lab, our clinical research team, and our industry partners. And if you have any questions, please let me know. Thank you very much.
Thank you, Professor Hadjipanagis. It was an amazing presentation, and congratulations again for your achievements in such a novel field. Unfortunately, we don't have any time for questions because we are very pressed for the next speakers, but thanks again for the honorary presentation. Kalimera. Thank you. We move on with the next presentation. I will call to the podium Dr. Rami Akwailan. Dr. Rami, he's already here. Hello, Dr. Rami. Dr. Rami was born in Jerusalem. He's a full professor of immunology and cancer research at Hebrew University of Jerusalem. He currently serves as Scientific Director of Cyprus Cancer Research Institute in Nicosia, Cyprus, and leading the Molecular Basis of Cancer Research Group. Dr. Aquilin has had a long-term interest in the genetic and molecular basis of human diseases. He translates hypothesis-driven research knowledge to develop new therapeutic modalities. His lab plays a major role in identifying critical roles for genes spanning common fragile sites that accompany or cause chronic diseases, including cancer and neuropathies. Thank you, Dr. Rami.
Thank you very much for the kind introduction, and I'm happy to be part of the speakers. Unfortunately, I could not make it to be with you, but I'll try to be concise and share with you some of our work on DNA damage and double-strand breaks. Before moving on, I just want to, this is my disclosures. As said, I joined CCRI last year, and in CCRI we aspire to be a world-class in this interdisciplinary cancer research institute, focusing mainly on cancer research and mostly on cellular and molecular basis of cancer, but also with a translation and in collaboration with a network of leading clinical and academic partners in the country, but also abroad. And we want to promote high-caliber cancer research in the island and contribute to breeding the next generation of cancer research scientists. So last week we launched the Cancer Research Club, so stay tuned and join us when you can, students and junior researchers. I think it will be a great platform for networking and for mentorship. Okay, so now to the science. My lab has been focused mainly, as introduced, also on the DNA damage. As you know, DNA damage and genomic instability is one of those enabling characteristics that feed and that contributes to many of the hallmarks of cancer. We focus mainly on studying the most deleterious type of DNA damage, which is DNA double-strand breaks, that can be initiated or caused by mainly environmental, like ionizing radiation, but also internally by activation of oncogenes or even physiological processes, as I would like to share with you today. The DNA double-strand breaks are detrimental. They can cause cell death of the cell if they are not repaired properly, but they also can be the reason for mutations, rearrangements, translocations in cancer, something that we see early during the cancer process, but also during progression. Today, if we focus on how do activated oncogenes contribute to DNA damage aberrations, we can rely on those aberrant proliferation outcome that is caused by activated oncogenes due to enhancement of the entry to the cell cycle. This aberrant proliferation can lead to DNA replication stress, eventually to DNA double-strand breaks, which activate the DNA damage response. And this would really act as a barrier for the transition of pre-cancer stages into cancer stages. What we would like to discuss mostly today is that we know today that DNA double-strand breaks favors certain regions in the genome, which results in chromosomal instability and, of course, SNVs that would feed into more additional mutations and cancer development. Replication stress is a major outcome of oncogene activation, and this could lead to genomic instability. We know that oncogene activation could also lead to telomere erosion and transformation of the cells. But what I would like to share and focus today on is this more growing stress that we are studying in our lab, but other labs in the world also, which is transcriptional stress, which is associated with hypertranscription that is happening within the cancer cell and could be contributing to increased level of DNA damage, in particular double-strand breaks that we study a lot in our lab. So as I said, oncogene activation requires not only building blocks and hypertranscription. This would lead also to high proliferation of the cells, again, to DNA replication stress, but also it can cause and it can come with a price. And as I will show you, this could result in excessive DNA double-strand breaks, which can lead eventually to genomic instability. So in order to study this, we wanted to focus on mapping of these double-strand break in an unbiased manner. And this is allowed by recent advancement in the technologies in the field, where we can today use next-generation sequencing to map these breaks in the DNA, DNA double-strand breaks, but also single-strand breaks, as you see here, other oxidation-associated breaks, and transcriptional breaks. So in our lab, we focus to use a method that is known as BLISS, for breaks labeling in situ and sequencing, where the double-strand break is blunted. Then we fuse an adapter of known sequence. Then we purify the DNA, generate libraries, and sequence. And eventually, we are able now to sequence the phenicity of the double-strand breaks, both from upstream and downstream, and determine at the nucleotide resolution where does the double-strand break takes place. We map this to the genome, and we can cluster these double-strand breaks, then go and study their characteristics and see how do they contribute to carcinogenesis. There are few lessons that we learned from mapping what we call the breakaome of different cancerous and non-cancerous cells. One lesson that we learned is that the landscape of double-strand break is cell type specific. It is different between this breast cancer cell from this non-cancer breast epithelial, and each cell line or each cell type would have a different pattern that make it very unique. We learned also that these breaks and the BLISS, the double-strand break density, is associated with early replication of the genome. So we know the genome could be replicated at early stage of the S phase or at late stage of the S phase. And we know that these breaks are enriched in early replicating regions, but also in short genes. Like we see more enrichment of these breaks in short genes within kilobases, rather than those that are major large genes of the genome, which, by the way, take them longer to replicate. So they will be in this region again in time of replication. What was amazing to learn, and is the focus of today's talk, is that most of the breaks that we identify as double-strand breaks in the genome, when we looked specifically at the different chromatin states that we studied here, is taking place on those regions that are actively transcribed, associated with active promoters, associated with strong enhancers, and those insulators that insulate or isolate the different chromatin compartments to make them in the, for example, in particular euchromatin regions versus heterochromatin regions. This association with transcriptional led us to call these breaks transcriptional double-strand breaks. We can study them in different types of enhancers, as you see here, observed versus expected occurrence of these double-strand breaks is much higher in the super enhancers or the cluster enhancers, and also in the single enhancers. And we can prove that this is associated with transcription when we perform GROSIC, when we look at the nascent RNA that is produced upon a stimulus like triggering with estradiol in MCF7 cell. We can see this peak of increased RNA of the estrogen-responsive genes, but also increased breaks in those same genes when we treat with estradiol MCF7. So this led us to show that actually in very active regions, transcriptionally active regions, there is coupling between transcription, but also occurrence of these double-strand breaks, which I will show you the mechanism in few slides. That is also coupled to DNA repair, because as you can imagine, we cannot let this double-strand breaks go without repair. Otherwise, we will end up with, again, cell death. If we inhibit or perturb this double-strand break repair, we can see that there is lower transcription of these specific regions. In this case, this is the study we published on super enhancers. So later on, we could identify that these breaks that is taking place in this and associated with transcription, they are mediated by the activity of topoisomerase 1, but also resolving of the R loop, which are those structures that cause these RNA-DNA hybrids during transcription. So these two breaks, one in each strand, could result on these transcriptional double-strand breaks and are associated with hypertranscription. The study is published recently, so I will not go into the details. Here are the papers. So from this study, we wanted really to focus and to try to map even more unbiasedly. If we can show there are hotspots in the genomes that are associated with double-strand breaks as a result of active or hypertranscription. And again, we employed the BLISS. And when we looked at this, again, unbiasedly, I remind everybody, these cells would never see any DNA damage agent. These are naturally, physiologically occurring double-strand breaks. We can see by the S-BLISS that there is these specific double-strand breaks, and they are associated with DRIP-seq, which is a measurement of R loops, and topoisomerase cleavage complex chip sequencing, which is associated with topoisomerase activity. And we can show and actually score these regions along the genome unbiasedly. And we came up with this score that is composed of this chipseq of top1, our loops, and top1cc, but also from our BLISS score, and showed that the enrichment is happening in those genes that are regulated by super enhancers again. So we show in the previous study that super enhancers are enriched in double-strand breaks, but now we are showing that super enhancer regulated oncogenes or genes, which is mostly we are studying cancer cells. There are also hotspots for transcriptional double-strand breaks. We can look at highly expressed, very highly expressed genes that are not regulated by super enhancer and show that there is much less of these double-strand breaks that we can detect by the BLISS. So there is enrichment of these breaks in these regions that are, in these genes, sorry, that are regulated by super enhancers. And if you look now at these genes, you probably can recognize many of these are very active oncogenes, JUN, XPP, PHOS, TFF, MYC, MCL1, and so on and so forth, that are enriched with these double-strand breaks. Can we control these double-strand breaks with inhibiting the activity of topoisomerase or R loops? Yes, as you can see here, we can reduce the breaks density if we use RNase H overexpression, or we knock down topoisomerase 1, suggesting and indicating that these breaks are regulated by these two mechanisms. Again, here just to show you that the double-strand breaks maps that we identify in these super enhancer regulated oncogenes are cell type specific. They are different between this lung cancer cell compared to this breast cancer. osteosarcoma or even a non-cancerous cell, they are cell type specific and they are determined differently because, again, this is regulated by this epigenetic map that is driven by super enhancers. So if they are super enhancer regulated, can we inhibit the super enhancer and see differences? Yes. We use the DBET, which is an inhibitor of super enhancer. And as you can see, when we use the DBET in MCF7 cell, we can reduce the breaks. And the same for HeLa cells, we reduce the breaks in HeLa cells. And this is just to show you the summary. With the DBET, we reduce in the MCF7, the same in HeLa. And if you look now at random genes, we do not see any effect of this inhibitor, at least not significant. So we can conclude very nicely that super enhancer regulated oncogenes are naturally occurring transcription stress hotspots that are identified in different cancers. I think I have one more minute to go, so I will rush here and just tell you that these double-strand breaks, we know that they would inhibit transcription. So how come that I'm showing you that are associated with transcription? Yes, we do think that this is the case, but they are and they should be repaired very efficiently. And we looked at DNA repair factor like gamma H2X, which is a surrogate marker for double-strand breaks, and we could show that gamma H2X density by chip sequencing is enriched on those same genes that we saw they are the hotspots for transcriptional stress, and we can compare them in MCF7 as gamma H2X density compared to random genes.
Professor Aguilan, sorry to interrupt you. We would be grateful if we can wrap up in a short period of time because we have a queue of hybrid speakers that we are unable to listen to. Apologize, but we are running late. Thank you.
Actually here and tell you that we do see that there is coupling with DNA repair, and if this repair is not really done, we can see accumulation of mutations in the genome. And I would just want you to leave with this take-home message that oncogene-induced transcriptional stress is a significant factor in the development of genomic instability. And thank you very much for your listening.
Thank you so much. We truly appreciate it, and we hope to have you with us face-to-face in the next meeting. Thank you, Professor Aguilar. We need to take a 5 to 10 minute break because the program is running really late. Please don't disappear because the next session will start very soon. Thank you, everyone. We now proceed to the next session. It's my pleasure to call the next chairs, Dr. Pavlos Neophytou and Dr. Eva Tsvetanova, to the podium. Thank you.
Good afternoon, everybody. Do we have with us the speakers, Dr. Konstantin and Dr. Gravanis? There, okay, thank you very much. My name is Pavlos Neophytou. I am the chairman of the Health Committee of the Cyprus Biological Society, which sponsors this session of the Congress. Our first lecture will be given by Professor Dr. Maria Konstanti. The title of her talk is The Neuroprotective Effects of Olea europaea, Crocus sativus, and Salvia species. Dr. Konstanti, thank you.
I would like to thank first Professor Patrikios and Elizabeth Johnson and all the members of the organizing committee for the invitation. I'm honored and thank you. And it's a great pleasure for me to participate for one more year in this wonderful conference. Well, let's see. Okay, this way, okay. Here. It's over 50 million people around the world that live with dementia. And in this number are not included the patients at prodromal or even preclinical stages. And the goal of treatment for these patients is to stop the disease progression and prolong the period of full autonomy in daily life activities. Unfortunately, there is no effective cure so far, despite the intensive research. The promising molecules for the development of new drugs unfortunately fail in clinical trials. In Alzheimer's disease, there are several neuropathological features, including the accumulation of beta amyloid proteins that form plaques within neurons, the hyperphosphorylation of tau proteins that form these neurofibrillary tangles, mitochondrial dysfunction, calcium deregulation, blood-brain barrier leakage and neuroinflammation, and all these conditions lead to the neuronal degeneration and death, mainly of cholinergic neurons in the basal forebrain and the neocortex. These neuropathological conditions lead in the progressive impairment of behavioral and cognitive functions, and finally to dementia. There is intensive research also on herbs, on the application of herbs, and since ancient years started, and including salvia, but nothing came so far. In our study, we investigated the potential neuroprotective effects of Olea europaea, Crocus sativus, and different species of salvia. This study, a preclinical study, employed various experimental models of the disease. and took place in collaboration with the Institute of Biosciences, the University Research Center of Ioannina, the Department of Pharmacology of the University of Crete Medical School, the Institute of Molecular Biology and Biotechnology of the Foundation of Research and Technology of Crete, the Department of Pharmacy of National and Kapodistrian University of Athens, and Democritos. The in vitro study we conducted employed the human SH neuroblastoma cells that were differentiated with retinoic acid to cholinergic neurons. And these differentiated cells pretreated with the extracts of the plants or the active compounds for 2 hours before being exposed to the to the amyloid or superoxide. And the viability of the cells was assessed with the MTS assay. The results of the in vitro study indicated that the extracts of Crocus sativus, the active compounds tested, had no toxicity. Oleuropein and the extract of olive leaves increased the viability, cell viability, by the total phenolic fragment of the extract Elocanthal displayed very significant toxicity. The salvia, different species extracts, had no toxicity at low concentrations, but we've seen toxicity at the higher concentration. When these neurons, the differentiated cells to cholinergic neurons, when these neurons were exposed to superoxide, to oxidative stress, their viability reduced to the half, almost to the half, and exacerbated by the extracts of Crocus sativus and the active compounds. The total phenolic fragment of the extract of olive leaves, and the Elocanthal, but oleuropein, the most important active compound of Oleuropea, protected the cells. The salvia fruticosa and officinalis extracts also protected the cells, but all the other salvia extracts exacerbated this toxicity. When the cells were exposed to beta amyloids, we've seen again toxicity, reduction of the viability, more than to the half, and the transcroquin 3 and 4, active compounds of Crocus sativus, protected the cells. Oleuropein again protected the cells from this toxicity, beta amyloid toxicity, and the phenolic fragment and the Elocanthal exacerbated strongly the toxicity. From the salvia species, the salvia argentea and verbenaga extracts protected the cells, but all the other extracts exacerbated the toxicity. In order to see if there is any direct effect on the aggregation of amyloid proteins in these cells, we ran the thioflavine assay, and we observed that the transcroquin 3 and 4, oleuropein, the extracts of salvia argentea and Crocus sativus, several diterpenes, triterpenes, methoxyflavones, phenolic compounds, the rosmarinic acid scutallerine, some of the active compounds of salvia protected the cells against the aggregation of beta amyloids in the culture containing these neurons. In the in vivo experiment, we used the 5X-FAN transgenic mice that bear 5 mutations in corresponding genes that are very important for the pathology of the disease. And these transgenic mice develop rapidly severe amyloid pathology, in particular accumulation of alpha-beta 42, the most important type of beta amyloids, starting from the age of 1.5 months. And at the age of 4 to 5 months, these transgenic mice develop a phenotype approaching that of the disease, of Alzheimer's disease. The transgenic mice, at the age of 2.5 to 3 months, received the extracts of the medicinal plants I mentioned before in a jelly for 33 days. And at the end of this period, the mice were submitted to various behavioral tests in the open field, novel object recognition test, novel object location test, in order to assess if there is any effect of the extracts to basic cognitive functions. And we observed that the extracts reduced the distance traveled by mice in the open field, the ambulatory and vertical counts, except the crocus, and they increased significantly the discrimination index in the novel object location and recognition tests. The in vitro data indicated that the salvia different species, and Crocus sativus and Olea europea, contain several compounds that display significant but dose-dependent antioxidant and neuroprotective properties, and in particular, oleuropein, transchloroquine 3 and 4, scutellarin, rosmarinic acid, and several diterpenes and triterpenes. But we observed that there is a diversification of the antioxidant and neuroprotective effects of the distinct salvia species. And I have no doubt that there is this diversification and in the other plants, medicinal plant species we tested, but we didn't have these samples to test. In the in vivo experiment, we observed that the salvia, Crocus sativus and Olea europea extracts improved the spatial and recognition memory of the transgenic mice. Taken together, this data, the current data, and the data from previous studies indicate that the medicinal plants we tested can mitigate the oxidative stress and alpha-beta induced neurotoxicity, and potentially are promising to be given as complementary to the traditional treatment. And I think that it's more significant, it's more important to say that for the development of new drugs, because they contain many active compounds with great potential. We should bear in mind, though, that all the medicinal plants, and this we tested, contain also toxic compounds that can significantly reduce neural viability and exacerbate the oxidative stress and alpha-beta induced neurotoxicity, and therefore they should be used with caution and in moderation in herbal preparations. In addition, we should bear in mind that the compounds they contain may also interact with the prescribed drugs, and this is of paramount significance in particular in the elderly and patients on medication, because these active compounds can modify the efficacy of pharmacotherapy and potentially induce toxicity. The data I presented here are part of the doctoral dissertation of Aristidis Kofinas, and for the conduction of the study, Professors George Leondaritis and Katerina Antoniou had a very substantial role. Christina Andriopoulou and Katerina Paglianga also participated in this study. Thanks a lot.
Thank you, Professor Constandi. Is there a question from the audience? No questions? Okay, thank you, Professor Constandi. My co-chair, Dr. Zvedanova, will introduce the next speaker.
Hello, welcome to our session. It's my great pleasure to introduce the person that's not paying attention to me right now, Dr. Achilleas Gravanis. He's a professor at the University of Crete Medical School. He's a professor that visits us quite often and teaches our students as well. He goes and teaches in Boston, so he's teaching pretty much everywhere. But more importantly, Dr. Gravanis is also working on some very exciting discoveries. He has talked to us in the past about his work on spinal cord injury, and today he's going to talk to us about the combination of TrkA, TrkB neurotrophin receptor activators in Alzheimer's disease.
Thank you, Eva, for this kind introduction, and I want to thank also my friend Yanis, who keeps me posted and present in this exciting, actually, event for Yanis 12 years. We are growing together, actually. So my colleague, Professor Kostadi, made my life very easy because she introduced you to this devastating disease, which will be the disease of the future, and is a result of our success, of the success of medicine for the last 20 years. So I will only underline the three biological endpoints of the disease. The patients lose various types of neurons, and so we observe neurodegeneration. The patients have a very important neuroinflammatory component of their disease, which was shown actually for almost all neurodegenerative diseases the last 10 years. And these patients also have problems with their myelin. They have lots of demyelination, a new event that was shown the last actually 3 to 4 years. It is frustrating because in almost all neurodegenerative diseases, we don't know the etiology, the cause of these diseases. So for us, pharmacologists, we cannot design actually targeted therapies. So the only option we have so far is to try to help our patients with symptomatic treatments. And this is exactly which is our focusing in our group in Crete, and our spin-off company, By Nature Ltd, which owns all the IP and the compounds I'm going to present today. So we design molecules, multidynamic molecules, with anti-apoptotic neuroprotective activity, and at the same time, these molecules can block the activation of microglia and induce phenomena that can block in situ neuroinflammation. And lately, these compounds were shown to be very effective in inducing neurogenesis in vitro, ex vivo, and in cell cultures. One of the most important actually mechanisms by which our brain controls the survival of neurons and microglia cells is through neurotrophins. Neurotrophins are polypeptidic actually agents produced in our brain and the peripheral nervous system. We have NGF, the first described neurotrophin by Levi Montalcini and Professor Cohen, and they got the Nobel Prize, actually when I was born. These two neurotrophins are recognized with specific receptors, membrane receptors, TrkA for NGF and TrkB for BDNF. They are involved in almost all important actually pathways in our brain, and they are very important for sustaining neuronal survival for all ages of a human being. If we lose the capacity in the brain to produce this type of agents, we are going to start degenerating in our brains, and they are shown to be at low levels to almost all neurodegenerative diseases. So for us pharmacologists is a good target for a symptomatic actually use of this knowledge. I'll go through the already published results involving neurotrophins in Alzheimer's disease. NGF promotes the survival of basal forebrain cholinergic neurons, very important cell population affected by the disease. And of course, in AD, the levels of NGF, as I mentioned already, are heavily decreased. NGF was given intranasally in animal models of the disease, and they were found very effective in blocking some of the symptoms of the disease in these animal models. Also, there is a formulation of NGF gold nanoparticles which was effective in reversing some of the damages of these animals. The levels of BDNF, as is the case for NGF, was also reduced in the AD brain, including humans. And in animal models, if you increase the signaling of BDNF, you can reverse some of the losses in cognitive capacities of these AD animal models. And transplantation of stem cells into the brain of triple transgenic AD mice can equally reverse some of the tau pathologies related to the disease. So our group, in collaboration with my friend for the last 20 years, Theodora Kalogeropoulou, an organic chemist at the National Research Foundation in Athens, designed and synthesized a big library, chemical library of small molecules, high lipophilic to pass the blood-brain barrier, mimicking some of the effects of NGF and BDNF. And I'm going to present the data actually which were published this year related to AD. Sivis Spigaritakis prepared his PhD thesis in Crete, studying the first of our compound, BNN27. Sivis now is in Boston. He spent some time in Harvard, and now he is in a spin-off company developing new therapies for AD using specifically biotechnologically designed monoclonal antibodies. So this molecule can mimic NGF in activating TrkA receptor, phosphorylation of the receptor, and internalization of the receptor and activation of specific gene networks. The next step was to use a very useful, actually, animal model of AD. Maria described some of the properties of this molecule. It's a 5-transgenic molecule possessing 5 mutations related to human AD on APP and beta secretases. And it develops a specific phenotype. It does not, it simply simulates the disease because Alzheimer's disease is not a single disease. It's a panel of diseases with some common aspects in terms of neurobiology, but we have different types actually of Alzheimer's, and we are now starting by studying clinical data to realize that the disease is not only one actually. And that's why it deserves different treatments for each one of it. So these animals accumulate beta amyloid. You can see strong astrogliosis in 2 months, synaptic loss, neuronal loss in the hippocampus, and of course deficits in their recognition, and LTP function in 6 months. We gave the BNN27. The formulation was a pellet, and the pellet was given for 60 days, and then we were following the animals behaviorally, and We tested the effect of the compound in vivo, given in working memory, spontaneous alteration performances, and the tests that Maria described. The work will come out in molecular psychiatry next week, so for those who want to read in details the paper, they can go there. So the compound was very effective in reversing almost 100% of these effects. We were very surprised because in the literature there were many compounds that they were used to reverse these phenotypic behavioral changes in this animal model, and none of them were so effective in reversing this phenomenology. BNN27 decreased the formation of alpha-beta plaques in the hippocampus of these animals and increased the synaptogenesis and decreased astrogliosis, two components, pathological components actually of the disease. Interestingly enough, BNN27 promoted neurogenesis in the hippocampus, specifically in the data gyrus of hippocampus, and this induction was very, very efficient. The compound protected mouse hippocampal neurostem cells in culture. We wanted to mechanistically study the effects we have seen in vivo by using cell cultures of neurostem cells, hippocampal neurostem cells, sterilely differentiated, coming from adult animals actually. And the compound was shown very effective in protecting these cell cultures against beta-amyloid toxicity. It reversed also beta-amyloid toxicity in neurons coming from embryonic tissues, from hippocampal cultures, and was shown to have a very protective effect, which was blocked almost 100% by a pan-TrkA receptor. I remind you that TrkA receptor is the receptor that binds NGF and, of course, our compound. We have done comparative proteomics analysis in wild type versus 5xFAD animals, untreated and treated with the compound, and we surprisingly and very indexly shown that the compound can limit actually the effects of NGF. Not only that, it affects many, 35 out of 80 genes related proteins, related to the pathology. The next step was to study the BDNF neurotrophin. So we have shown, and it was published last month in GLIA, that BDNF is very important in protecting the brain of these animals against demyelination. And we have specifically shown that demyelination is decreasing through the lifespan of these animals. Ioanna Zota, one of my PhD thesis, did a very tedious work on that. We went again in vitro to find the mechanism by which this is happening. So we cultured oligodendrocyte precursor cells. Let me remind you that OPCs give rise to mature oligodendrocytes which produce myelin. So beta amyloid was shown, and it was published many years ago, to be very toxic for these cultures, and BDNF could reverse effectively enough this toxicity. This phenomenon was also reproduced in primary cultures of mature oligodendrocyte precursor cells in wild-type animals. Having this data, we again worked with Theodora Kalogeropoulou, and we designed and synthesized a large chemical library of BDNF mimetics, TrkB receptor agonists, and one of them is very effective in inducing proliferation of human cortical neuroprecursor cells in cultures. It is very effective in increasing proliferation and survival in mouse adult hippocampal neurostem cells in culture, and also increase the proliferation and survival of mouse embryonic cells in culture. We have done also a comparative oncology of the effect of this compound compared to BDNF to find out if it has the capacity of mimicking some of the effects of BDNF on gene expression, and indeed we had very interesting results. the compound can mimic BDNF in controlling actually proteins related to APP. It can regulate the genes regulating the sensitivity of this tissue to endogenous BDNF, in other words, track B, and also regulates many of the proteins known to be involved in the disease. With collaborations in Europe and in the US, we have expanded our chemical library. Now we have many synthetic compounds mimicking the actions of BDNF and as agonists and activators of track B receptor. So to conclude, our idea is to design and test a combinatorial treatment for Alzheimer's, symptomatic treatment, focusing on diminishing neuronal apoptosis, demyelination and activation of oligodendrocytes, neuroinflammation by blocking glia cells, and of course, in an effort to reverse some of the damages by inducing in situ neurogenesis to replace the damaged neurons with new, fresh, normal ones. And these are the collaborators and students that perform all this work and our funding. Thank you very much for listening.
Are there any questions? Yeah.
Thank you. Yes, for this wonderful lecture. And I must say that I'm impressed how many this PNF practitioners surprisingly is positively with what the antifunctions are uncovered. And my question would have to do with amyloid, beta amyloid. Is it, do you know, have you established whether it acts on amyloid or indirectly to the mechanisms results in the reduction of the amyloid plaques?
Vangelis, let me make a statement which I think is useful for an audience that is not very informed on the disease. Beta amyloid was considered for many years as the pathophysiology and the etiology of the disease, which is now not the case. Actually, we know now, even Robakis, Professor Robakis, who was one of the first proposing beta amyloid pathology for AD, is convinced enough with his data that is an epiphenomenon of the disease. So something else is happening, or many other things are happening through our lifespan, and then you have this toxicity. So in our case, there are data in the literature showing that neurotrophins can affect the process of APP gene and also the post-translation and processing of the end product, inducing also secretases. So most probably, we didn't test it, but most probably this is the mechanism by which these compounds work through the regulation of the expression of APP gene and the post-translation and processing through gamma secretases.
Minor correction, John Hardy was the first person to do the amyloid hypothesis. But more appropriately, I agree with you about the fact that it is a tombstone of cell death. But now tell me why your molecules aren't tombstones, why the decrease in activity of these agents isn't simply a result of fewer cells that are alive. And therefore is also a tombstone effect. Why do you think it's a primary event which causes the disease?
You're right. I mean, because we don't know the etiology, the only thing we know so far is that two mutations in the APOE gene are heavily involved in linkage. Actually, they are linked to the disease. So
that's a correlation. That's a correlation.
That's a correlation, absolutely. Yes. So we have no idea on the pathophysiology of the disease in terms of the etiology. So that's why I mentioned at the beginning, until we find
the etiology, we should focus out of the box thinking on symptomatic pharmacology, actually. So, and because it's a very complicated disease with different types of clinical manifestations, we have to be multifaceted. We have to target different aspects and biological points of the disease to increase the possibility of controlling the disease. That was our hypothesis, and that's why we reasoned this way. Symptomatic treatment, multifaceted symptomatic treatment.
But that may just be a function of the... I think to label all those as Alzheimer's disease could confuse people. I think that I agree with you exactly that there are many causes of dementia, but I think there's likely to be one cause of Alzheimer's disease as described by the neuropathologists, particularly at the level of the neural plaques. It's a great area to be in, and I very largely agree with you, but I wouldn't call all dementias Alzheimer's disease. Would you call the dementia you get like Cassius Clay with his punching, plus a bit of Parkinsonism associated, would you call that Alzheimer's disease? Or would you call that dementia?
Yeah, I agree with you. And the more we get in terms of clinical data and linkage analysis with different gene expression profiles, the more we realize that we have different types of the disease. So we have to focus on each one of it. And that will be, I think, the future, and it will be very helpful for designing a new therapy for each one of them.
Thank you.
It's exactly the same story with Parkinson's disease. Sorry. It's exactly, you've mentioned actually that. Yeah.
There are a few more questions in the audience, but we are running out of time. So please, Dr. Gravanis is always willing to talk about research and not only. So meet him in the coffee breaks and talk to him about it. Thank you very much.
Thank you.
We now invite Dr. Marius Panzaris and Dr. Tassos Karandreas to chair the following segment.
So, good afternoon. I'm Tassos Karandreas. I'm a professor in surgery, general surgery, and special thanks to the Deputy Dean Ioannis Patrikios for his kind invitation. So, the next session is concerning neurology, neuroimmunology, neuropharmacology, and chronic diseases. The lecturer is Professor Marios Panzaris, Senior Consultant Neurologist, Head of Neuroimmunology Department, Cyprus Institute of Neurology and Genetics. Please, Professor, you may proceed.
Thank you. Let's wait for the presentation to appear. Thank you. Thank you, Patricio, for the invitation. Okay, thank you. Now, I'm going to talk to you about the stem cell treatment from the bone marrow concerning multiple sclerosis patients. And this is an unmet need that we have since we have a lot of patients that they do not respond to any treatment that we have until today. So the reason that I have decided to do this presentation is because we are now starting in collaboration with the German Oncology Center to establish a protocol and give this treatment in Cyprus. So, as most of you know, the bone marrow is the lining within the bones, especially in the vertebra and the ribs and the pelvic bones and the sternum, and it consists from two different types of marrow, the red one and the yellow one. From the red one, red blood cells, platelets, and white blood cells will originate, and from the yellow marrow, the stromal cells and the mesenchymatic cells will originate. Now, from the red marrow and the hemolytic stem cells and the amyloid and the lymphoid progenitor cells of the cells of the blood will originate. And important thing from the mesenchymatic or stromal cells is that these cells can give rise to muscle, cardiac muscles, neurons, and other cells if you treatment in the lab. Now, what is autologous hematopoietic stem cell transplantation? It's a procedure that has several steps. In the first step, we mobilize hematopoietic stem cells from the bone marrow, giving the patients intravenous cyclophosphamide and subcutaneous colony-stimulating factors. And after several days, we proceed with collecting the stimulated stem cells through a procedure called leukapheresis, and we keep them freezed as a cryopreservation method for the next step, where several days later we condition the patient with several cytotoxic drugs in an effort to kill the abnormal immune cells and even the bone marrow cells. And on the later stage, we give back the hematopoietic stem cells that we collected, and within several weeks, up to 4 weeks, the patient's immune system is reconstituted back, and the patient can go home and follow for several period for any side effects from the treatment. Now, the conditioning is the treatment that we give in order to kill the abnormal immune cells. Usually today we use the intermediate intensity protocol, where we only give cyclophosphamide and thymokyne, antithymokyne globulin. And through this method, we only kill the periphery abnormal cell and will not destroy the bone marrow. This is called the intermediate method. Now, what is happening after we give back the hematopoietic stem cells? In several months, we see that T cells are starting appearing in the periphery, and later under the action of thymus gland, more T cells and B cells are appearing in the bone marrow. And even later, we can see that there are some normalization of gene expression leading to the restoration of immune tolerance, where the abnormal immune cells that were not recognizing our own protein as our own protein, they are now functioning very well without causing any neuroinflammation. So what is the aim of the autologous hematopoietic stem cell transplantation, SMS? Is to destroy the abnormal immune system and restore it with normal functioning cells. And in contrast to the other treatments that we do have, and they are very effective, is given once off or is done once off, and it lasts for up to date. We have 10 years of effectiveness. What is doing the autologous hematopoietic stem cell is that it has a very rapid effect with rapid reduction of relapses, activity of the disease, and the progression of the disease. The first study was done in Thessaloniki in Greece, and it used to be done in patients that they had progressive disease with very severe disability. There were 15 patients, and they get a very strong conditioning with a lot of immune suppression. And you can see that within the first year, most of the patients presented a dramatic improvement of their disability. As the years went by, and we get a lot of information about the effect of this autologous hematopoietic stem cell transplantation, we changed our opinion, and from the progressive patients that we started giving the drug, we now give the drug in the relapsing patients, the patients that they have frequent attacks of the disease, the relapsing type, and in the small percentage of the patients that we give with the progression of the disease, these patients, they do also have activity with relapses or new MRI evidence when you do the MRI scan. And recently, we have finalized our method to the non-myeloablative protocols using only cyclophosphamide and antithymocyte globulin. So we only destroy the peripheral immune cells, not the bone marrow, prodromal, or stem cells. So today, in our meta-analysis, we know that autologous hematopoietic stem cell transplantation can reduce the frequency of relapse activity up to 70 to 100%. It can reduce the progression of the disease up to 100% for 5 to 10 years with no major side effects. And as you can see, most of the most effective drugs that we have can lead up to 50% reduction of the activity of the disease, whereas the autologous hematopoietic stem cell transplantation can lead up to 80 to 93% reduction of disease activity. So it's very effective. We have also seen that patients with relapses, that they also have a progressive nature of the disease. They produce a significantly less progression of the disease when they have the autologous hematopoietic stem cell transplantation compared to other medications that we have, and even they present some improvement of their disability. The mortality rate of the autologous hematopoietic stem cell transplantation in the beginning, in the 90s, was very high, 7.3%, but today this mortality rate is less than 0.1 to 0.2 because of the improvement of the method and also of the patient selections, because today we know that patients that have many years of the disease, very high disability rate, if they are very old in age and they have the non-relapsing MS type of the disease, they have the most chances, or they're in great danger for presenting mortality from the method. So today, we have a protocol that we follow, and the method of treatment is given in the relapsing remitting MS patients, in progressive MS patients with relapses or MRI activity. The patients have to be young, the short disease of the duration, less than 10 years, and they have to give a consent of their treatment, and also they need to have no other comorbidities that would put them in danger for increased mortality. So today, most of the international MS societies and neurologists, they advise that we can give this method of treatment, the autologous hematopoietic stem cell transplantation, to patients with active relapsing MS patients or relapsing progressive MS patients that they do not respond to any of the effective treatments that we have. And these patients must be young, less than 45 to 50 years old, and also they need to have the duration of the disease no more than 10 years. Another advice that we do have from the International Society of Bone Marrow Transplantation is that we need to have specialists in hematology that they know how to do the procedure. We need to have neurologists that they will have experience in the follow-up of these patients. We need to have a single database and put this data on for long-term observation. And also, we need in the future to have more and more ideal procedures, either in mobilization of cells or in the conditioning of patients. And finally, over the last few years, we do have comparative studies comparing the autologous hematopoietic stem cell transplantation with the most highest effective treatments we have from the beginning to see which is the best effect, which is the best treatment in the long term of patients with MS, because a lot of neurologists, including me, we believe that we need to fight the disease drastically from the beginning. Now, what about these mesenchymatic stem cells that we do have in the bone marrow? A lot of studies have shown that these cells have a lot of secretory capacities. They do exert a very fantastic and dramatic paracrine function where they are going, and they secrete neurotrophic factors, they secrete cytokines, chemokines, even small particles of that as extracellular vesicles are moving around in the area where they are going, and they exert actions like remyelination. They modulate the cells of the adaptive immune systems, the T and the B cells. They regulate the innate immunity, leading the microglia to a more pro-inflammatory, anti-inflammatory state, so it's improving neurogenesis. They have a fantastic migration capacity to go through the blood into the areas of the brain and travel to the areas of the inflammation. And finally, we've seen that they reduce the toxicity of iron-loaded within the cells in the brain that are found around the MS lesions. As you can see in this case, you can see that you need to give repeated infusions of mesenchymatic stem cells because their action is transient. And as you can see, while you are giving the infusions, the disease of the activity remains low, but unfortunately, if you stop it, you see that the disease is recurring. So you need to give it continuously. All meta-analyses in studying patients with progressive MS have shown that the disease is effective in these patients with progressive MS, either stabilizing or improving the patients, but this analysis includes also patients with progression and disease activity. If you narrow down the meta-analysis and you only include patients with progressive MS without any evidence of activity, meaning no relapses or no MRI findings of new lesions in the brain, then we see that there are no significant statistical evidence of any help of these mesenchymatic stem cells in this type of patients, which is the type of the patients that we need to find a treatment because we do not have. And why is this happening? We believe that MS and all the models that we use in experimental allergic encephalomyelitis are not the same. MS is only in humans. The immune system of humans is completely different from any animal. The second one is that mesenchymatic stem cells can be collected from bone marrow, can be collected from adipose tissue, and these tissue cells present different characteristics. The third one is that these mesenchymatic stem cells that are coming from MS patients are not so good as from healthy controls. And finally, the cryopreservation of the cells leads to a less functional capacity of these cells. So we need fresh mesenchymatic cells. And the third is that all the experiments have been done in animals where you give 1 or 2 million of these mesenchymatic stem cells in a mouse of 20 grams. And if you are going into the human with 70 kilos, you need 3 billion. And all studies in humans have been done with 1 to 2 million per kilogram. So probably we give small numbers of mesenchymatic cells. And lately, we have discovered that giving IV intravenous mesenchymatic stem cells, they are trapped. The majority are trapped in the lungs. They are destroyed, and the minority go to the brain. So we thought of giving them intrathecally. So we do lumbar punctions, and we give the mesenchymatic stem cells intrathecal, and they go very well into the brain, where they produce their secretome, the cytokines, the neural growth factors, and other substances, where they exert their neurogenesis, remyelination, and so on. But this is a transient effect, so you need to give repeated intrathecal infusions of mesenchymatic stem cells, and unfortunately, this leads to inflammation of the arachnoid. So it's causing arachnoiditis, and this is a very severe complication. Lately, we have started thinking of using not the cells, but the secretome, the substances that the mesenchymatic stem cells are producing, and this is done very easily through the intranasal route, because whatever you give from that route, it can go directly into the brain, and perhaps this might be the solution in the repeated infusion. So thank you very much for listening.
Thank you very much, Professor. Any questions from the audience, please? So, thank you very much. We may proceed to the next lecture. It's about systems biology dissection of stress-related mental disorders across brain regions, omic layers and cell types by Professor Nikolos Daskalakis, who is Associate Professor of Psychiatry, Harvard Medical School. Hello, Professor. I don't know if you listen us. We cannot listen to you. I think we have a dysfunction. Can you solve this problem, please? Is that problem from us or from Professor?
Can you hear me now?
Yes. Yes, we can hear you.
You can hear me now?
Thank you very much. Hello, Professor.
Yeah, good morning, Professor. Let me share my slides. Can you see the slides in full screen? Can you see the slides?
Yes, we can see them. It's okay.
So I'll be talking to you today about, I see myself with a neck of... So, in stress-related disorder, I'm working on stress-related disorders, and it's important to understand that a way of understanding stress-related disorder is to remember ourselves about the stress response. All mammals, including humans, we have a hardwired response to stress. So when we are exposed to a threat, here is a photo of a tiger. Behaviorally, we have to respond very fast with a fight, flight, or freeze response. And that has to happen very fast because we have to have a behavioral response to what is life-threatening. This is mediated from the autonomic system, and it's very fast. And then something that is also very fast is when the threat is gone, is that we also have to adapt and return to homeostasis with systems like the HP axis and the end product cortisol that is mediating the return to homeostasis. Something happens in stress-related disorders, something around individual variation, that individuals with stress-related disorders stay in that state of activation, although there is no more stress in their environment. A way of understanding individual variation is through GWAS, genome-wide association studies, and these genome-wide association studies are trying to connect the genotype with
they're trying to connect the genotype. I was trying to create. Okay, so they're trying to connect the genotype, which is, you know, the millions and millions of letters of the DNA with the phenotype, that is the binary variable, having or not having the disease. Statistically speaking, this is very hard, and because it's very hard, you need a lot of power. Here is, in the middle, you can see approximately what is the number of cases you need to have to identify the so-called significant loci for disease. PTSD, which is the disorder that I study, somewhere in the middle of schizophrenia and depression. Schizophrenia, after having 17,000 cases, now it has approximately 300 loci. MDD, which is much more environmentally regulated, did not give so much back in the investment of the GWAS. And PTSD is somewhere in the middle, where we have identified now 100 loci. But when you are thinking about it, in order to discover treatments, understanding disease better, you need to, at the same time, understand the biology of disease. And this you can do with a system biology approach that doesn't go directly from genotypes to the phenotype, but also introduces intermediate steps. For example, it introduces the relationship of genotype to molecular phenotypes, and then how those molecular phenotypes relate to neurobiological phenotypes that you could potentially study in live humans, like neuroimaging. So bridging the gap from genotype to phenotype. One way of doing it, I will give you one example, and then you can think of like a lot of other combinations, is, for example, when you focus on gene expression, you can study the relationship of SNPs with a gene. And in order to do that, you have to measure gene expression at scale with RNA sequencing or similar approaches, and also sample the tissue of interest, in this case, the brain, and collect more and more samples. But in the end of the day, when you have these samples, you can measure the genotype, but also measure gene expression. In a simplistic way, you need to create an equation that links SNP genotype with gene expression, so a combinatorial model that can predict gene expression from genotype. And this gene expression outcomes could be as complicated as spliced RNA or linear RNA, circular RNA, cell-type specific RNA, depending on the question at hand. And these models can be stored, transferred to others, and what you could then do is link genes that are in particular tissues and brain regions and cell types with disease. And this you can do it in the two ways. On the one way is to impute gene expression. So suddenly, when you have a biobank like the Cyprus Biobank, you can take the genotype files and convert them to impute gene expression, and then associate that with the phenotype, or going online, find summer statistics of disease, which is basically SNP associations with disease, and convert them to gene, tissue-specific gene or cell-type-specific gene association with disease. That would make a more appealing scenario in which you can form a hypothesis, test a drug, calculate polygenic risk scores that are more biological and potentially more meaningful. This is what we did recently in a Nature Genetics paper for PTSD. So in the very up Manhattan plot, you know, it's a Manhattan plot because it has the skyscrapers and the statistical signals go up and down, and some are big and some are small. We have did analysis to associate genes with this PTSD risk, and we start identifying particular loci that are very consistent, where we can really see mediating genes. But we are also early days, so there are particular locations in the genome that we don't have an exact understanding of what are the genes that mediate this. the obvious next step would be to actually study these gene expressions in the real tissue of PTSD and actually see what is going on. Is it the genetics? Is it the environment? Is it a combination of the two? In a recent publication in Science, we did exactly that. And this came up in May this year. And the experimental design was that we said, okay, we need to create a very big data set of postmortem multi-omic investigation of the PTSD brain. So we had 300 brains, 100 were from PTSD cases, plus minus depression, one control group that had no psychiatric phenotype, and MDD, which was a control group because MDD is the most common comorbidity of PTSD, but these cases did not have PTSD. So in these brains, we divided them into discovery and replication. We measured transcriptomics, methylomics, and proteomics from 3 brain regions. And in a subset of those, we also did a single-cell transcriptomic analysis, basically studying gene expression in the prefrontal cortex, but in every single cell of the sample. At the same time, having like biomarkers in mind, we have analyzed the UK Biobank proteomic data set of 1,500 proteins in relation to PTSD and MDD phenotypes. And at the same time, as I said, we were analyzing at the same time the GWAS of approximately 1 million people for PTSD and MDD, because in the end of the day, we wanted to see if the more critical gene expression, molecular phenotypes are different on the basis of genetic risk, or are more related to disease processes, more downstream of disease, with the hypothesis that in a disease like PTSD, you are born with some genetic background, but then you accumulate stress exposures, you eventually get the disease, eventually get the treatments. So when you die, all these gene expressions or other molecular phenotypes are influenced by all those factors at the same time. Now I want to go fast through the results. I think more important is you can access the paper and read the details, but when we compare PTSD and MDD, we want to identify which are the molecular features that are primarily different. We saw that prefrontal cortex gene expression was by far for both the most informative for this, but we also saw that in other brain regions, other molecular phenotypes had signals. For example, DNA methylation, this epigenetic regulation of gene expression in the hippocampus was relevant for PTSD, and other features were more important for MDD. Another thing we wanted to do is to actually correlate the data. One type of a correlation we did is, are the different regions, depending on the molecular phenotype, correlated with each other? So are they redundant? And the question was that there was low to moderate correlation. So the regions are not redundant with each other. They bring different aspects of biology, and also DNA methylation, that is very environmental influence, was the feature that was the least correlated between regions. Another question was, is the phenotypes overlapping? And within disease, it was important to know if die by suicide or having an experience of childhood trauma, is it producing the exact same result as the primary diagnosis analysis? And the first answer was largely yes, but depending on the particular feature you study, especially at the protein level, there were differences. Another question was, are male-specific and female-specific analysis overlapping with the primary diagnosis? And the answer was that males and females, male and female-specific analysis in PTSD largely had the same relationship with primary diagnosis, which was moderate correlation. But at the protein level, that correlation was much less. But in the MDD, we saw a sex difference there because the male analysis seems to be more in line with the primary diagnosis compared to the female analysis. And another question is PTSD and MDD overlapping as diseases? And this question is primarily driven by the comorbidity and also by the fact that genetic correlation says that the genetic overlap of the two diseases is above 90%. So the question is, are they the same? The answer is that if you pay the price and you study the downstream biology of disease, you see that they are actually more and more different. Here at the multi-region, multi-omic level, you see they have a moderate correlation. And especially for some particular features like DNA methylation, that correlation is even low. And also, there are genes that are different between the diseases directly that are not captured by studying the primary diagnosis alone from each of these disorders. Then one other question was, can we actually correlate omic layers with each other and how to do that? One way of doing that is to map the data into pathways and correlate them at that level, and realizing that the multi-omic signatures at the pathway level are not very much correlated. And that was a surprise to us, based on the classic biological dogma. And, going to the details to get a feeling how this can go is, we had the expectation that immune pathways will be involved in all those multi-omic layers, and that was true. But then we realized that some immune pathways could be endorsed only by the RNA levels, and then there could be other immune pathways that are endorsed from both RNA and protein, but then the direction of effect being opposite in the two. Also, other pathways that are not related to the immune system were also endorsed only by, for example, the synaptic involvement in both disorders was primarily endorsed by DNA methylation, RNA metabolism by proteins, and so forth. Giving that complex picture, in another approach to go about this, we try to kind of spatially register this data, try to understand if there was, the way you extract the tissue, you get, a sample of the tissue, but at the same time, you kind of collapse the structural anatomical layering of the cortex, and we want to see if inside the data we can capture effects of disease in different layers of the cortex. And we realized by doing this analysis that in the upper right panel that the RNA signal that had this prevailing immune dysregulation was in the very higher layer of the cortex, where you have primarily non-neuronal cell types, you have the leptomeninges and a lot of non-neuronal cell types, while the proteomic signal was in a lower, deeper layer where you have the neurons. So we formed the hypothesis that there has to be a cell type specificity happening. Another way of going to the data was to doing factorization, and we did that. And then basically we recapitulated multi-omic factors, some related to age, some not related to a particular factor, but they were different in disease. In the single cell analysis, we did primarily analysis by major cell types, although the data have seen a lot of other subtypes of cells. I have to finish, right? Did you say something? Sorry.
I'm sorry, Professor, I'm interrupting you. We are a little bit behind our scheduled program.
I will just finish in 2 slides.
Thank you.
So in the single cell analysis, we recapitulate the cell type specific signatures for both disorders. We had power to detect particular signals of the glucocorticoid receptor system, but also other signals. And we also saw that at that level, the correlation was smaller between the two diseases. And we were able to validate this with stem cells exposed to glucocorticoids. And the final thing, we had this observation in UQ Biobank that we show that the correlation of brain and blood was primarily at the RNA level of the brain with the proteins of the blood, making some hypothesis about a possible influence of peripheral signals to the brain, and potentially the upper layers of the cortex are implicated to that. And I will stop there.
So, thank you very much, Professor. If you please, no questions from the audience because we are a little bit behind the schedule already. Professor, you are very welcome for the next Congress next year here in Cyprus, and we may proceed to the next lecture. Thank you.
So the next lecture is given by Dr. Patrick Pallier. He is coming from Barts in London. He is in charge of projects on neuroprotection and repair after trauma in aging and neurodegenerative diseases. He's going to talk us about how we can treat the blood-brain barrier integrity, because we need to keep it functioning. Thank you.
Thank you very much. And first of all, I want to apologize for being late, but the taxi sent me to the other side of the town, so it was a bit of a nightmare. I'm going to talk to you about the effects of long-term leucine and isoleucine treatment on blood-brain barrier integrity and behavioral and cognitive dysfunction in male biopsy mice. So this is very different from what you've heard already, but this preclinical research is about some of the risk factors for developing dementia. And we do know that these risk factors, many of these risk factors are modifiable. And the ones that are easiest to modify are those that are linked to your lifestyles. And some may be difficult to control, just like smoking or excessive drinking, but this is achievable. Others are easier to attain, like a lack of mental, physical, and social activities, or feeding ourselves an unhealthy diet. And for instance, eating too much processed meat or consuming too much salt. And if the constant, persistent exposure to some of these risk factors are not being addressed, then they can lead to poor health, among which the development of obesity, insulin resistance, type 2 diabetes, or gut dysbiosis. And there is one thing that many of these risk factors have in common, is that the persistent exposure leads to, and this is also seen in Alzheimer's disease, can result into increased circulating levels of the branch-chain amino acids, leucine, isoleucine, and valine. So these are essential amino acids, and they're very important for the brain because they are the primary source of glutamate synthesis. And we know that these amino acids are neurotoxic and they're metabolites as well, because this is what happens in maple syrup urine disease. In this disease, there is a defect of the enzyme that is supposed to oxidize the alpha ketoacid derivatives of these amino acids. And the patients have been characterized by very severe neurological and developmental delay and an array of cognitive deficits and behavioral dysfunction, and also presence of markers in the serums of neurodegeneration and myelin disruption. Now, raised levels of these amino acids are also very well known to disrupt the blood-brain barrier. And we do know that blood-brain barrier dysfunction is a pathological feature of Alzheimer's disease that may occur very early on in the course of the disease. And therefore, with my colleague Simon MacArthur, we hypothesized that there may be a pathophysiological link between poor health and lifestyles, raised circulating levels of branch-chain amino acids, blood-brain barrier dysfunctions, and early cognitive deficits and behavioral dysfunction. So Simon wanted to test this in mice, but he didn't have the expertise, and he turned to me to try to set up a behavioral battery of tests to assess very early, very subtle cognitive and behavioral deficits in mice after supplementing them chronically with high doses of either leucine or isoleucine. We started treatment from 9 weeks of age, and after 4 weeks of treatment, I started testing the mice in this battery of tests that I'm going to explain one by one. And at the end, we sacrificed the mice. We took the brain and many tissues and the blood. A lot of work is being carried out on these tissue at the moment. So first of all is the nesting test. Why the nesting test? Because this is a mass equivalent of activities of daily living. And this is something that the mice do very routinely, and that seems to be easy, but actually it does require perseverance, it does require executive function. And executive function impairment is something that signs the start of dementia in Alzheimer's disease. Now, the idea is that you give a piece of folded paper in the cage to the animal, and you come back 23 hours later, and they are supposed to make and build a very nice nest. Now, if you look at the control mice in here, this is not a very nice nest. Actually, it should not look like this. This was the first time we were doing this. Maybe that was the wrong paper. Maybe they didn't have enough time. But a nice nest should be very shredded, and normally the mice pulled it on the corner of the cage, and the height should be higher than the mass so that they can be very snuggled into it. You won't see this 3D aspect on these photos, of course, but what you will see is that the treatment had no effect at all on this task in here. And if anything, the leucine and especially the isoleucine-treated mice performed better and made beautiful nests exactly how we wanted them to be. So they scored the highest score of 5. We couldn't even run statistics on this graph. But this is not very surprising because we know that in humans, supplementation with essential amino acids improve cognitive function and especially executive functions. And you also have to remember that in this situation, the mice are in their own environment, very quiet environment. They do this overnight, nobody is disturbing them, and everything is fine. Now, this is another story in this test. So this is a test that I call roosability. I invented it and created it, and this was published years ago. And why roosability? Because sleep-wake disturbances are a common feature of neurodegenerative conditions. Now, the idea is to assess the reactivity of the mice to mild disturbance. You take the cage from the holding room, you move it to a quiet room, and then you open the cage. And the experimenter stays still, put in front of the cage, and acts as a distractor. And then, because the mice are very curious, the first thing they do is that they start assessing their environment, and they see you. And then they start exploring and leaving the nest. And what we do is that we take the mouse by the tail, transfer them to a waiting cage, and we can assess the number of mice that are being disturbed by the process over time. And we assess this over 5 minutes. And what you can see is that after treatment with isoleucine, we didn't find any impairment. But this was very different with leucine treatment, and we find out that they were a bit more timid, a bit more reluctant to get out of the nest. And I don't know if this is down to a problem of roosability or if the mice are showing a source of an anxious-like phenotype, because this is typically a condition that is very safe. The mice are very used for the cages to being opened. They should react normally to cage opening. Now, this was done while the mice were very quiet in the holding room. I did this for a couple of days, and then one day, the day after, I arrived in the holding room, and the animal technicians had put the music on, and the tap water was on, the hood was on, there was a lot of noise, and the guys didn't understand what I needed to do, because you needed to have the mice very quiet before you run the test. And this ran for days and days, for 3 days in a row, and I thought, well, after all, I'm here, I'm going to collect, because if you don't collect data, that's lost data. So what happened in the noisy environment was, in fact, very interesting, because in this case, all the mice stayed for longer in the nest. They were very reluctant to get out. They were very stressed. But the isoleucine-treated mice were the ones that were the most affected by this acute stress condition. So I get that they are more susceptible to acute stress. The next test that I use is a test that I invented years ago, and I validated in the mouse model of Huntington's disease, but it was never published. But in this task, I take advantage of the fact that the mice on the rotor rod, they have issues maintaining balance. And then I flank the side of the plates that are running with the rod with cues as a distractor. And this is what I see as an equivalent of the flanker task. Flanker task is being used in the clinic. So, for instance, you need on the red rectangles here, the patient needs to focus, for instance, on the arrows and need to type on the computer which arrow in which direction it is, but it is being flanked by either congruent and incongruent arrows that act as a distractor and then will impair the cognitive function. That's the same idea in here, and I use two types of cues. The first cue, I called it the normal speed cue. This is a normal speed cue because visually, when it turns, it gives to the mice quite a nice visual feedback of the actual speed of walking. And I know that these cues are distracting because normally on rotor rod, the mice need to learn. There is an element of motor learning in here, and usually after 3 days of training, they start getting they can say 55 seconds, and then they plateau close to 60 seconds. Here, after 6 days of training, they barely achieve 50 seconds on the road. And then I don't tell the mice at all, and then I change the walking speed, a speed that they never encountered before. And you can see that they drop the performance dramatically. And then I introduce another cue, which I call the low-speed cue, because in these cues, in this type of cue, the patterns, the succession of patterns gives a feedback of a speed that is much lower than the actual rotating speed of the rod. And in this condition, the mice perform even worse. But the less treated mice, they perform significantly, similarly to the control. However, it was another story with the isoleucine treated mice. They performed significantly worse when this cue was being introduced. And I suspect that these mice are more easily distractible. This is the size of a normal open field, and normally the open field is based on the fact that the mice ate open arenas that are very harshly lit. I'm using a smaller open field because I wanted to have less aversive conditions with 3 different arenas. The periphery, which is close to the wall, which is being felt safe by the mice, an intermediate zone, and the center zone. And normally this is run in plain light, and you use a very harsh light. And if I wanted this to be very aversive, I would use 600 lux of light. And I use very low light to make sure that this was not felt very aversively by the mice. And in these conditions, the freezing episodes are normally correlated, and they correlate with anxiety-like behaviors in rodents. And you can see that the treated mice displayed more freezing, significantly more freezing episodes, but even very significantly more for the leucine-treated mice. And the leucine-treated mice also spend less time doing unsupported rearings. Unsupported rearings, they are vertical exploration. That's when the mice are trying to find a solution from the center of the open field very often to try and escape. So, and you can see that despite the fact that I try to have less aversive conditions, the mice are avoiding the center a lot. They travel less in the center. So the task is still being felt very aversive. But what I also noticed is that this time I was running statistics, when there was a main treatment effect that was borderline, this was done to the isoleucine treated mice. And these mice explored much less as opposed to the other treated mice. And what I suspect, so less distance travel, more time immobile. And what I suspect is that these mice are different. They are displaying different reaction to the task. And this is speculative at the moment. We'll need to do a lot more work to complete this. But I suspect that the leucine-treated mice display more like a more anxious-like phenotype. But the isoleucine-treated mice may be more susceptible to acute stress. That we've seen this already in the other task.
Professor,
finally,
we have another 2 minutes.
Okay, so I'll go very quickly on the zero maze. The zero maze didn't give any significant difference between the mice. However, the isoleucine-treated mice, they seem to show an increased impulsivity. They tend to decrease the latency to the first entry to the open arm. The open arm, that's the anxiogenic arm. So it doesn't seem that the treatment affected any of the gross locomotor function of the mice. I didn't put the results of the novel object recognition, which is linked to episodic memory. We need to validate this, but it seems to be that there is no deficit in memory, and that the other deficit that we see in anxiety, like behavior, in distrability, impulsivity, maybe very early disturbances before any deficits in memory happen. And we also find out in these mice that treatment with isoleucine disrupted the blood-brain barrier. And therefore, we propose that chronic treatment with isoleucine has a deleterious effect on the blood-brain barrier and leads to increased reactivity to stress and impaired attentional processes. We don't know if this would lead to increased anxiety, but we know that anxiety often occurs early in the course of AD, and that attention is the first non-memory domain to be effective in AD. So maybe reducing isoleucine intake to slow or postpone the development of dementia symptoms could be one likely strategy. And I want to thank Professor Patricios, of course, and my collaborators, but also the brilliant students from this university who join me most of every summer to do some research with me. Thank you very much.
So, Dr. Paller, thank you very much for the presentation. Unfortunately, we don't have much time because Professor Gravanis. Sorry for that.
Very interesting work. It reminds me, your work, the story of having a peripheral cause for neurodegenerative conditions which can be facilitated entering into the brain through the blood-brain barrier opening. And you know very well the story about Parkinson's disease and alpha-synuclein in the GI tract. So I think that your thinking is out of the box for AD, adding the possibility of having some, deleterious actually signals, and through facilitation of the opening of the they enter into the brain and damage the specific neurons. So would you kindly comment on that?
Well, we are investigating this at the moment. So we've done a lot of in vitro work, and the in vitro work shows that the 3 different amino acids do have different effects on the permeability between cells. Isoleucine increasing the permeability, valine doing nothing, and leucine doing exactly the reverse. So at the moment we're investigating this a lot because this is quite surprising, and this has been validated by many different kinds of tests. And of course, these are models. We model this. We don't put the 3 amino acids together, which are some in vivo work that we would want to do in future. But at the moment, it seems that these amino acids may have different effects, and some of which may go through increasing inflammation, for instance. But again, this is too early to talk about it because this is the work of my colleague Simon McCarter at the moment, and we're doing a lot to explore this aspect. I was just in charge of the behavioral neuroscience, but we work collaboratively on trying to solve these questions. Thank you so much for your
Well, thank you very much. I think that we are moving to the next session. So I would like to ask the next.
For the next presentation, we invite Dr. Pavlos Kostas and Dr. Violeta Anastasiadou to take their places as chairs. Please.
Ladies and gentlemen, good afternoon. It's an honor to introduce the first speaker of the session, Professor Nikolaos Grigoriadis. Professor Grigoriadis is a distinguished expert from Aristotle University Thessaloniki and a leading clinician at the Herbal University Hospital in Thessaloniki, Greece. His work is focused on exploring immune-mediated mechanisms in neurological diseases, particularly the role of complement activation. Today, Professor Grigoriadis will share his insights in a lecture titled Complement and Neurological Disorders, shedding light on the intricate interplay between complement pathways and neurological health. Please join me to welcome Professor Grigoriadis.
Thank you very much, Mr. Chairman, for your generous introduction. I'm really grateful for being here with you once again, this year, and I'm definitely grateful to the organizers, and particularly to Professor Patricios, a good friend and distinguished scientist and collaborator of these years, for giving me the opportunity to be here and share with you some updates about the complement in neurological disorders. Complement, which is an old player in immunity, though a new target in neurology. And to tell you the truth, while I was a medical student, we all knew that there is no possibility that anything might be asked from us during examinations from the complement. It was all the time in the material we had to learn for our examinations, but we knew nobody was paying any serious attention on it. But after so many years, it came out that complement is a key player in neurology, and these are my disclosures, and this is what I will try to do within the next 20 years. Before I start, I will kindly ask you to allow me, although I haven't gave any notice to the organizers and Professor Patricios, I would like to dedicate this presentation to my beloved Ioannas Karousis. He is the son of our esteemed and well-known colleague and professor, Dimitrios Karousis, from Israel, from Hadassah. His son was assassinated recently by terrorists in Tel Aviv while being in his task for his project by his university. He was an excellent student of the School of Architecture, and you may understand that this was an awful event that had a great impact and still has in our life, of course, primarily to his parents' life, but also to my life and my wife's life, Tina's. We are the godfather and godmother of Ioannas. So in his memory, I would like to dedicate this speech. And finally, because on Sunday we have his memorial ceremony in Greece, in Cyprus, and in Israel. So the complement system contains more than 30 proteins that are present in blood plasma or on the cell surface. And the three major functions this system has is the opsonization of foreign molecules, the increase of inflammatory response via short peptides called anaphylatoxins, and the lysis of the pathogenic microorganisms via the formation of a pore in the lipid membrane. The very last mechanism is also valid for killing not only microorganisms, but also body cells, of course, in the central nervous system. This is the complement system, and we all know that there are three different ways that this system is activated. We pay much attention, of course, to the classical pathway where in order to have the activation of the complement, we need to have autoantibodies. It is the autoantibodies that invite the complement to become activated, and finally, as you can see here, after this cascade of events, it may finally reach to this MAC, the so-called MAC, the membrane attack complex, which is a pore on the cell membrane, and via this pore, the cell becomes degenerated and finally killed. So I will start by the role of complement. I will start from the periphery, and then I'll go to the central nervous system. the role of complement in the neuromuscular junction and peripheral nervous system immune-mediated disorders, and I'll start with the more classical neuromuscular junction disease, which is the myasthenia gravis. Here we see 3 different mechanisms in order to have myasthenia gravis. The first one is that autoantibodies go and block the receptors of acetylcholine receptors in the metasynaptic membrane on the muscle fiber. The second mechanism is that one autoantibody against the acetylcholine receptors may block 2 neighboring receptors, thus leading to the receptor internalization and finally degradation. And last but not least, it is the complement that it is activated and brings problems in the neuromuscular junction function. But it's not only these sound a little bit more functional, let's say, mechanisms. This one is really very important. Why? Because due to the complement activation, there is a massive destruction, morphological destruction of the neuromuscular junction. So we may understand that this mechanism may lead to more permanent neuromuscular junction malfunction. And whether it is important, the complement or not in this process has been also identified in this wonderful paper made by Angela Vincent in Oxford group, where they found that in anti-acetylcholine receptor antibody negative patients who were exhibiting myasthenia gravis like clinical symptoms, in the biopsies it was found that there is an complement activation already there, despite the fact that no antibodies were able to be detected in the serum of these patients, thus meaning that it's not the antibodies the absolute necessity for the induction of neuromuscular junction. And of course, this has also been further supported by experimental studies, as those 2 here. You can see that animals that had been deficient to C6, the parameter of the protein C6 of the complement, did not exhibit any clinical disease after myasthenia gravis induction, compared to the wild type, whereas by the time the C6 was substituted in these animals, the animals exhibited very nicely myasthenia gravis clinical signs. And here in this experiment made by Mihailidou, and wonderful researcher we have in our groups in Thessaloniki for the last 3 years now, in one of her previous studies, they found that in wild-type animals, where we may induce the MG, by the time these animals are treated with a C6 inhibitor, these animals may exhibit a better outcome with regard to grip strength. This is the test that we perform in experimental myasthenia gravis, thus again indicating the important role of the complement in MG. Let's go now to, we're still in the periphery, and just this slide only for Guillain-Barré syndrome, which is an autoimmune polyneuropathy, polyradiculopathy, and we can see that all day, 3 days after the initiation of symptoms, there are already deposits of complement in around the spinal roots, the axons in the spinal roots, and here we can see that 8 days later, this deposit is even more evident and massive. And now we are going to the central nervous system, and I would like from the very beginning to say that complement is a very important factor during development. We all know that in the central nervous system, similarly to the neuromuscular junction, there is an excessive of synapses. We are born with an excessive of synapses. So not all of these synapses are important, and our body has mechanisms in order to eliminate and delete some of these synapses, and it seems that in these otherwise very normal process, the complement is very much involved. How? It is expressed on synapses, particularly those who exhibit low activity. They may express factors of the complement, and there goes the microglia with the receptor it has on his surface of the CR3 receptor, and simply destroys and eats, phagocytoses the synapses. However, after, not only during development, but also during pathology, here is an example for schizophrenia, it has been found that this complement is expressed in the synapses who normally remained in the central nervous system, and again, this triggers the microglia to go and phagocytose these synapses. In multiple sclerosis, where we have identified four different pathological hallmarks for this disease, it was found that in the pattern 2, T cells and complement are present, and it was found that 58% of the biopsied MS patients have in their lesions the complement activation, and how complement acts in these patients, again, from a more recent publication by Mihailidou, while she was in the Netherlands working on the complement, it was found that in multiple sclerosis, as we can see here, this is from autopsy, human autopsy, we can see the activation, and here is schematically being seen, the activation of the C3b factor of the complement on the synapse, and again, microglia goes and identifies the C3b via its receptor, the CR3, and of course, finally destroys the synapse. And we know that in multiple sclerosis, we have a massive synaptopathy, and this is really something very, very important for the ongoing process of the disease, and symptoms like disability progression or even cognitive dysfunction. And it is not only the synapses, it was found that in multiple sclerosis, again, that complement may also be activated along the axon. We know that in multiple sclerosis we have axonopathy and destroy of axon. It seems that the complement is a key factor for the ongoing axonopathy and the axons that are phagocytosed as well by microglia. What is really very impressive is the following. It is that the neural cells themselves express complement factors. This is not probably due to the complement that comes from the periphery. For some reason, and particularly in chronic MS, the neural cells themselves, and here we can see very nicely a neuron where the C3 factor of complement is expressed. This is done here with in situ hybridization. And from some anecdotal findings in our laboratory, as you can see here again in human autopsies, we found that there is a massive expression of C3, C3d, in other words, complement in the neurons and some other cells, which seem to be astrocytes, contrary to the normal people, to controls. And what was also very nicely seen here, as you can see among the same experiments we performed in Thessaloniki, is the expression of the complement compounds, complement components along the dendrites of the neurons that were being identified in cortical MS lesions. And last but not least, also in the experimental model of autoimmune encephalomyelitis, it is pretty clear that there is an expression of several components of the complement throughout the disease process during the acute phase and also during the chronic phase. And I'm going straight to the NMOSD, another immune-mediated, clearly autoimmune disorder of the central nervous system, which resembles, up to a point, multiple sclerosis. And there it has been found that the underlying pathology is the one that is illustrated here. Antibodies against aquaporin 4. Aquaporin 4 is a channel for water in the central nervous system, and particularly in the astrocytes. Goes there to the astrocytes, identifies the aquaporin 4 that is expressed on the astrocytes, and there it invites the complement, and this leads to a destruction of the astrocyte. And this process further retracts and invites other inflammatory cells like neutrophils and eosinophils in the central nervous system. And finally, this leads to the dying of the astrocytes, but also to oligodendrocytes, thus inducing a secondary demyelination. And here are some nice experimental in vitro studies indicating that indeed these factors of the complement may lead to lysis of the astrocytes in vitro. Very briefly, for ALS, it has been identified the expression of complement factors both along the the axons, but also on the end plates at the neuromuscular junction, thus introducing a mechanism that might be involved in the destruction that takes place in the neuromuscular junction and the neurons in these patients. Similarly, in Alzheimer's disease, it has been found that, again, the complement may be activated and contribute to the synaptic pruning in these patients. And finally, in the traumatic brain injury, it was found that particularly among the neurons that are at the penumbra of the injury, there is a full expression of complements on the neurons, on the cytoplasm of neurons, thus again indicating that probably complement might be a target to save these neurons also in persons that have been traumatized previously in their brain. And all these data I presented you briefly are the reason that currently there is really a huge interest with regard to the treatment in several neurological conditions where monoclonal antibodies against complement are used. And for example, I may tell you, because this is something we already use in neurology, there is an anti-C5 monoclonal antibody that we use particularly in NMOSD patients, and there is a 100% response to this treatment, which is amazing for these people, taking into consideration that we need to help them and try to protect them for future relapses from this disease. And I would like to end here by thanking all my colleagues in the group we have in the Multiple Sclerosis Center in Thessaloniki and the Laboratory of Neuroimmunology and Experimental Neurology. And of course, some of these issues will be further discussed during the annual meeting we're going to have, the meeting of the Hellenic Academy of Neuroimmunology, again in Thessaloniki. Thank you very much for your attention.
Thank you, Professor, for this excellent presentation. A number of functional polymorphisms in the complement system have been associated with a number of neurological diseases in the past. Has there any genetic component associated with this hyperactivation of the complement system in these diseases?
As far as I know, there are no similar studies, particularly for these diseases, because it is already, I mean, it was a big surprise, the fact that the CNS itself is a source, because we know normally complement is produced in the liver, right? Mm-hmm. It was really an extraordinary surprise to see that for some reason the cells themselves express these complements. So I don't really know, because it's something new, but anyway, I'm not aware of any GWAS or correlation studies or whatever we may call it. I'm not a geneticist, so forgive me if I use wrongly any terminology, but as far as I know, no, there are no similar studies.
Thank you. We have time for one question, maybe?
So, Nikos, wonderful presentation. And I think that you bring, as you always done, another series of thinking and hypotheses on the strong neuroinflammatory component of all neurodegenerative diseases, actually.
Yeah.
Any clues what will be the cause or the damaging factor which will induce complement components in neurons and other, supporting cells of neural tissue?
You mean if there are any factors we may...
Right,
okay.
yes. That could be potential, etiological factors for these diseases.
I really don't know. There are many speculations we may do. For the time being, we have the ability in some cases, by using these monoclonal antibodies, for example, to block the complement activation. But the important thing is here we need to consider two factors. First, the ability of these monoclonal antibodies to enter the CNS and block the complement within the CNS, although it is already very useful, the fact that they may block complement at the periphery. And the second is we don't really know whether these monoclonal antibodies we have so far, not only for NMOSD or MG, but for other diseases as well, whether they will be able to block the complement that is expressed endogenously by the neurons. So there, I'm afraid, in order to have better administration tools, we probably may need to use your expertise, Professor Gravanis, and the tools you are able to develop for intra-CNS administration of anything we would like to deliver there.
Thank you.
Thank you very much,
Professor Grigoriadis. And we share with you the condolences for the loss of Alexandros. It is my great pleasure to introduce our next distinguished speaker, Professor Dr. Stylianos Antonaragis. A long CV, which I will not repeat, of course, but you can all read through PubMed and in the conference book. Professor Antonaragis is a globally respected geneticist, a professor of genetic medicine at the University of Geneva. His groundbreaking contributions have shaped our understanding of the genetics of complex disorders and the interplay between mutations, variability, and environmental factors in disease pathogenesis. With an illustrious career dedicated to elucidating the nuances of genetic determinism, he has been a pioneer in genomics and personalized medicine, and he still is. We are very privileged to invite him to deliver his lecture today on the determinism of genetic disorders, mutation, variability, and environment. Thank you, Professor Antonaragis, for accepting the invitation.
I thank you very much for the very generous introduction. And I will talk to you, as you said, about that topic that I gave a slightly different title, Genomic Individuality and Phenotypes, because I want to talk to you about penetrance. And for the peace of mind of the next distinguished speaker, when I reach 00, I will stop. Now, I thank very much also the organizers, Professors Patrikios and his colleagues. And let me talk to you a little bit about penetrance. What is penetrance, which is one of the most important problems in genetics today, and I think it will take us perhaps 1 or 2 decades to understand this phenomenon of penetrance. Penetrance is
the fraction of individuals with a phenotype, given that they have a mutation in the genome, a particular genotype, a particular variant. And you see that illustrated here. There are 20 individuals. All 20 have this red blob, and the red blob means that they have a pathogenic variant in a gene, but not all of them have a phenotype, and the phenotype that you see here is an abnormal external ear. So 40% of individuals develop the phenotype in this particular scheme, and 60% of individuals, they did not develop. And the question is, why is that? The syndromes that give us most insights into this are the developmental syndromes. And using the developmental syndromes, we have a Mendelian entry into a complex genetic process and, most importantly, the causes of penetrance. And quite recently, decided to work a little bit on a developmental syndrome that not many people work, the abnormalities of the external ear, which is very easy to diagnose and quite difficult, actually, to decipher the molecular mechanism that give you this particular phenotype. The decision to work on this syndrome is also because this gentleman that you see on your screen, Maurice Goldenhar, was an intern in pediatrics in Geneva in 1951 and 1952. And at that time, he described that syndrome that has his name now, the Goldenhar syndrome, that has abnormalities of the external ear and the internal ear, and abnormalities of one half of the face. It is called microtia, hemifacial microsomia, craniofacial microsomia, etc. And he published this in a paper in 1952 without his mentor, Professor Klein, who was my predecessor in the genetics chair in Geneva. So how to make an ear? And what is the complex etiology of developmental abnormalities? And I like to thank my collaborators, especially the first two that you see here, Yongbiao Zhang and Mao Kei from the University of Beijing. We studied 670 cases of craniofacial microsomia, or Goldenhar syndrome, from all these countries that you see in your screen. And the first entry into a gene that causes this phenotype was using this Pakistani pedigree that has a recessive form of a microtia, small ear. It is a recessive form. You see the two affected individuals as black circles, and the parents are first cousins. And you see the microtia, in the top part of the figure. Okay, here. So you see the two affected individuals. Yes, I have it. And then you see all the other members of the family, they have normal ears. The gene that was identified was a transcription factor, FOXI3, and the variant is an amino acid substitution, phenylalanine 234 to leucine. A classical recessive phenotype in this particular family. The father and the mother, who are carriers, do not, they have normal external ears, and all the brothers and sisters that are heterozygous, they also have abnormal ears. So we thought, bingo, we have a new recessive disorder. However, there was a large Chinese family with a dominant form of this particular disorder. You see all these individuals shown in black in different successive generations, a classical dominant inheritance in which the gene responsible was also FOXI3. The mutation was a different amino acid substitution, arginine to tryptophan. And the important thing here is the reduced penetrance. In other words, there are individuals with the variant, with that particular mutation in that gene, that have abnormal ears, microtia here, 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 there. But there are other individuals with the mutation that had normal ears, nearly normal ears. So in this pedigree, the mode of inheritance is dominant with reduced penetrance. And we're asking the question why some people develop normal ears with a variant, and some people develop abnormal ears, or they don't develop normal ears with that variant. FOXI3 is a variant, a gene that causes a minority of microtia, like 3.1%, but that it doesn't matter. What matters is that we now have a gene that gives you that phenotype, and we can study the penetrance. Here's the spectrum of the variants within the linear showing of the protein. Functional analysis of the variants. I will not bother you with this. The hypothesis, the first hypothesis that we have is that since each one of us has two FOXI3 alleles, these individuals have one particular variant in one allele and a so-called normal second allele. So we thought that perhaps the nature of the so-called normal allele is important in penetrance. And we're lucky to identify a family from the literature, this particular family from Genova, Italy, with this microtia, in which there was a deletion, a large deletion of about 2 million base pairs, 2 megabases of worth of DNA that included the FOXI3 gene. And the deletion, shown here schematically, is present in the affected individual and in the father. But the father was normal. And the main difference between these two individuals, the father and the child, is the nature of the second allele of FOXI3, because the second allele of the affected individual comes from mom. So they're not identical in the composition of the FOXI3 variants. So they both have a mutation, but the second allele is different. We sequence that second allele, and the nature of that second allele that is present in the affected individual has a compilation of variation. The variation that it has causes, not causes, we call this the haplotype. It is a concept that was first introduced with the HLA system and the beta globin system, that the sequence of variants in a particular chromosome we call a haplotype. So that haplotype of the second trans, let me call it trans allele of the FOXI3 mutation, has all these variants that you see in this particular, this particular slide. All these variants, normal variants, common variants, with two linkers disequilibrium blocks. That's for the aficionados. For simplicity, let's call it blue, the blue allele. The blue allele in you and I of European extraction, is approximately 12%, 13% of the population of Europeans. They have that normal allele. And in Chinese individuals, about 20% of 1 in 5 individuals in the population have that allele. And yet, the nature of the second allele determines the presence or the absence of the phenotype given a bad mutation in one copy, one allele of the FOXI3 gene, as exemplified by this family. You see a father and a mother, three siblings. One is affected, that female. The affected female has a mutation, a bad variant in FOXI3 gene, an arginine 242C, to cysteine. This mutation is present in the two of her brothers, and it's coming from the father. But father, brother number 1 and brother number 2, they have normal external ears, as you see in the figure down there. What is interesting is that the affected individual inherited the blue haplotype from the mother of the normal FOXI3 allele, while the other 3 individuals, father, brother number 1 and brother number 2, they inherited different haplotypes, not the blue one. And hypothesis that becomes now more plausible is that the presence of the second allele is very important for the presence of the phenotype. If you take all the individuals with variants in FOXI3 gene and microtia, most of them contain the blue haplotype, as you see in your scheme there, as a second allele. And the statistics, you do any massaging of the statistics, you come down with 10 to minus 5 probability of this being, not by chance, in 37 individuals. If you put some of the variants in mice, you see in the far right of your scheme that the mice develop also hemifacial microsomia. You see the abnormal shape of the mouth over there that's developed very well in the one half and not very well in the other half. And plus, if you're an aficionado of the mouse, you can see several abnormalities in the bones, but I will not go into this. So the hypothesis now, or the conclusion, if you have on top both genes affected, both alleles affected, then you have a disorder likely to be recessive. If you have one bad variant on one allele and the blue haplotype on the other allele, you have a severe microtia. But if you have the variant in number 4 in one allele and a non-blue haplotype in the other, you don't develop the phenotype. The question is, what common variability in the population is the one that gives you that difference in the penetrance? And the most probable hypothesis is that if you have a polymorphic site in one of the enhancers, we call this EQTL in our lingo, and let's say you have a G, that G in that enhancer gives you a lot of transcripts of the gene, while if you have a T, it gives you much less transcripts. That's very difficult to study in the FOXI3 because FOXI3 is expressed in a very small window in the development. In the mouse development, it expresses for about 9 hours, and then it shuts down. And these 9 hours in the embryology of the mouse are enough to make a normal ear. So we're studying this in the mouse, but we don't have yet identified the exact variant in an enhancer. I will continue with a parallel or very similar story. FOXI3 transcription factor is not the only factor that makes an abnormal, that makes an ear. Let me talk to you about a second gene that's called SHROOM3. We studied with my collaborators in China 2,500 normal Chinese individuals, Han Chinese, and 2009 individuals with microtia. Numbers are important in these particular studies. And using a burden test, in other words, how many variants you see in one group and how many variants you see in the other group, the gene that comes up, the most interesting and important is this SHROOM3. Now, because we have large databases, we can see a lot of variants in normal individuals and a lot of variants in affected individuals. And then the question is which ones are really important. And I give you the conclusion of this. Here, there are 2 pathogenic variants, very pathogenic by experiments and by prediction. They were related to normal development because there was a low expression EQTL nearby. Another group of variants, very severe, very important. They give you a hemifacial microsomia because nearby in an enhancer, there was a variation that gave you a high expression. This enhancer we know, and that explains all the difference, all the penetrance in the phenotype. And with this, I will finish. Dr. Frakoviev will not take your time. The conclusions are that rare, pathogenic, and common variants determine the penetrance of the phenotype. The gene expression variation is important for the phenotypic variation, and variation in enhancers may be crucial for genetic medicine, and there's a lot of attention now in the thousands and thousands and thousands of enhancers of genes, especially developmentally related genes. With this, I thank you very much.
There are questions?
In genetic topics. Sorry, because you've got a bird's eye perspective on many of these genetic topics because of your involvement in so many different projects. So what would be your advice now, given that you show this isoallele, of course it's also, I think, in retinitis pigmentosa and some other diseases, you also have this kind of effect, where the variant curation expert panels of ClinGen, they're kind of cursed with the ACMG, AMP criteria, which are between pathogenic and benign. And this is actually further down the spectrum. It's almost therapeutic. And then, of course, these criteria do not even take into consideration the severity of mutations. So if you were to point the path forward for how to annotate variants, which is now critical for next-generation sequencing and which is in all the software and it's really required. So what would be your advice on how to deal with this and how to make these annotations more informative?
Yes. Well, that's a very important question diagnostically and therapeutically. Of course, the American College of Medical Genetics criteria are for variants in the coding regions and not regulatory variants. But as you can imagine, for developmental abnormalities and many other abnormalities that are Mendelian, and there's a penetrance issue, an annotation of the regulatory landscape of the genome for these genes is very important, and we'll come into this with time and with the knowledge of the grammar, of the rules, of the enhancers. Enhanceropathies are probably quite common in genetics. The developmental abnormalities give us a handle, but also we expect that common complex phenotypes are also due to enhancer problems. There the problem is much more complex, because if there are a few genes involved, not many, but oligogenic, and each one of these genes involved has 20 or 30 enhancers for different expression in different tissues, then the focus on enhancers will probably give us a lot of answers for the presence or absence of a disease given a genotype. However, the identity of the other allele is not the only mechanism for penetrance. There are many. I can name to you 7 additional molecular mechanisms that contribute to the penetrance. That's a complex issue. However, as I said in the beginning, that's my belief that the complexity of the phenotypes is not only due to the bad, rare, high-impact pathogenic variants in the coding region of the genes.
Any other questions? If I may ask, Professor Andonaragis, we do have a number of families with Goldenhar syndrome or hemifacial microsomia who are not molecularly characterized. We do use nowadays trio exome sequencing to use more detailed weapons, and it is a difficult group of patients in Cyprus. Also, one of the most difficult parts is the everyday medical genetics service of genetic counseling, where you have to explain, in the absence of a detailed molecular mechanism and diagnosis, also the variability, the possible variability in penetrance. Do you think that we will be able to have solutions or guidelines for this type of families and their genetic counseling challenges in prenatal?
Absolutely. As you say, as you're implying, the more we know, the better we do our diagnostic evaluation and the counseling. Now most people are working on the coding fraction of the genome. The penetrance issue is important mostly in the dominant disorders. And the more we know, the more we become more granular in the analysis. Now, if in hemifacial microsomia specifically that you asked in the beginning, we know of 3 genes that explain only about 10% of the phenotype. So we'll identify many more, as expected, of course, because developmental abnormalities, they involve tens of transcription factors in the different stages of development, and each one contributes at the end. However, when we know all the modifying factors in cis, the enhancers, or in transcription factors that control transcription factors, then we have a better idea of the diagnosis. And some people think that by modifying enhancers and not the specific variant in the gene, we may have successful treatments that are not specific to the variants in the culprit gene, but to the regulation of it. Thank you.
As we continue with the Neurology Session 9, we welcome Dr. Marios Pantantzaris and Dr. Nicholas Grigoriadis to the stage as chairs.
Well, it seems that I will be alone. I don't know where Nicholas is. Anyway, I have the CV. Okay, so we proceed to the next session and the next speaker, which is Dr. Richard Frakowiak, and his distinguished doctor that he's dealing with cognitive functions and human project at UCL, and he's going to give us a talk about what the future is promising to us about the clinical neuroscience and the research on that topic. Thank you very much.
Thank you very much, and thank you for the invitation. I won't name everyone. It's very dangerous to prognosticate, as we have recognized last Tuesday. But on the other hand, it's also very important to prognosticate, because otherwise you're stuck in one way of thinking. So that the process is a virtuous circle which involves destruction of hypotheses. I'm going to talk today about the future. So do please attack me as much as you can. And I'm going to talk about clinical neuroscience in particular. Now, I need to know how to advance. Good. This was the situation in 2010, and I can tell you it's much more complicated now, of the amount of neuroscience data we have. Resolution along the y-axis, types of studies and types of models along the x-axis, each investigated to a high degree of precision and very few of them interacting with each other. And this is our problem. So the question is, can we help? Well, we can get to the human. There are always questions about rat models and mouse models and how effective and efficient they are. In the human, we have had non-invasive human brain modeling, imaging, and that has been very helpful. But it is simply at the mesoscopic level. But there is a nice thing happening over the last 5 years. It is becoming quantitative, something that used to happen with PET scanning, but it involved radiation. It could be repeated in anatomical terms as densities, but now we can actually measure things like water content, myelin content, regionally within the human brain. So one way is to improve our technology, and this is essentially the American way, getting more and more specific, better and better resolution, and so on. But our task is to understand the brain in its totality, the multi-scale brain, going from the molecule, a little piece of DNA, all the way up to cognition, and trying to bring together all the information we already have and knowing which gaps we have and where we need to target our future research. So, this has been attempted by the laboratory of my friend and close colleague, Henry Markram at the EPFL, where he has understood that many people in engineering don't generate hypotheses, collect data, and reach conclusions, but they collect a lot of data, work out how, at one level of resolution, the different components work, so get the rules of the game that we've just been talking about, and then move up the system, which is now being constrained in its degrees of freedom, because at each level, if you know the rules, you are limited in how the next level can work. So I'll illustrate that with a slide that he's lent me. As you know, we've been looking for mathematical expressions of rules in neurology since 1948 with the Nobel Prize of the people who looked at the transmission of signals rapidly across the axon. These were the Huxley-Hodgkin equations. There are a lot of such models already developed for ion channels. There are many such models developed for synapses. In addition, we have masses of information about how different neurons are distributed in the cortical columns. We have a lot of information dating from work done mainly in Russia and in France in the 30s, 40s, still in the literature, about which neurons connect to which neurons at which level, and now with the amazing work going on in Seattle, we're getting really precise information about where different neurons are and how they connect. So the question then is, can we predict how the next level will work? And this has been done for pairs of different types of neurons. So on the blue side of this, you see what is found, and on the red side, you see the modeling result, so that you're trying to compare the model's function, in this case an anatomical function, with what you find in the validating anatomy. This can be done also for functionality by introducing a current into a model. You can show in vitro on the left side, in silico on the right side of the lower panel, and you can show how nicely they compare each other, either as multiple trains of impulses or single impulses, and even the whole disynaptic inhibition system. So this is the theory behind how to go about things. The development of models at different levels of organization that are driven by data and the technology of simulation, a technology which has been used by engineers for at least 40, 50 years, and which are involved in building cars and airplanes and everything. These models are mathematically expressed, and these models then have to be biologically validated. So, this is the sort of result. This has just been published in Cell Biology. It is a simulated mouse cortex with all the neurons involved in a rat. And that's all I can tell you about it because the paper's just come out in Current Biology. But the essence of the technology is that you could now interrupt mathematically this model and see what the effects were on the rest of it. So let's get back to the human. The human at the moment doing neurology is about 140 years old. He taps reflexes, he looks into eyes, he scratches the sole of the foot. And he provides a pattern of abnormalities, and he calls this a disease. Of course, this isn't a disease, as she would have showed him in the first place. It's a syndrome. So the syndrome has now reached its limits. We've just heard how different phenomenologies come from the same genetic abnormalities, or same phenomenology may be caused by multiple genetic abnormalities. So the Human Genome Project, which has been so influential, as has been described by Professor Antonarakis, is a constituent element of organic matter, but it does not provide us with a lock and key answer to understanding human disease. Modern science, I've shown you, is fragmentary and atheoretic and can run down blind alleys like the amyloid situation we discussed previously. Modern clinical neuroscience, as again I showed you, is becoming increasingly sophisticated, and modern information technology and modern mathematics have their own problems, not least of which is the physical and energetic constraints of doing modern information technology. As you know, people like Amazon and others are building their own or buying nuclear power stations in order to generate the power that is needed at the computational level in order to generate these sorts of models. But in the end, what we must be hunting for is mechanical, biological diagnoses, as has just been stated as well, so that we can then know what we have to fix. Now, the question in neurology is, do data exist that permit such mechanistic diagnoses already? And the answer I'm going to suggest is yes, and that these data are distributed in all the hospitals, clinical laboratories, fundamental laboratories in the neurosciences in the world. The question is, how can we use them? And Google has shown us how we can use them. This is not to put them in large warehouses and to put them in a specific way and to curate them and to make them all the same, but to solve that problem by using all the data, because then the signals would come out from the noise, and that is done by adressage, addressing the sum of all the data. So this is the radical concept here, which is that you need to be able to address data with your question, not you need to be able to create a warehouse which is highly stratified in order to then think about what questions you're going to ask. So the other interesting thing about addressing all the data is that there are now algorithms available that can mine the data. And by mining, we mean look for all the possible correlations and, more importantly, the interactions between those data with a statistical assessment of how well the ensuing models explain those data. So this raises the issue of whether the data can actually function also as hypothesis generators. Whereas the first is a question of having a hypothesis and addressing the data in order to see how to answer your question. And the question, I believe, that is going to be here for the younger people amongst you is to say to yourselves, we are fed up with this Bible of syndromes, which is mainly used for getting payment for your activity, which is called DSM-4, into a true Bible of disease signatures. What do I mean by a disease signature? A disease signature is a constellation of biological, physical, physiological, electrophysiological imaging data in humans, which are common to certain sets of humans, so that we can then use those commonalities to go back to the doctor and say, are these people expressing the same diseases as syndromes, or is there a wide range of their expressions, which is what I suspect will be necessary. And that will be done in the very near future with artificial intelligence, and specifically with artificial general intelligence, because we will be able to address with much greater precision and variability. Now, we already know that informatics integrate a lot of data. This is a half day's work by a postdoc 10 years ago. What's that? Oh yeah, sitting on a desk, addressing the National Library of Science in Bethesda, and interested in what he wanted to image in Parkinson's disease, because he knew that the subthalamic nucleus had one particular target, and that connection was the one that gave him Parkinson's disease. But he also knew that Parkinson's disease was rather heterogeneous syndrome. And so he just asked, of all the literature that was there, to bring out and give a picture of the connections that those two, and as you can see, the connections are multiform. There are hundreds of them, both afferent and efferent to different parts of cortex, as well as to the basal ganglia, from subthalamic nucleus, and also to the basal ganglia, back to the subthalamic nucleus and around. So this is the complexity we have to deal with, and we cannot do this purely by imagination. It's too complex. The other thing we could do is to classify patients already with informatics, simple informatics. So this is the first example of artificial intelligence, which I published in 2007, on trying to discover how can one find Alzheimer's disease before death. Now, if you make a diagnosis of Alzheimer's disease and take people to post-mortem, the neuropathologist shows you are wrong in 30% of cases, even in the very best centers. So we have to understand that there are people with dementia who don't have Alzheimer's disease. We've already discussed that. So at the top here, you have the best possible article that I could find, with a correct diagnosis of Alzheimer's of 81%, 61% sensitivity, 93% specificity. We trained a support vector machine, which is a type of artificial intelligence, with images from friends of mine in the world who had patients who had had MRI scans with a diagnosis of Alzheimer's or with a diagnosis of complete normality, who died with those diagnoses and who would send me their scans. After the neuropathologists had said, yes, this is real Alzheimer's disease, yes, this is real normality. This is not just normality which is pre-Alzheimer's, it's normal normality. And of course we found 4 groups: Alzheimer's that had Alzheimer's pathology, Alzheimer's that wasn't Alzheimer's, normal that was truly normal, and normal that had the changes of Alzheimer's preclinically. And the results from these binary classifications are shown at the bottom, 95% in all cases. Now, the line I show here is a great simplification. It's 2 dimensions. We're dealing here with multiple dimensions, tens of dimensions, who knows how many dimensions, but so that these mathematical boundaries are complex and cannot be visualized. So we need informatics. So now you'll say to me, well, how much data do we have? Well, we have all the hospital databases in the world. We know we can do this because Netflix does this every night. Moves data there, it goes to there, sends it here, there, everywhere. Very quickly, you just press a button and it's there. These hospital databases are not complete, not structured, not standardized, not clean. That's fine. We're dealing with vast amounts of data if we do this. We can protect for privacy. It's not protected against corruption, so we have to protect against corruption. But hospitals have engineers who do this. Every hospital has a data security setup. We also have research databases. That's our databases. We protect these culturally because we think our database is going to win the Nobel Prize. A database has never won the Nobel Prize. It's your intelligence in questions. So we need to get with it, stop all this shutting off the databases. Open them up, put them on the web, and let's get on with it. And you use other people's data, they use your data. This is our duty. Get real. And then the final ones are the pharmaceutical databases. Well, people say he's mad. So I went to see the CEO of Sanofi. And I said, I want your databases. And he said, you're mad. I said, no. I said, what percentage of your double-blind clinical trials are positive? Oh, about 3 to 5%. I said, can I have all the rest? Oh, I see what you mean. So even they are, and they have really very well-structured databases. So at one stage, I had 5 big hospitals throughout Europe, all linked up and all doing this sort of thing. And then I retired and there was no funding, and this is all to be done by people who are a lot more savvy about informatics than I am. And the hospital management were the main supporters because they already had security procedures. Every day in real time, they produced archives off-site to protect their data. And all we wanted was to have our own off-site archive server where we could pre-process all the data, the neuroscience data, by denoising, standardizing, anatomically normalizing, numerically normalizing, and creating a database which could be addressed by the investigator outside the hospital. And if he addressed all the hospitals in the world with the question, do women of the age of 30 compared to the women of the age of 40 at sea level or at 1,000 meters have more or less multiple sclerosis in the spring and the summer? That would be an address. You would send that, and locally they would find the data which was needed for you. Locally they would aggregate it so it becomes not break-intable, and then they would send it out to a unified portal, which we had already built as well, which would then aggregate it a second time, guaranteeing secrecy for the individual, and generate an answer, and an answer which was for the population as a whole, which a doctor could then, when seeing a patient, say, this is what you've got. Do you mind if I send it to find out whether it corresponds with any result that is online? So the doctor remains in power, the hospital remains safe, the hospital management can ask questions about which diseases when in the year, so that they can organize their buying of equipment and opening beds and all this sort of thing. And this gives you a whole series of results which can then be removed, whereas the prevalence can be stored, and so that you can get back to what you want. Now, let me just give you one example to show you that this works. 6,000 normals on Alzheimer's, completely random data from 3 French cohorts, with all sorts of data, including proteins in the CSF, genetics, not in everyone by any means, because you can interpolate if you have enough data. And we went through 3 types of analysis of this: a phenotype-led, semi-supervised clustering, a cluster analysis. This is data mining. We've heard about the dangers of phenotypes. A biologically led classification, where we know how we are working still hard at understanding the biology, or deep learning. You remember this is the DeepMind technology which won the Nobel Prize this year with Demis Hassabis. And this is one result, right? We started off with all the people in the cohort who appeared to be normal. And we found that a proportion had the pathology of Alzheimer's disease in blue, and the rest had another pathology, or were completely normal. And then we followed them in time. And those who had the pathology of real Alzheimer's disease have a completely different prognosis to those that don't have the pathology of Alzheimer's disease, but who can be demented for other reasons. And this difference is bigger than the difference between ApoE4 homozygotes. So, data mining to provide disease signatures. Just watch that big pink circle. That's all the patients with dementia, and they're associated with a beta, they're associated with a pattern of imaging. These are the various types of data that we've been looking at. There are normal people who have different, they're in blue, who are at different ages, and who also have dementias of other types. This type of thing is what we're looking for with data mining. So, I finished. Thank you very much.
Thank you. So thank you very much for this interesting and very complicated data that you have presented.
Well, you won't do it. It's the younger people who understand.
Yeah, okay.
You have to be a non-professor to understand this.
Is there any question from the audience?
Come on, younger people, where's your question? Yes,
Yes,
no,
Professor.
you're not young.
Okay.
Is there a younger person here with a question? Oh, this is the European Medical School. Is it high quality? Come on. What about him? He's looking away because he doesn't want to ask his question. Yeah, come on then. He needs a microphone.
Okay, at the start you said that we're still at the beginning of all of this. Where do you see it going in the next, let's say, 20 years?
No, I'm not hearing you.
At the start, you said we're still in the beginning of this, of the procedures. Where do you see it going in the next, let's say, 20, 30 years?
Well, I think, so that was my question. Well, say it again, because I'd still not quite heard it.
How do you feel time would involve to have all this way of thinking applicable in the clinical setup?
Oh, well, this was going to be my last, oh, it's gone. It was going to be my last slide. You have to stop doing things the way your seniors do it. Now, forget syndromes, except for exams, and because it will help you give current treatments. Instruct yourself or find collaborators who are real experts at informatics, and experts who are now appearing who are real experts at artificial intelligence techniques, which are they're just sophisticated statistics in multi-dimensions. And then finally, find something that you want to know the answer to. And get yourself involved with a university which has, or a country which has computing facilities, but that will soon not be important. We started off wanting supercomputers in Europe, and we got 3 or 4 of them lined up. But 4 years into the project, we realized for much cheaper, we could just hire Amazon time. So things are moving very fast. I think from the point of view of the bosses, what you need to get them to do is to start introducing this culture of open science so that you can talk to people around the world who are thinking about the same things as you, and so that you could create networks to begin to do them. And the other thing the bosses need to do is to start talking amongst each other about how to sort out this problem of creating a health Google for the world. Now, Europe had that chance. It didn't see the vision, and it gave up on it. It needs people with a bit of seniority and a lot of oomph to put together another program to go to Europe and to say, look, we really need to do this. Because not only if we know it works, but not only, you've got to scale it, so we don't know if it scales. We know it scales to 5. Does it scale to the world? Well, I gave you some reasons why I think it does. I mean, you just need to think of telephony. Even telephony tells you that can be done. So you really need to go back to them and say, hey guys, you need to get wise.
Well, thank you very much.
Pleasure.
And thank you.
We would now like to invite Professor Ioannis Patrikis for him to introduce our distinguished guests.
Good afternoon, everybody. I'm going to introduce our honorary keynote speaker, Thomas Sudhoff. Thomas Christian Sudhoff obtained his MD and doctorate degree from the University of Cologne in 1982. He performed his doctoral thesis work at the Max Planck Institute, and he began his independent career as an assistant professor at UT Southwestern in 1986. Sudhoff's work increasingly turned to the analysis of synapse formation and specification, processes that mediate the initial assembly of synapses, regulate their maintenance and elimination, and determine their properties. Should have served on the faculty of UT Southwestern Dallas until 2008. And then became the Avram Goldstein Professor in the School of Medicine at Stanford University. In 2013, he was awarded the Nobel Prize in Physiology of Medicine, together with the two US-American biochemists, James Rothman and Randy Shegman, for the discovery of the vesicle trafficking. The lecture title is two words, understanding synapse formation. Professor, the stage is yours.
Okay. Thank you. Good afternoon, everybody. Thank you for this kind introduction. I've never been on a stage like this. Thankfully, I took on my red shoes today. Otherwise, I'd be completely misplaced here. So it's a wonderful occasion to be here. This is the wrong, okay. Let's start at the beginning. So I changed my title a bit because I wanted to tell you, in a better fit with the theme of this meeting, about our attempts to try to connect molecules to an overall behavior, an organismic function, memory. What I'm going to tell you about today is going to be rather detailed, because that's how we do things. I'm going to tell you about some real experiments that we are performing, whose analysis or interpretation is not always totally clear. In my presentation today, I may lose you, but don't despair. I'll try to catch up with you, or give you an opportunity to catch up later on, because some of the data that I'll present may be foreign to you. The concepts that I'm going to talk about are concepts of modern neuroscience, where we are at this point in trying to understand the brain, using a variety of approaches, ranging from molecular analysis to behavioral studies. In neuroscience, there's a general discussion always on what is the best approach. You've just heard, for example, in biomedical research, that there's an increasing emphasis on data mining, which is very useful to some extent. Other people believe that we need to study the brain as a black box, because it's so impossibly complex that we'll never understand it anyway. A bit of a pessimistic view. Others, on the other hand, are more interested in single molecules, channels, or specific neurons somewhere in the brain. Despite all these different views, perspectives, I think everybody in neuroscience will agree that there's a unifying concept, very vague, in the idea of the neural circuit. And so neural circuits, as illustrated here very schematically, are in many ways the starting point that people use to actually discuss how the brain might work. Neural circuits are formed by synapses that connect neurons into networks. The idea of neural circuits in some way ignores the fact that there's other types of cells in the brain that are just as important. Without them, the brain doesn't work either. Synapses transfer the information from one neuron to the next in the brain, but they also change that information. They're the fundamental computational unit. They change this information by transforming a given spike code in a presynaptic neuron in a differential postsynaptic response. They have amazing properties that we and others have been studying for decades. The major goal of our lab at this point is to try to understand how neural circuits are constructed, how they are formed by the interaction of neurons with each other. And when you look at a synapse, it is fundamentally an intercellular junction between a pre- and a postsynaptic neuron. As an intercellular junction, it is presumably formed by the interactions between pre- and postsynaptic surface molecules that are referred to as cell adhesion molecules, even though the major function of these molecules is not to adhere, but to signal. Many synaptic adhesion molecules are described, some of which are shown schematically on this slide here. You don't need to read all this. It's just a colorful slide of different molecules. On the left side, it shows the presynaptic side. On the right side, it shows the postsynaptic side. You can immediately see that there's many more on this right side than on the left side, because on the left side and the presynaptic side, there are these hub molecules, such as the neurexins, that interact with a lot of postsynaptic molecules. What is apparent, however, from this description of all these transsynaptic interacting adhesion molecules, that these molecules themselves form networks. There's molecular networks, just like there are neural networks. And these molecular networks presumably guide synapse formation. How synapses are formed and specified, and which molecules are actually important, is unclear. And you can't use data mining to find this out because literature is all over. It doesn't tell you. So we and others have embarked on programs to systematically study this, to figure out how this works. And we've also tried to understand how these processes might control synapse dynamics in disease and in learning and memory. My talk today will be about learning and memory. It will be about trying to understand how synapses operate in learning and memory, which we don't actually know. You will read in textbook that synapses undergo long-term potentiation and that explains memory, but that's, I would say, at best a simplified version of what we know, at worst misleading. We are guided in trying to understand memory by a concept whereby memory acquisition, consolidation, storage, and retrieval are separate phases that likely involve many specific circuits and molecules, and that one can actually analyze this to some extent. We also hypothesize that although LTP as an explanation of memory may be too simplistic, overall synapses must be essential for understanding how memory might occur. Conceptually, we divide memory formation into a number of phases. Sensory inputs, for example, by learning, by seeing, by smelling, whatever, leads to memory acquisition. This memory is then either kept as a short-term memory or consolidated into a storage space to become long-term memory that can be recalled and reconsolidated during recall. This is a hypothetical and unproven diagram. Memory consolidation and storage have not been experimentally separated. And where and how memory is stored remains enigmatic, as does the nature of consolidation and reconsolidation, and many other questions surrounding this. Because memory likely involves synapses, transsynaptic adhesion complexes must be central to memory formation, and I already talked about this. And I just want to point out one particular complex here that is identified on the top that I'll come back to, because it turns out that we have evidence, not yet conclusive, that this complex is particularly important for one particular type of memory. So today's talk on memory circuits will suggest key roles for this complex, as I will describe to you in following. And this is shown here again in more detail. more later. Okay, so this is what I'm going to tell you. I'm first going to tell you about what type of memory we are studying, because this is a bit unusual. 99% of people who study memory study one particular memory, fear conditioning. We are the 1% or less than 1% that also study something else in addition to fear conditioning. And I will tell you two stories that illustrate two different first facets of memory, to just give you a feeling for what the complexities are, what the challenges are, and how much we understand, and also to illustrate how we in neuroscience now try to approach a complex problem that still is very, very unclear on how to address it. So I will first describe social transmission of food preference and then tell you about these two studies. Okay, so let me explain what social transmission of food preference is. This talk is about food. Not dinner yet, but anyway. And when we talk about food, most of the time we talk about what's good food and what's bad food and where to get good food and where to get bad food, or not to get bad food, right? So this is a very human thing, but mice do that too. They also tell each other about food. And the way this works is as follows. When you expose a mouse, a demonstrator mouse, to just plain food, and then you have it socially interact with an observer mouse, as shown here, and subsequently, outside, after the interaction, you give the observer mouse the choice between two different flavored foods, in this case cinnamon and cacao. The observer mouse generally will have a preference. They will like one type of food better than the other. As it turns out, at least at Stanford, observer mice, no matter what genetic strain, prefer cacao over cinnamon, as do I, by the way, just in case. That is the innate food preference. Now, if you then do a different experiment where you have the demonstrator mouse eat cinnamon-flavored food, then remove the food and then have it interact with an observer mouse. And you then give the observer mouse the choice. The preference is reversed. The demonstrator mouse tells the observer mouse in the social interaction that cinnamon food is just perfect to eat. It is the simultaneous olfactory and social stimulation in this interaction that causes this communication. Just to illustrate how this works, this is the innate food preference that I already mentioned. If we do social transmission of food preference training, STFP training, just as I explained it now, you can reverse this. And now cinnamon is preferred. This memory lasts for months. One interaction, the mouse will remember a month later what food is better, okay? Despite the fact that it would normally prefer cacao. It does require the social interaction because just having the mouse smell the cinnamon food doesn't work. Nor if you have a kind of a dummy, a mouse dummy that smells like cinnamon, doesn't work either. It really has to be a true social interaction. So the bottom line here is that STFP, social transmission of food preference memory, represents a one-trial appetitive, not aversive, learning paradigm. Very different from fear conditioning that many of us also use, which is aversive, also one-trial learning paradigm. And it involves an ecologically relevant behavior because mice presumably will also tell each other in the wild what food is good or bad. What I want to do now in the subsequent half hour or so, I don't know how much time I have, zero, is to tell you about our attempts to understand this. how we do this, and what we find. And I will tell you two very different stories. One that was published some years ago, one that was just published a couple of months ago, about our successes and failures in trying to understand this. So the first story has as a starting question, how is the sensory odor information initially processed during STFP memory formation when the mice get together in the social context? And we hypothesized, obviously, that the olfactory sensory organ, olfactory bulb, is involved, and that feedback connections between the olfactory bulb and target projection areas must be feeding back into the olfactory bulb during the process. And so we looked at the synaptic connections of the olfactory bulb. You may remember from your neuroanatomy, if you ever had it, that the olfactory bulb has a main olfactory bulb that contains all the olfactory sensory inputs, and it in addition has an accessory olfactory bulb that senses pheromones. The main olfactory bulb contains multiple regions that it projects to. These projections are mediated by projection neurons called mitral cells and tufted cells, and they form axons and synaptic connections with the piriform cortex as the primary sensory cortex, and with the anterior olfactory nucleus, as shown here. These connections are bidirectional. There's also a feedback coming back. In addition, there are other connections, including to the ventral hippocampus. Two major reciprocal connections are thus involved in processing information from the main olfactory bulb to the central part of the brain. And we became interested in the AON because, as I tried to tell you earlier, we're interested in trying to understand at the molecular level how synapses are built. And it turns out that the AON uniquely expresses very high levels of a synaptogenic molecule called C1QL3. So let me explain this a bit. I showed you this slide already earlier. C1QLs are secreted C1q domain proteins. They contain a domain that's called a C1q domain that's also in complement factors, C1. And the C1QLs bind to BIs, which are adhesion GPCRs on the postsynaptic membrane. Because these molecules form a complex, and we know from previous work that we performed that C1QLs are synaptogenic, we hypothesized that C1QLs in the AON might be involved in projections to the olfactory bulb, and thereby regulate in some manner olfactory behaviors. And we intended to figure this out. What you see here schematically is how this complex works based on crystal and cryo-EM structures that we obtained, demonstrating that you have a postsynaptic adhesion GPCR called BI, a presynaptic adhesion molecule called RTN4R, and the secreted C1QLs, and they all together form a complex that somehow has to do with something, with synapses. So this is the molecule that is highly expressed in the AON. Now let me go a little bit into how we actually do such experiments when we are trying to understand circuits. What you see here is an experiment where we are mapping, using retrograde tracing, the synaptic connections between two different brain regions. And specifically, as you can see here, we, in this case, injected a retrograde tracer, choletoxin B, into the olfactory bulb. And then we identified brain regions to which this retrograde tracer would be transported. And we measured the extent to which the retrograde transporter retrogradely transported tracer would overlap, in this case, with C1QR3 expression. And this shows on the top left the injection site in the olfactory bulb. And you can see that when we do this, we find out that it's highly transported to the piriform cortex and to the AON. E and F shows the piriform cortex, C and D shows the AON, and you can also see that in the AON there's total, complete overlap with C1QR3 expressing neurons. So this raised then the question, given that there's this overlap, whether the C1QR3 molecule is essential for synaptic connections that are formed by the AON to the target molecules. We analyzed this using classical synaptotag tracing, which is another method in which we can trace synaptic connections, and using electrophysiology. I'm not going to go into the details here. I just want to point out that when you look at these slides, you can see that, oops, oh, this is fancy, that here there's a decrease in puncta, decrease in synapses, and here in the input-output curve, or the slope measurements, there's a loss of synaptic connectivity. So this experiment, typical for the types of experiments we do, illustrates that these synapses depend on C1QR3, and thus C1QR3 truly is a synaptogenic molecule in this particular synaptic connection. So then comes the critical experiment. Does this connection have a role in STFP training? And if so, does it have a general role in all kinds of olfaction, or only in STFP training? The way we do this again is using stereotactic manipulations. We use the C1QR3 conditional knockout mice. We delete C1QR3 using these mice by injecting Cre or delta Cre as a control into the AON. Before training, then we train and we test. And you can see on the right that the deletion basically blocks STFP memory acquisition. In other words, you do need the retrograde connection for STFP memory acquisition. Great. This was done before we did the acquisition training. What happens if we do it afterwards, after the acquisition training, and then test longer-term memory? And what you see here is that if we do the injection immediately after training, and then measure later on, weeks later, STFP, it's normal. So if you do it afterwards, it's no longer required. It's only required for the training process. We then tested various other olfactory behaviors, just the ability to smell, a non-social olfactory memory. None of these were affected. This manipulation only affected STFP memory acquisition, but nothing else that we tested in our experiments, suggesting that the retrograde connection is selectively required for STFP memory acquisition, for the social component for social olfactory behavior, but not for other types of olfaction. Further experiments also showed that C1QR3 expression in AON to piriform cortex projecting neurons, or to piriform cortex to olfactory bulb projecting neurons is not required. As I showed you earlier, the idea is that C1QR3 binds to a postsynaptic adhesion GPCR and thereby mediate synapse formation, we can test this by postsynaptically deleting the adhesion GPCR and performing the same experiments. What you see here is exactly such an experiment. When we do this now, deleting the postsynaptic adhesion GPCR, we also block the synaptic connection. And when we measure at STFP training, as you see here, same paradigm, we also block SPTFP memory acquisition, but we have no effect if we do the same experiment after memory acquisition, i.e. that connection again, shown here, is only required for the acquisition. Oops. So these experiments gave some insight into the acquisition process of STFP memory. They suggested that the AON has a critical role in this particular olfactory behavior paradigm, but only in doing the acquisition phase. They also showed a specific role for one particular pair of a synaptogen with its receptor in establishing a synaptic connection and maintaining the synaptic connections. In brain, synaptic connections very often turn over all the time. And so the maintenance of formation and the difference between formation and maintenance is actually not that clear. When we place this into the diagram of the memory formation phases that I showed you earlier, the sensory inputs operate via the main and the accessory olfactory bulb. Memory acquisition involves those sensory inputs, of course, in an interaction with the AON, with the piriform cortex, necessarily, because this is a contextual memory, and the ventral hippocampus. And this is mediated via this transsynaptic complex, because that is essential for this particular synaptic connection. Does that explain how memory acquisition works? No, it doesn't. But it does suggest that memory acquisition for this particular one-trial long-term learning involves a synaptic connection that is not required for other olfactory behaviors, which in some ways indicates that the initial interaction between the olfactory bulb and the AON is more complex during STFP memory acquisition than it is, for example, during normal just olfactory behaviors, normal smell behaviors. A specific transsynaptic signaling pathway underlies STFP memory acquisition, but is dispensable for later stages of long-term STFP memory or for other olfactory behaviors that we analyzed. So much for memory acquisition. Let me move on and tell you about the second project that I was going to discuss with you. And remind you that in mice, social signals are often, maybe mostly, communicated by olfactory inputs that operate via the accessory olfactory bulb. In fact, that is sort of the social nose of a mouse, and maybe of a human as well. So, this project starts again with a definition of circuits. And what I mean with that is the connections, the connectivity. Because despite all the connectome studies that are happening, we actually don't understand really the connectivity of the brain. In this case, we're again using a retrograde tracer, but we're using an AAV, a retro AAV. Details don't matter. It enables the same kind of experiment as I showed you before for the cholera toxin. And we analyzed the connections of the accessory olfactory bulb, not the main olfactory bulb, as I showed you earlier, with the brain. And when we did this, we surprisingly found that the major inputs to the accessory olfactory bulb from the central brain are in a somewhat enigmatic, weird brain region that is shown here, down here. And they're ipsilateral, or not contralateral. In addition, there's connections to the ventral hippocampus and to the entorhinal cortex. This brain region is the cortical amygdala. And specifically, it's not the entire cortical amygdala. It's part of the amygdala complex, which has more than 10 subnuclei. It is the posterior medial nucleus of the cortical amygdala, the COAPM, as shown here at the bottom. And quantifications demonstrate that in this quasi-cortical structure here, which is not a neocortex, but only 3-layered cortex, most of the connections are to layer 3 ipsilaterally. There's some to layer 2, only noise contralaterally. So this was a bit surprising because it suggested that there's a completely different cortical structure that projects to the AON, to the accessory olfactory bulb. And it led us to ask whether this might also have a specific role in STFP memory formation. So we did the same experiment that I showed you earlier, but now focused on the cortical amygdala. And what you see here is the experimental paradigm whereby 3 weeks before the training, we perform bilateral virus injections into the COAPM that express tetanus toxin to inactivate all outputs from the cortical amygdala, or GFP as a control. And then 3 weeks later, we train the mice, and then 3 weeks later, we test them. We also test them on the day of training, day 0, as shown here. And when we do this, as you can see here, or in the memory retention summary, GFP doesn't obviously do anything, it's the negative control, but tetanus toxin basically inactivates STFP learning only after 3 weeks, not on day 0. So it does not have any effect on memory acquisition, only on memory, consolidation, storage, recall, reconsolidation, one of those. Okay? Consistent with this conclusion, if we do the same experiment, by using virus injections after STFP memory training, you get the same phenotype, the same impairment. So in other words, this structure, these connections from the cortical amygdala are required after training. They're not required during training, not during memory acquisition. Okay. So what time after training? When exactly does this happen? Okay. To test this further, as shown here, we specifically inactivated using AIV, retro AIVs with only those neurons in this cortical amygdala that project to the AOB. And we again impair memory training, either 3 weeks before or 1 day after. So it is those neurons that project to the AOB that are involved, essential for memory, long-term memory formation. Now this gives us an idea of how this might work, because it suggests that this particular structure is involved in some phase of long-term memory formation. But we don't know which phase. And in order to further tease this out, we used a technology that's called chemogenetics. This developed by Brian Roth at the University of North Carolina, where you can basically inactivate or activate neurons using a chemical agent in a defined time period. And the way this experiment was done is shown here. We inject into the AOB retroactive viruses and into the cortical amygdala the double-fluxed chemogenetic agent. I'm not going to go into the detail. What this does is that it selectively expresses the chemogenetic agent only in those neurons of the cortical amygdala that project to the AOB. And then we inactivate these neurons either in the first week after training or at the entire period before memory test or in the week before the memory test or just before the memory test, basically during the memory test, trying to test whether it's involved in the recall or in the consolidation. And as you can see here in the bottom, if we do it the entire 3 weeks, chemogenetics inactivates STFP, saline is a negative control. If we do it just before the test, either 40 minutes or during the 3rd week, just before this whole entire time, it has no effect. If we do it during the 1st week, it still impairs memory formation. So these experiments define a very short period when these neurons are required, the 1st week. Not during acquisition, not after the 1st week. In other words, they demonstrate that this particular brain structure is selectively required only for consolidation, not for storage, not for recall, not for acquisition. First time, I believe that it's been possible to separate consolidation from storage and recall. One of the objections of the reviewers when we sent this in for publication was that many brain regions might have the same phenotype, that it's well known, which is true, that the brain operates by distributed information processing throughout the brain. And in this particular paradigm, STFP, there have been previous studies demonstrating convincingly that other brain regions are also involved. So this was a very reasonable objection that led us to test other brain regions as well. And what we found is if we did a similar experiment in the orbital frontal cortex as shown here, it does also impair memory, reproducing actually data, beautiful data, in the literature which already showed this, namely that the orbital frontal cortex, which has no connection with the olfactory bulb directly, only indirectly, is essential for STFP memory, long-term memory, although it turns out that it's essential for later stages. The ventral hippocampus, on the other hand, which is directly connected to both the main olfactory bulb and the accessory olfactory bulb, is not. There's no effect. Neither is the basolateral amygdala, another component of the amygdala complex, or the MPFC, the medial prefrontal cortex. So it is very selective. This process of memory formation, consolidation, doesn't just go everywhere. Now the problem here is, for those of you who study memory, that the ventral hippocampus as part of the hippocampus is supposed to be essential for contextual memories. In fact, whole careers are based on that. Nobel Prizes have been given for that. So clearly, this is a puzzling result because here the ventral hippocampus is not essential. When we express, as shown here, tetanus toxin 1 day after training, how can we reconcile this? And so we tested with chemogenetics whether the ventral hippocampus might be required immediately after training, but not later. Because, as you probably all know, the ventral hippocampus is not really a hippocampus involved in long-term memory. It's more rather involved in short-term memory. And what you see here is that indeed, if we chemogenetically inactivate the ventral hippocampus 48 hours after training, it does impair STFP memory formation. At the same time, when we do this immediately after training for the COAPM, it has no effect. In other words, what happens is that consolidation does involve the ventral hippocampus at a phase after acquisition where the information, the contextual information, needs to go through the hippocampus in order to be consolidated in the cortical amygdala, as shown here. In terms of the output pathways, it's actually unclear what brain regions the cortical amygdala communicates with. We did extensive circuit mapping and found a number of brain regions that are the targets of projections from the cortical amygdala, including, again, the AON, which turns out to be essential. Because when you, using, again, rather complicated technologies, inhibit those projections from the cortical amygdala to the AON, you can impair memory formation, long-term memory formation, not short-term memory formation. So this projection is, again, not required for acquisition, only for memory consolidation. And this is another approach for achieving the same thing, to just prove, as you can read in the paper, that it's really those synapses that are essential. So what does the STFP circuit look like now? We basically have these connections from the main olfactory bulb and from the accessory olfactory bulb that are then interconnected by synaptic connections between these various regions, project to the accessory olfactory nucleus, and then by an unknown pathway are communicated to the orbitofrontal cortex. Thus, we identified a circuit centered on the cortical amygdala that is selectively and only required for long-term STFP memory from consolidation. It is also a brain region, a circuit that involves protein synthesis in the cortical amygdala. How and why? So what does this truly selective consolidation process actually look like? What does it actually do? And so we use transcriptomics to explore gene expression mechanisms, because recent developments have enabled an unprecedented ability in the field to measure single-cell expression of mRNAs. The experimental strategy here is to use deep, smart single-cell RNA-seq. I don't know whether you're familiar with single-cell RNA-seq. There's different methods. There's drop-seq. This is very shallow. There's nuclear-seq, which is also very shallow. There's 10x genomics, which is intermediate. And then there's smart-seq, smart-2-seq, which is the only approach that gives you probably more than 50% of the mRNAs. Drop-seq probably gets you somewhere around 5 to 10%, so it's very, very, you're basically skimming the surface. The way how we designed this experiment is shown here again. We first label the projection neurons in the cortical amygdala that project to the AOB using a retro-AAV. Then we do the behavior training. We have 3 conditions, either plain food, odor, or STFP training. 30 minutes later, we dissect the cortical amygdala, and we do smart-seq 2. And when we do this, we define the neuronal composition of the cortical amygdala as shown here. There are 6 clusters in this UMAP plot, very simplified, that gives you an idea of a cortical structure like this that is basically composed of 6 principal types of neurons, which can be subdivided into subtypes. This is a unique cortical region distinct from other types of cortex. And what does STFP training do to gene expression here? This is a classical heat map that you've, I'm sure, seen before, and it compares the home gate condition, as shown here, with the odor condition and the STFP condition. And you can see that there is a series of genes that are selectively upregulated or downregulated as a function of STFP training, and that are absent from here, which are basically look like random noise. Among these genes that are upregulated by training RTN4Rs, the genes that I showed you earlier that encode the receptors in this bi-complex, for which C1QL3 is also a substrate. Multiple transsynaptic adhesion molecules, including RTN4Rs, that form a complex with bis and C1QLs, are identified here. To confirm these results and to compare STFP-induced gene expression changes between different brain regions, we performed spatial transcriptomics, MERFISH. As you can see here, same paradigm, exactly same experiments, except we're including the OFC, where we don't use labeling because it doesn't project to the accessory olfactory bulb. But instead of doing SmartSeq, we do MERFISH, cryostat sections. When you do this, you get these beautiful pictures of the brain. It's computationally very demanding. It shows you that the composition, the neuronal composition is quite different. What I find quite surprising and amazing, for example, if you look at the 6-layered cortex, it changes as we move along. For the cortex here, this is the hippocampus, and down here is the cortical amygdala. Here you can see the projection neurons that are TDP positive in layer 3 of the cortical amygdala. This is layer 2. And here you can see the olfactory bulb down here and the OFC above it. This enables us to test whether the SmartSeq results are consistent with cortical, with spatial analyses, and also makes it possible to compare different brain regions. And what we found in these experiments is that each brain region is different. And many brain regions really don't have specific changes as a function of STFP memory formation. What you see here is a comparison of the DEX between the cortical amygdala and ventral hippocampus. Both contain STFP-specific changes to some extent. But the ventral hippocampus genes do not overlap at all with the cortical amygdala. They're different. There are specific changes in gene expression programs that differ between the two different brain regions, especially with respect to the synaptic adhesion molecules as shown here. The same thing applies for the OFC, where there isn't even a change as a function of STFP memory formation. The change is entirely sensory, suggesting that the role of this region in STFP memory is contextual. It's basically identifying the sensation, not in the actual memory. And finally, if you compare if you look at which ones of these cortical amygdala specific DEX are actually changed in the OFC, you can see there are none in STFP, although odor does something. So the comparison shows that the OFC, which is also essential for STFP memory consolidation in a protein synthesis-dependent manner, senses odors, not social context. And the RTN4Rs lead us back to this complex that I indicated to you earlier, where we have these two different interactions that are involved both in memory acquisition and in memory consolidation. So the bottom line here is that the RTN4RL by 3 complex controls neural circuit formation by regulating various processes that are essential for synaptic connectivity that I'm not going to describe in detail, and that thereby they're critical for long-term memory formation. I'm at the end of my talk. I would like to summarize what I've tried to tell you here in the second part by coming back to this diagram, whereby the olfactory bulb obviously is essential for memory acquisition, and for memory acquisition specifically for the social memory, this involves retrograde connections from the AON, whereas the cortical amygdala is essential selectively for memory consolidation in a process that involves gene expression changes, which are required, even though the cortical amygdala itself is only required for a week. So that 1 week, gene expression changes are critical for memory consolidation. And in all of these processes, we believe there's evidence to think, although not yet compelling, that by3 specifically mediated synapse formation is critical for all of these steps in different circuits. What is interesting here is that the cortical amygdala acts selectively only in memory consolidation, but requires gene expression changes. To the best of my knowledge, this is the first time a circuit has been shown to be only required for memory consolidation, and basically demonstrating that consolidation is truly separable from other components, at least of this type of long-term memory formation. How this actually works beyond, and why, for example, you need gene expression changes even for a transient stage in memory formation is unknown. So I'm ending here. I would like to acknowledge the people who did the work. The second part of my talk was done almost single-handedly by Jihui Lu, who now is back in China, where she has her own lab. The bio work that I didn't discuss in detail was done by Jia Wang and Yi Miao, who are about to leave the lab, form their own labs. The transcriptomics was done by Wenfei Sun, who is a joint postdoc with Steve Craig's lab at Stanford. It's been a great collaboration. And the work that I've discussed on the memory acquisition was done by Cosmos Wang, who is now a postdoc at Harvard University, and David Martinelli, who is now an assistant professor at the University of Connecticut. I've had many great collaborations, some of which are listed here, that have been instrumental for everything we have done. Thank you. Happy to discuss this or anything else you would like to discuss. Thank you. And you can see I didn't move out of this here. It's like a little, yeah. If I had known that this would be a red carpet, gee. Okay, anyway, yeah. Please, yes, I love questions.
So then this wonderful neuron of yours consolidates after a week. What happens in that neuron during that week?
If I knew that, I would be very happy.
Is it isolated from any further activities? Because it's
So
that
there
particular...
is a very popular concept in neuroscience, the engram concept, which basically says that you activate during memory acquisition a specific set of neurons that then encode the memory. You shake your head, which basically reflects my own feeling. I think it's a rather unsatisfactory concept at this point, especially since the memory that's being actually studied is always short-term memory. It's never long-term memory. And so the whole engram idea, which goes back more than 100 years, was really for long-term memory, but now people talk only about short-term memory. Yeah. We also refer to the cells that we label in an activity-dependent manner, not in this study. We published other papers on this as engram cells, but I find this concept rather unsatisfactory. Our hypothesis is that these gene expression changes, which happen in the majority of projecting neurons, that they change the neurons But in electrophysiological studies that I haven't discussed here, we couldn't find a major change. We could find a small change in excitability, but not anything that we would really be excited about. What we would love to do is to map the synaptic connections quantitatively. We haven't done that because, as you might know, that's not that easy. Yeah. Please, go ahead. Yes.
Congratulations on your excellent presentation. Do we have any indication that during the consolidation period, some combinatorial and recombination capability is happening, which is the hallmark of creativity and innovation?
Okay, could you repeat that? I'm sorry. Yeah.
It's my Cypriot accent. Is there any indication that during the consolidation period, we have some combination and recombination of stored and consolidated material, memory material, which is the hallmark of creativity and innovation?
Yeah, so the idea that we have, and this is hypothetical, based on the gene expression changes and based on basically hypothetical ideas of how memory might be encoded, that consolidation involves a change in synapses, and the output synapses from the cortical amygdala in this case. But the question is really, does that change involve a restructuring or formation of new synapses? I don't know. One thing, people always think we know a lot. We don't actually. We don't know how synapses are eliminated. We don't know how synapses are really formed. We know that synapses have a very highly dynamic nature that differs between different brain regions, but we also don't know how this is regulated. So the best evidence for the restructuring that we have comes from the gene expression changes that I showed you, which demonstrate that the major genes include, to a large part, genes that we and others have identified as being involved in synapse formation.
You will find my question very naive, but it's coming from someone who studies Mendelian disorders and abnormalities in order to understand normality. I was wondering if there are mice, or human for that matter, that they only have long-term memory. And the reverse, if there are mice, humans, that have only short-term memory.
Yeah, great question. There's the famous case of HM in human history, in medical history. HM was a patient who, in the beginning of his 20s, was subject to a complete removal of his hippocampus and some of the temporal lobe because he suffered from severe intractable epilepsy. It cured his epilepsy, but he was unable to learn anything new. He was unable to basically remember something that happened 5 minutes ago. But he had perfect memory of all experiences that happened before his operation. So he could draw a map of his childhood home. He could walk back to where he was as a child. He remembered everything. This experiment, which is unfortunate for the patient, I don't know if it's ethically a good or a bad thing. I have no idea. That's beyond my pay grade. But shows that you can actually separate long-term memory from the hippocampus because the retrieval of the memory worked still, at least the explicit memories, right? Implicit memories actually still worked for the patient. So, for example, he couldn't remember having met a person, but he could communicate implicitly, let's say, with a dog of that person. There are these stories of this patient. So in that's the best experiment I know, or best example I know, where you can actually separate long-term from short-term memory. In general, short-term memory is always a prerequisite for long-term memory, of course. But long-term memory, once it's stored, I think is independent of the hippocampus and can be separated if you eliminate the hippocampus afterwards.
That's quite an interesting one, because it's true that he had these bilateral hippocampal lesions and operations, I should say, and so on. But the trouble with his long-term memory, which everyone says was normal, there's a little grain of disbelief there, because if you look at patients, for example, with Alzheimer's disease, they lose their short-term memory very quickly, and they retain their long-term memory. Actually, if you measure the long-term memories, you give them cards or photographs of things that happened in their past. Their long-term memory is changed, and is sometimes very badly changed, even though it seems that they remember things, they remember in the wrong order.
Yeah, I totally agree. There's two problems here. One is that long-term memory that requires a contextual recognition, of course, requires also the hippocampus. So if, for example, HM was asked to recognize something as opposed to explain something explicitly, his long-term memory would also be impaired. Yeah. The other thing, obviously, in Alzheimer's disease, as you all know, as a degeneration, it basically affects all neurons and it destroys the whole person, unfortunately.
I am surprised that you think that things happen in memory and in the brain that are not contextual.
Yeah.
What do you mean by that exactly? I mean, every time you do even the same thing again, day after day, the context changes, and yet you continue to do it well. For example, a tennis player will, who has a complete memory of how to play tennis that is subconscious in most cases, and when he thinks about it, it disintegrates. If he goes onto a new court, he doesn't change, but if he starts playing on a different terrain and so on, then we know that the contexts interfere with their games. You need think only of Nadal, who was excellent on the dry court, but when he came to Wimbledon, he used to have problems. So it seems to me that it must be very difficult to decide that a memory is non-contextual, completely non-contextual.
Yeah, maybe we're getting a bit into semantics. What I find interesting in the case of HM and similar patients is that they could verbally recapitulate memory. That's what I mean with non-contextual. So, in other words, it's not that they were put into a context, a sensory context, and then asked to recall the memory. It is that they were put into a cognitive context, if you want, okay, and asked to recall the memory. I think if they were put into a sensory context that is not explicit, like verbal, that they would have problems. Okay, I don't know that. It's an interesting question.
So your mouse experiments are controlled for time and sex and age and everything, so that you eliminate most of that sort of...
I'm sorry?
You eliminate most of the noise, and that's why you can repeat your experiments again.
Yeah. Okay, somebody in the back?
Mr. Shukov, very congratulations about your speech. I have a question about the synapse genesis that happens when the mouse become older. When mouse become older, can something happen to all of those experiments and in the amygdala and the hippocampus synapses and all of that circular system when they become all dead?
I'm sorry, I didn't understand the question.
The question is more like what happens when, if we have, your team have done the same experiments with older mice rather than younger mice.
Oh, the age, yeah. Great question. I don't know what would happen. Older mice are clearly not as good at learning than younger mice. I would suspect that they wouldn't be doing as well, but I can assure you that even when you reach my age, you can still learn. So it still works. So I don't know. Yeah.
Thank you very much.
Okay. Thank you. I think the next talk will be about a subject that is related to what I used to work on, which is secretion, but that's a long time ago.
Thank you, Professor. Thank you. Thank you. Thank you very much. And a minor present from us to you.
Thank you so much.
Thank you.
Wonderful.
Thank you.
Yeah? Okay. Now we start section 10, interactive workshop number 3 on internal medicine, endocrinology, and diabetes. I would like to welcome to the podium chairs Dr. Ioannis Kyriazis, who will be online with us today, Dr. Andreas Ptaras, and Dr. Kati Ioannidou Stelia.
Ο κύριος Κυριαζής. Ωραία, να το. Και δεν θα κάνουμε και παρουσιάσεις, απλά τα ονόματα θα πούμε και τον τίτλο.
Αν θέλετε διαβάστε μόνο αυτά.
Ναι, αυτά τα ονόματα. Ναι.
Και δεν θα έχει commentating.
Μπορούμε να ξεκινήσουμε?
Ναι, παρακαλούμε.
Ναι, Γιάννη, προχώρησε.
Many thanks to the organizing committee for inviting me to participate in this excellent conference, and especially to the president and dear friend, Professor Ioannis Patrikios. At this roundtable titled Internal Medicine, Endocrinology and Diabetes, the magnitude of an unresolved problem, advances and new treatment approaches, my co-chairing fellows are Dr. Andreas Ptaras and Dr. Kati Ioannidou Stelia. The first lecture we're about to listen has the title Revisit of the Dogma of Glucose-Stimulated Insulin Secretion in Pancreatic Beta Cells and News Beyond. As we all know, pancreas plays a critical role in maintaining glucose homeostasis through the secretion of hormones from the islet of Langerhans. Glucose-stimulated insulin secretion by the pancreatic B cells is the main mechanism for reducing elevated plasma glucose. Researchers have also uncovered a novel route to stimulate the growth of healthy insulin-producing pancreatic beta cells in a preclinical model of diabetes. The findings hold promise for future therapeutic that will improve the lives of individuals with type 2 diabetes. So, we have the privilege and pleasure to listen to the Professor's Wolfram Greiger's speech regarding the specific topic. Professor Greiger, we are ready to listen to you. Is Professor Greiger listening?
Yeah, but it doesn't work here.
Μπορείτε να εμφανίσετε την παρουσίαση. Could you please present? Okay. Could we see the presentation, please?
So meanwhile, I can tell you that I asked the organizer not to skip the break, so I have more listeners, but I failed, obviously. So, yeah, we can start. Thank you very much. So today what I'm going to tell you is we switch gears from the brain to the pancreas, but it fits very well because beta cells are supposed to be also neuronal cells, so it fits very well to Professor Süder's talk. So what I'm going to tell you today is a little bit a rethinking about how beta cells work, and I think it's essential because we try to design therapeutic intervention against diabetes and how we prevent the progression of diabetes. I think when we try to do that, we should at least know how the beta cells work. And this is basically the common aim of beta cell knowledge. And I just go quickly through it, and I'm sure you know that so far we know that glucose uptake stimulates glycolysis, and glycolysis makes NADPH and pyruvate, and both NADPH and pyruvate enter the mitochondria, stimulating the citrate cycle, again making NADH, and these both NADH fuel the OXPHOS, making ATP. ATP prevents the K-ATP channel, leading to depolarization. L-type channels go open, you get the calcium influx on vesicular fusion, and that's the mechanism for insulin secretion. However, there's one thing, and I tell you, working with mitochondria, it's always impressed me how people ignore that, because the one thing is the mitochondrial ATP production, as we know, depends on the OXPHOS substrate, entirely NADH and FADH, and also an activity of citric cycle, which produces the NADH again. So in other words, to get the OXPHOS activation and the ATP production, the glycolysis-derived NADH has to enter the mitochondria, and that is mastered by a protein that's called ARLA. And ARLA is one of the calcium-dependent part of the malate-aspartate shuttle. On the other side, citric cycling on the other side is also a calcium-dependent mechanism, and particularly the isocitrate dehydrogenase is essential dependent on calcium. As you see here, there are two main mechanisms that drives high glucose-induced ATP formation are dependent on calcium. However, the model doesn't indicate calcium being involved at all. So in other words, when ARLA and EDH are not activated by calcium, the glycolysis would be disconnected from mitochondrial ATP production, and the beta cell wouldn't be able to sense glucose elevation. So in this regard, the beta cell have a very specific mechanism to ensure the direct coupling between the glycolysis with the OXPHOS ATP production. And it is by the beta cells produce a very unique calcium leak from the endoplasmatic reticulum towards the mitochondria, and that is established by presenilin 1. And I hope you realize now, listening to presenilin 1, that really beta cells are somehow familiar to neurons, because we all know that presenilin 1 pops up on Alzheimer's disease. So what is about this presenilin 1 mediated calcium leak? So the mediated calcium leak goes directly to mitochondria. I try to use that. Yeah, here. So the presenilin 1 here, together with some helper proteins, I don't want to go in detail here, releases calcium continuously towards the mitochondria. And you have to realize that the ER calcium is 4,000 times higher than the cytosol. So once when you put a small leak, there's a lot of calcium going through, and this calcium is directed entirely towards the mitochondria. And there, it obviously activates, it does exactly what I told you before. It stimulates RLR and stimulates the TCA cycle. And the mechanism on the other side needs to be equipped that this calcium that comes from the ER has to be refilled, compensated, or refilled continuously from the extracellular space. And this mechanism has been found by a sodium-calcium exchanger here, and then so far non-found, non-discovered sodium channel and TRPC3. But mainly this sodium channel allows sodium to enter the beta cell, and this will stimulates the NCX1, and NCX1 shuffled out sodium again and calcium in. And this calcium is reuptaken by the ER. And as you can see, these mechanisms so far completely unexplored as therapeutic targets on one side, but also a mechanism to introduce diabetes. And what I will show you in the next few minutes is how these mechanisms are important to develop diabetes, and maybe these mechanisms are the clue to understand how type 1 diabetes occurs so suddenly. Okay, so just coming back, what does presenilin, how important presenilin 1 is, a very simple experiment. This is a control, and if you have a beta cell and you expose a beta cell to high glucose, it starts oscillating in calcium, meaning, so now the beta cell senses the glucose, now it can release insulin. On the other side, when you knock down presenilin 1, you see that these oscillations are pretty much reduced, and it results in the reduction of insulin secretion, and I hope you appreciate here the effect of this, all that the presenilin knockdown has particularly the initial insulin secretion is completely wiped out, while a long-lasting insulin secretion remains. And this particular first insulin secretion is very important for tissue priming, and we think about this as a pre-diabetic state. Okay, so in other words, by organizing mitochondrial-oriented calcium leak from the ER towards the mitochondria, presenilin 1 establishes the calcium hotspots in the so-called mitochondria ER calcium contact sites, called shortly MERCs. There, this high calcium elevates matrix calcium, stimulates RLR, and yields a pre-activation of mitochondria despite there's no high glucose. So in other words, if you are sedentary, still your mitochondria is pre-activated in the beta cell, although there's no substrate, but the calcium is high. And the mitochondria basically waits that substrates come and then is producing ATP. So this we call metabolic priming. And in other words, we found out in another stories that this metabolic priming ensures the beta cell susceptibility to elevated glucose. But today I just want to do one step further. And this one step is that we have recently found that this metabolic priming that occurs in the gap between the ER and the mitochondria by increasing calcium and stimulating the uptake of NADH, meaning recycling NADH to NAD, is extremely important to run glycolysis per se. And when you knock down presenilin 1, and this is a very, I think, fundamental finding, beta cell stop making glycolysis. So in other words, when you don't have presenilin 1 here, the beta cell glycolysis makes a bottleneck, which is the first step that need NADH, because here NADH is not existing anymore, cannot recycle because RLI is not activated. Consequently, the glycolysis is not finished. So a beta cell that has no presenilin 1 or a dysfunctional presenilin 1 doesn't have a glycolysis anymore. And the intermediates of the upper part of the glycolysis, these obviously, and this was our idea, might try to trigger a loss of beta cell integrity. So not only that you don't sense glucose, we explored whether these conditions also sensing the lack of identity of beta cell getting maybe an explanation of diabetes. So what we tested is some beta cell marker, and as you appreciate here is that a lack of presenilin 1 in INS cells reduced all specific beta cell differentiation markers, but also in human beta cell cells, you see a decrease in beta cell markers. And finally, we had also the same experiments in mouse pancreatic slices, and you can see here that a knockdown of presenilin 1 yields a decrease of beta cell differentiation markers. So in other words, presenilin 1 not only prevents glucose sensing, it also yields the loss of identity of the beta cell. So what we did is now we tested whether we can rescue when we reduce the glucose exposure of the cells. And as you can see here, just decreasing glucose concentration, you see a normalization of the signal. And this is meaning, again, that these intermediates of the glycolysis that are accumulating during this, in the absence of presenilin 1, yields a normalization of this procedure to a normal beta cell. Interestingly, and this is again a link to the previous talk, we found the same phenotype in an Alzheimer's disease mouse. So what we did is we took the famous 3xTG Alzheimer's disease mice and tested the same protocols in the islets, and you can see here there is a small decrease of several markers of beta cell markers, and interestingly also insulin secretion, particularly the first fast insulin secretion, was drastically reduced, while a long-lasting decrease in insulin secretion was gone. So in other words, here we have discovered a new common molecular mechanism between the Alzheimer's disease and the beta cell dysfunction, and type 1 diabetes. So this, I make the story very short. So we tested all these molecular mechanisms, and you know, I'm a molecular biologist, so we like to play around with these dizzy tools. But we finally had a nice idea what signal transduction means here. But, and most importantly, we had an effect that AMP kinase, which is a very important sensor of starvation, was decreased while mTOR was increased. So there was a lot of signaling. However, and this was very surprising for us, no intervention against AMP kinase or mTOR could rescue the beta cells of losing its identity. So we were thinking, you know, this beta cell on one side is losing its identity, on the other side it has a lot of signaling molecules changing, but they didn't have an effect. So we're wondering what basically was the effect, and this is a very short slide because I'm run out of time. What we find out is that particularly these signaling molecules are important to normalize the beta cell function in terms of immunogenicity. So when you don't have this signaled by presenilin 1, suddenly PDL1, which is a checkpoint protein on the surface of the beta cells, to kind of calm down the immune system. And now we had suddenly this PD-L1 strongly reduced by presenilin-1 knockdown, meaning that this beta cell is very susceptible to immune system. And once the immune system gets activated, by example, measles or some other virus attack, this might result in an attack of the beta cells by the immune system. So just to summarize, this is the normal signaling pathways, how a beta cell on one side saves its integrity and also its functionality. On the other side, when you don't have presenilin-1 that makes this ER calcium leak in the mitochondrial ER calcium contact sites, you suddenly have no glycolysis anymore, but no intact glycolysis, but high glycolytic intermediates, because suddenly you have this bottleneck function. And this leads to loss of identity of the beta cells. On the other side, you have a signaling cascades, particular various different activation of calcineurin, MFAT, AMP kinase, and mTOR that leads to beta cell dysfunction. And overall, I hope I can show you now two new approaches. On one side, we can protect really from diabetes because we can fight against the loss of beta cell identity. And I'm very happy to tell you that the first trials already running in our institution that we try to really prolong the onset of diabetes in human. On the other side, we can intervene the beta cell dysfunction, maybe helping people with already existing diabetes mellitus. With that, I would like to acknowledge my team, particularly the guys who are in reddish that have mainly contributed to this team. And I thank you for your attention. Thank you very much.
Thank you very much. We don't have any questions because we don't have time. Sorry, we don't need questions. So I'll call the next speaker, Professor Hadji Gelaki, dealing a lecture entitled Looking for the Future, From Clinical to Precision Medicine.
Dear chairs, dear colleagues, first of all, I would like to thank the organizing committee and especially my friend, Professor Ioannis Patrikios, for this kind invitation. As you can see, my talk is about a look to the future, from clinical medicine to precision medicine. On this slide, you can see the shape of the Earth from the space in the early 60s, which coincided with the approval of metformin. However, today, this image of the Earth from the space looks completely different. And this circular shape of the Earth is depicted in the consensus for the holistic treatment of type 2 diabetes, and also as the cover page of the supplement of the Pathology journal referring to precision diabetes medicine. But what is actually precision medicine? It's an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. And this approach allows all clinicians and researchers to predict more accurately which treatment and prevention strategies will work for a particular disease and in which groups of people. It is in contrast to a one-size-fits-all approach. But starting with phenotype, the word phenotype is used with many different meanings, and in the biology, the most widely accepted definition of phenotype is observable traits of an organism. And deep phenotyping is defined as the precise and comprehensive analysis of phenotypic abnormalities, often for the purpose of scientific examination of human disease. And why should we care about this precise analysis of human phenotype? Because the combination of deep phenotype data with an increasing amount of genomic data appear to have an enormous potential to accelerate the identification of complications of disease subtypes with prognostic or therapeutic implications. Are we actually ready for such a project? As the medical field has embraced the omics area and big data have provided novel insights into pathophysiology and disease progression, the term precision medicine has been coined to capture the promise of tailoring. It is a movement from one size fits all to personalized therapy. Additionally, precision medicine has also the potential to be used for precision prevention. There is a consensus from the American and the European Diabetes Association about precision medicine in diabetes. And the purpose of this consensus is to define relevant terminology and review the current status of diagnostics and therapeutics in diabetes. Particular focus is placed on elucidating the etiological heterogeneity of diabetes, as well as lifestyle and pharmacological interventions. According to this consensus, diagnosis involves refining the characterization of the diabetes diagnosis for therapeutic optimization or to improve prognostic clarity using information about a person's unique biology. And precision diagnostics employs methods to subclassify patients to enable the successful application of precision medicine approaches. However, the precision treatment the target of precision treatment is to optimize therapy in order to achieve therapeutic goals and to reduce the side effects. Precision therapeutics involve tailored treatment based on information about an individual's unique biology, and precision prevention determines likely responses to health interventions and risk factors, optimizes also interventions and/or minimizes risk factor exposures for a given individual. Monitoring is also valuable for prevention, diagnosis, and prognosis, and includes detailed assessments of biological markers, behavior, diet, sleep, and psychophysiological stress. The focus of precision prognostics includes predicting the risk and severity of diabetes complications, patient-centered outcomes, and/or early mortality, and we have to take into account the clinical and environmental characteristics. The path to precision medicine, to precision diabetes medicine, is a long one. First of all, we have to understand the disease. To take into account all the biomarkers and algorithms, clinician education is needed to take into account also the health economics and, very important, the patient engagement and the feedback of the patient. In addition to all this, there is also the omics universe. Emerging omics technologies such as proteomics, transcriptomics, and many other omics might provide new opportunities in understanding the underlying molecular disease mechanisms, enabling the design of new effective therapies. However, no single omics data type is able to reveal the complex behavior of cells or tissues in different states. There are biological networks that can be used for integration of multiomics data, and this approach might reveal phenotypic differences and underlying molecular mechanisms involved in the occurrence of the disease. According to Einstein, in theory and practice are the same. In practice, they are not. Now, how close are we to precision medicine? We know that there is an alarming increase in the prevalence of diabetes, and is estimated to affect almost 700 million adults by 2050. So a potential solution to reduce the rising diabetes expenditures and reduce inequalities in diabetes care is to shift toward precision medicine. The most recognized classification of diabetes is that from the American Diabetes Association and from the WHO. And nowadays, we have new approaches to precision diagnosis with newer conceptual models. Such a new conceptual classification model subtypes diabetes into 5 distinct clusters and is based on 6 key variables, such as gut antibodies, age of diagnosis, BMI, HbA1c, beta cell function, and insulin resistance. Each cluster has distinctive treatment pathways and varying complication risk assessment profiles diagnosis. This Swedish registry, the ENDIS registry, was actually a great stimulus for further arising interest on the complex phenotypes of diabetes, and according to this, we have now these 5 new subclasses of diabetes: the severe autoimmune diabetes, the severe insulin-deficient diabetes, the severe insulin-resistant diabetes, the mild obesity-related, and the mild age-related diabetes. The rationale for this diabetes reclassification was based on the observation that people with diabetes have different phenotypes and show also a broad variation in the main features of diabetes. According to this classification, complications can be predicted much better than before. And we can decide and choose the right medication for the right patient in order to avoid also the complications. Additionally, precision medicine utilizes genetics. There are more than 400 genetic variants that have been identified, and more research is needed to make precision medicine a valuable option for all types of diabetes. And we have also to adapt our interventions concerning the treatment of diabetes. A few years ago, this article pointed out an urgent need for the review of the current diabetes classification, and also a need to align the classification in line with the known etiology and disease course. And the proposed model was the beta cell-centric classification of diabetes. This beta cell-centric classification system supports the interplay of genetics, insulin resistance, environmental factors, and inflammation in the immune system that cause beta cell disruptions. This beta cell-centric model recognizes 11 interlocking pathways that contribute to hyperglycemia, as you can see on this slide. And on the right, you can see the mediating pathways of hyperglycemia addressed by various available agents. The optimal strategy is to use the least number of agents to target the greatest number of mediating pathways of hyperglycemia. However, this is not enough. Pharmacogenomics is essential for the application of precision medicine, and what is it is one of the emerging approaches to precision medicine, tailoring drug selection and dosing to the patient's genetic features. What we know nowadays about the new drug classes we have available on the market, there are some genotypes that are associated with much better response to treatment of type 2 diabetes using the new drug classes. And this very interesting article pointed out that there are 146 targets of SGLT2 inhibitors that intersected with the disease. And on the right, you see an interaction network for drug target discovery consisting of SGLT2 inhibitors and these 146 targets. Now to the question, how far are we from precision medicine? While precision medicine has the potential to be a game changer, its application is not without challenges. Challenges in diagnosis and classification, challenges in prevention, challenges in monitoring and treatment. Some of these challenges pertain to lack of data. Others are linked to inequalities in the availability and affordability of various diagnostic and therapeutic modalities. It is to be hoped that further advances in this field will bring personalized care within the reach of every individual with diabetes. Now, coming to the end of my talk, we knew genotype, phenotype, and clinical features. Biomarker profile, mediators profile, and omics have been added, and this composition has led from the old classification to the different outcomes and cardiovascular risk factors to composite genetic architecture and to different metabolic profiles. Led also from new technology to better understanding of metabolic pathways and from large databases to patient networks. And all this led to improved care and outcomes. However, dear colleagues, the future of personalized healthcare lies not only in prevention, in precision medicine, but also in artificial intelligence. Both impact the goal of personalizing care in 5 different ways, and their impact is consistent with the ultimate goal of prevention and early detection of diseases. This could actually reduce the burden of disease on the general public and thus the cost of preventive health care for all. And we have learned much about precision medicine, and we will continue to learn. However, its future is complicated, extremely complicated, I would say, like a maze. Probably one of you can find at the end the way to the exit. So, putting all this data of precision medicine in the center of discussion, diabetes seems to be treated in a much more charming manner than before. And with this, I would like to thank you for your attention. Now, I would like to please to upload my questions. Okay, you can scan the QR code and then vote, if it's possible. The question is, what is the role of precision medicine? Right. Oh, 50-50. 30-30. One and two, correct. Right. The next one, please. Classification of diabetes is based on the following key variables. Please vote. The right answer is the A. Gut antibodies, HO diagnosed BMI, HbA1c, beta cell function, and insulin resistance. And the last one, please. Common features between severe autoimmune diabetes and severe insulin-deficient diabetes. Please vote. E is not correct. The correct answer is the A. Early onset diabetes, low BMI, high HbA1c, and insulin deficiency. So, thank you very much for your attention.
Thank you very much for an excellent presentation. Due to shortage of time, we will continue with our last presentation. And I would now like to present my co-chair, Professor Andreas Pitaras, who is a clinical hypertension specialist at George Washington University and adjunct professor of the School of Medicine at the European University of Cyprus. Thank you.
Dear Chair, ladies and gentlemen, we all know that lifestyle changes is the hard homework for the patient. So as you can see here, it's not so popular. And all the international societies suggest lifestyle interventions from the beginning of every step in hypertension management. Here you can see the European Society of Hypertension guidelines, and here the International Society of Hypertension in collaboration with European Society of Hypertension. You can see here four fields: movement and body weight, food and drink, body and mind, and others. And recently, the European Society of Cardiology guidelines here suggest many lifestyle changes in order to get blood pressure reduction and cardiovascular risk reduction. Let's start with exercise. which has a therapeutic, prognostic, and preventing role in the management of hypertension, and has a beneficial effect in every single risk factor and disease, including hypertension, reducing the systolic and diastolic blood pressure by 4 to 10 millimeters and 3 to 8 millimeters respectively. And here in an old publication in New England Journal of Medicine, following patients with severe hypertension taking at least 4 different drugs and having left ventricular hypertrophy, as you can see here, a clear reduction in blood pressure, reducing the medication up to 33%, and we saw a regression in LVH, in left ventricular hypertrophy. But the most difficult exercise is to go to the gym. So we need to improve the implementation of exercise guidelines, because the different exercise programs typically report dropout rates up to 45%. And if we include the wives in the exercise programs, like a typical Greek mother-in-law, the benefits are greater. Unfortunately, only 1 of 3 physicians advise an exercise program to their patients. And the message is that rather than canceling more than 30 minutes per day, we can recommend just 10 minutes of moderate intensity exercise for 3 days per week, because a body at rest tends to remain at rest, whereas a body in motion tends to remain in motion, so we simply need to get patients to act. We need to give a real an exercise prescription in every single patient and include exercise into our treatment plans. The European guidelines suggest up to 300 minutes of aerobic exercise per week of moderate intensity, or alternatively, up to 150 minutes per week of aerobic exercise of vigorous intensity, and supplemented with dynamic resistant exercise. The European Society of Cardiology guidelines suggest more than 150 minutes per week, 30 minutes for 5 to 7 days per week. And here, the International Society of Hypertension suggests all these things for patients. We need at least 3 meds, and you don't have to be a marathon runner to get all these benefits. Just 5 to 10 meds is enough to get all these benefits. And we published recently 2 papers in JACC, which rated as the most important publication for the JACC for the years 2022 and 2023. Here, the first one, the higher the exercise capacity, the lower the mortality rates here in 750,000 population. And you can see here, even in octogenarians, the benefit is there. The higher the exercise capacity, the lower the mortality. And we saw in the other publication that even 1 or 2 med increase in exercise capacity, we have a benefit with decrease in mortality, and on the other hand, a decrease in exercise capacity, we can see a harm increasing the mortality. We all know that in real world, we have many barriers to physical activity, and we have to give many solutions to overcome those barriers to physical activity. And to say that there are 1,440 minutes in each day, and just spend 30 of these minutes doing something that is physically challenging, to follow the activity pyramid and with no excuses. Going to the diet, beyond the religious approach, swallow your pride that contains no calories, the guidelines suggest more plant-based and less animal-based food, salt substitutes with sodium chloride, except in CKD, in renal dysfunction, salt restriction, less than 5 grams, about 2 grams of sodium or teaspoon, increased potassium, except of patients with advanced CKD. Another guidelines approach is reduction to alcohol with a strong suggestion, and adopting a healthy and balanced diet such as Mediterranean or DAS diets. Drink less alcohol and restrict free sugar consumption and sugar-sweetened beverages. And the ISA-GSA guidelines suggest, as you can see here, the fruits and vegetables, protein, potassium, and so forth. Because our food is the #1 cause of poor health. And we faced recently a fast COVID pandemic on top of diet-related diseases as diabetes, obesity, hypertension, worsening outcomes as we all know. And about the nutrition, there is both passion and confusion. We have to prefer healthy foods and not isolated nutrients, and to choose quality carbohydrates with low glycemic response, and to avoid processed meat because it increases the relative risk, as you can see here, more than 2 times. And to prefer all the protective foods. And we have to know that just small changes can have a big impact. Here is the Mediterranean diet, with some variations depend on the different countries. And this is a typical modern diet pyramid, DAS diet. The salt is pretty important in the management of hypertension. Here, the quantity of sodium in DAS diet. And we have to look for the hidden salt in processed foods. It's pretty important. And you can see here the clear difference between unprocessed and processed foods. You can see the clear difference in salt here. Going to the mind-heart-body connection, we all know that stress has a strong relationship with blood pressure, and we all know the Takotsubo stress cardiomyopathy. And the guidelines suggest reduced stress via controlled breathing exercises, mindfulness-based exercise and meditation. And here, good sleep, meditation or yoga, and listen to music to have a possible benefit on cardiovascular risk. And here are 7 ways to reduce stress, as you can see here. This is a nice banner to have to our office and to see it and to see the messages. And the most important thing is that food is the most abused anxiety drug. On the other hand, exercise is the most underutilized antidepressant. Going to the smoking, smoking cessation and referral to smoking cessation programs to avoid blood pressure increases, to reduce the risk of masked hypertension and improve cardiovascular health outcomes. You can see here on the other guidelines, the International Society of Hypertension, and here the European Society of Cardiology, the same approach. But unfortunately, patients enjoy smoking. They usually know the risk of smoking. Patients are not motivated and they have too much stress. We have to inform our patients that smoking leads to up to 11 years loss of lifespan. And here is a nice table from the European Prevention Guidelines showing the lifetime gain from smoking cessation for every single patient. Here, for an example, 3 years. We can give some therapies for smoking cessation, and we need to allow to delay quit date after starting medication, because 40% of smokers make a quit attempt each year. 44 want to quit gradually, and developing effective gradual reduction could engage more smokers in quitting. And we need to inform our patients that there is no safe level of smoking. Even 5 cigarettes per day indicate a higher risk. And we have to have a clear schedule in order to stop smoking. And here to indicate all the benefits of smoking cessation. Another good idea is a mobile cardiometabolic cardiorespiratory unit to have a clear benefit and to give a holistic point of view. Obesity gives a hard time to the cardiovascular system, especially for the younger, and the guidelines give information for weight reduction. Here to maintain healthy weight and waist to height ratio less than 0.5, and keeping the BMI between 20 and 25 kilograms per square meter, and waist less than 94 centimeters in men and less than 80 centimeters in women. Unfortunately, there is a delay to ask for medical advice up to 11 years. And we have the approach of 5 A's: ask, assess, advise, agree, and assist. And you can see here the current options in obesity management, the lifestyle changes, medication, endoscopy procedures, and the bariatric surgery. Here are the three pillars: psychological intervention, pharmacological, bariatric surgery, and on top the physical activity, medical adherence, and medical nutrition therapy. The most important thing is that it's not finding the time you think you need, it's using the time that you have and always ask for permission. It's very important to repeat the messages and to see the patient as equal partner, sharing the patient needs and wants and clinician knowledge and recommendation. Motivation makes you start, habit makes you continue. If it's important for you, you will find a way to do it. If it's not, you will find an excuse, and usually we say, yesterday you said tomorrow. And if you are persistent, you will get it. And if you are consistent, you will keep it. And the promise of prevention depends on robust healthcare delivery, and it's never too late. Thank you very much for your attention.
Thank you very much. Apologies to the audience and to the previous speaker. There is a hybrid last lecture by Professor Magaritsis, who is a professor of internal medicine at the University of Thessaloniki Medical School in Larissa, Greece. Yes, we can hear you if you want to make a start.
Can you see the slides? Please. Okay. Well, good evening, everyone, dear colleagues. Because of an unforeseen illness, I could not be there with you. First of all, I would like to thank the organizing committee and especially Professor Patricios for this honorary invitation again to be part of this spectacular congress. And give me a minute. Well, my lecture is about the diagnostic and therapeutic approach to a patient with hypernatremia. We're going to discuss about an 80-year-old male patient that has a body weight of 70 kilograms with a history of dementia, who was admitted to the hospital because of fever, somnolence, diminished fluid ingestion, and oliguria of 5 days duration. On clinical examination, the patient was febrile with dry mucous membranes, decreased skin turgor, and tachypnea, and the blood pressure was 85/50 millimeters of mercury, while the patient was in the supine position, and the pulse was 125 beats per minute. Lab tests showed leukocytosis, increased CRP levels, increased BUN levels, creatinine of a normal range, glucose 140 milligrams per deciliter, low potassium 3.1 millimoles per liter, but an extremely high sodium of 160 millimoles per liter. In this patient, the central venous catheter was placed into the right jugular vein, and the central venous pressure was very, very low at 1 centimeter of water. Now going back to a little physiology, with regard to plasma osmolality, we know that osmolality of solution, the best method to be measured is directly by osmometer, but this is not always feasible. And for this reason, there are several empirical formulas to calculate plasma osmolality. The best known is the Worthley equation, by which we can calculate plasma osmolality. This is the equation of sodium concentration multiplied by 2, plus the glucose concentration divided by 8, and concentration divided by 2.8. And we all know that plasma sodium concentration is the primary determinant of the plasma osmolality. It can be approximately expressed that plasma osmolality is 2 times the sodium concentration in millimoles per liter. Factor 2, we know, is used to account for the anions that accompany sodium in the extracellular space, that is chloride and bicarbonate. Now, with regard to the definition of hypernatremia, we know that it's a rise of sodium concentration higher than 145. Plasma sodium is an impermeable solid because of the action of potassium sodium ATPase, and it contributes to tonicity and can induce actually the movement of water across cell membranes. Therefore, hypernatremia always denotes hypertonic hyperosmolarity and always causes cellular dehydration because water moves from hyposmolar to hyperosmolar areas. Clinically, hypernatremia is divided into acute, that develops within 48 hours, and chronic one, that develops more than 48 hours, or if there is unknown the time of initiation. And because sustained hypernatremia can actually occur only when thirst perception or water access is impaired, the groups at higher risk of getting hypernatremia are patients with altered mental status, intubated patients, infants, and of course, elderly persons. Please upload the first question, question number 1. Question number 1 is, which of the following statements about hypernatremia is false? I don't know if I have to wait for the audience to vote. A, it is a state of isoosmolality, results in intracellular fluid volume contraction, stimulates thirst, excretion of minimum volume of maximally concentrated urine. It is commonly caused by insufficient water intake. We are looking for the false statement.
Please let me know if I have to proceed or wait. Are you there?
If you could scan the QR code and respond to the question, please.
So the correct answer is that it's a state of dysosmolality. Actually, the false statement is the correct answer. We have already said that hypernatremia. Now, a few words about epidemiology. This is a common electrolyte disorder, an incidence of 1 to higher than 3%. But mortality rates are very significant, from 40 you see to 60%, and the highest mortality is seen in patients with hospital-acquired hypernatremia. One important thing here is that the majority of hypernatremic patients on admission exhibit also hypovolemia. There is a low volume, it's a low volume state, and half also of these patients have at least one additional electrolyte disturbance. So a lab test for the other electrolytes should be done. Hypernatremia is also particularly common in patients in intensive care units, from 7 to 16%, as you can see, and also in about 8% of neurosurgical intensive care units. A little in pathophysiology, when we have hypernatremia, we say there is an increase in plasma osmolality, so that actually stimulates the osmoreceptors located at the hypothalamus, and this has two responses: the release of an antidiuretic hormone, which actually acts on the collecting tube wall in order to increase the reabsorption of free water, and secondly, it's the third stimulation that increases the water intake by mouth from the patient, and these two actions, these two responses actually try to restore plasma osmolality back to normal. With regard to the clinical types, the acute type, as we said, is when that develops in less than 48 hours. There is an intracellular dehydration. As I said before, there's a movement of water from the cells to the plasma, and that leads to shrinking of brain cells. And this is most probably the reason of the neurologic symptoms of acute hypernatremia. But when there is a chronic initiation, more than 48 hours, it happens an adaptive response with adaptive retention of solutes into the brain cells, in order to have restoration of the brain cell volume. And symptoms there can develop, are mild. They can develop when iatrogenically we try to get a rapid correction of the hypertonicity. In that case, we might get a cerebral edema. Now, with regard to the causes of hypernatremia, hypernatremia results either from net water loss, but there is no sodium loss together. And that happens, of course, in diabetes insipidus, either neurogenic or nephrogenic. Drugs that can also cause, most probably, nephrogenic diabetes insipidus, like lithium, amphotericin B, or vatansen, in cases of hypercalcemia or hypokalemia. The second cause is to have hypotonic fluid loss, meaning that you have loss of water, but this loss of water is higher than sodium and potassium losses together. That happens in renal, like loop or osmotic diuretics, in gastrointestinal tract losses, vomiting, diarrhea, or lactulose medication, or skin from cutaneous losses from burns or excessive sweating. More rarely, it might happen also from hypertonic sodium administration, and that is mainly iatrogenic. Please upload the question number 2. Question number 2 is, which of the following types of hypernatremia occurs when sodium loss is accompanied by a relatively greater loss of water from the body? Is it essential, euvolemic, hypervolemic, hypovolemic, or none of the above? Actually, it's what we just said a about that there is a greater loss of water compared to the sodium or potassium losses. That results in which type of hypernatremia? Tell me when we proceed, please. Panel. Well, the correct answer is B. In these cases, we have hypovolemia. Actually, as we said before, this is the most common type of hypernatremia. Now, with regard to clinical manifestations and diagnosis of hypernatremia, of course, history, clinical examination in lab determine the cause of hypernatremia. It's very important to determine the cause. And the increased sodium levels, especially in acute hypernatremia, because of the, as we said, the hydration of the brain cells, results in lethargy, weakness, irritability, seizures, and coma. But this also brain shrinkage induced by acute hypernatremia can cause vascular rupture, bleeding, subarachnoid, and death. That is the cause of death. This is the cause of death in patients with hypernatremia. On the contrary, in chronic hypernatremia, brain shrinkage is countered, as we said before, by an adaptive response, which promotes the accumulation of organic osmolytes like glutamate, taurine, and myo-inositol. And in this way, there is a pooling of water into the cell, trying to restore the cell volume, the brain cell volume, and that accounts for the milder symptoms of hypernatremia that develop slowly. So let's move to the last part, is the management of hypernatremia. To get a detailed medical history is very important in order to address the underlying cause. The second most important thing is to assess the extracellular volume status, actually the effective arterial volume, and I will explain why. And third, it comes third to correct the hypertonicity. In order to manage the underlying cause, we have to stop any fluid loss from the gastrointestinal, from renal, control pyrexia or hyperglycemia, to stop lactulose and other diuretics, to treat if there is any hypercalcemia or hypokalemia, and to moderate medication like lithium or other medication that can cause polyuria. Now, there is a difference between the management of acute and chronic hypernatremia. In cases of acute hypernatremia, it has been shown that rapid correction improves the prognosis without increasing the risk of cerebral edema, because the accumulated electrolytes are rapidly extruded from brain cells. So in these patients, reducing the serum sodium concentration by 1 millimoles per liter per hour for the first 6 to 8 hours is appropriate, in order actually to prevent the consequences we said before, the cellular dehydration, which might induce intracerebral or subarachnoid hemorrhage. This is not the case in the management of chronic hypernatremia. In patients with chronic hypernatremia that develops in longer than 48 hours or it's of unknown duration, the reduction of the sodium should be done very slowly at a maximal rate of 0.5 millimoles per liter per hour in order to prevent the cerebral edema and convulsion. It is recommended a targeted fall in the serum sodium of less than 8 to 10 millimoles per liter per day. The goal is to reduce sodium to 145, and in cases that patients develop seizures, they might need prompt anticonvulsant therapy or adequate ventilation. How can we calculate the water deficit? The calculated water deficit is calculated by this formula in order to get, as we said, levels of less than 8 to 10 millimoles per liter per day. Is the total body weight meters multiplied by serum sodium divided by 140 minus 1. Here we have to also calculate the insensible water losses, that is estimated to be about 10 ml per kilogram per day, and renal or extra-renal, let's say, gastrointestinal tract water losses, and also to calculate in febrile patients about 3.5 ml per kilogram per day per 1 degree of Celsius if there is an increase in the temperature. Now, the preferred route for management of hypernatremia, as we all know, is to administer fluid by mouth or by feeding tube. If neither is feasible of these two processes, fluids should be given intravenously. Hypotonic fluids, of course, are appropriate. like dextrose 5%, dextrose in water 5%, or the half isotonic saline, 0.45. But can we use isotonic saline only in cases that there is a frank circulatory compromise, there is a hemodynamic instability? In these patients, we have first to restore the effective arterial wall. And after selecting the appropriate infusate, either will be dextrose water or half isotonic, or even other infusates can be used, the rate of infusion should be determined. Please upload question number 3. We have a 72-year-old patient who lives alone that is confirmed that has a diagnosis of euvolemic hypernatremia. There is no hypovolemia here. Which of the following is the most appropriate treatment? 5% dextrose in water, loop diuretics, normal saline, sodium bicarbonate, or hypertonic sodium chloride of 3%. As we said before, in hypovolemic hypernatremia, we might use normal saline, but in cases of euvolemic hypernatremia, we have to give hypotonic fluid, and because of that, we should place the patient on 5% dextrose in water. But how are we going to calculate the effect of 1 liter of any infusate we choose to use on serum sodium? How can we be sure that the reduction in sodium concentration would be less than 8-10 millimoles per liter per day? For this reason, this formula has been developed by Androgen Professor Nick Matias. Professor Nick Matias is a Greek professor in Harvard University, and this formula actually can calculate the change in serum sodium according to any infusate, to 1 liter of any infusate. It says that the change in serum sodium is the infusate of sodium minus serum sodium divided by total body water plus 1, and also the second type of this equation can also calculate the change in serum when we also add to our infusate potassium chloride, because a lot of times these patients also have, as our patient, low potassium level. And as you see here, for 5% dextrose in water, of course, we know that there is no sodium there, so it is 0 millimoles per liter. For 1/4 of isotonic, for 1/2 of isotonic, for Auriger's lactate, you see that the sodium concentration of Auriger's lactate is 130, and for, of course, normal saline, we already know that is 154. The total body weight is calculated by this formula, 0.5 or 0.45 for women, multiplied by body weight. So, recapitulating about the management, the assessment of the extracellular body fat is very important, because patients with a decreased volume, that is by far the most common type of hypernatremia, should first be given isotonic saline in order to restore the effective arterial volume. The formula by Androgen Matias actually does not predict the deterioration of sodium patients with hypernatremia and severe extracellular volume depletion, also when there is a marked reduction of renal support. However, this formula takes into account, as we said before, the amount of potassium added to the infusate is osmotically active sodium. For example, to see how important is the potassium chloride we might add to our infusate, 1 liter of isotonic normal saline plus 2 flacons of potassium chloride results in a hypertonic solution, because you see sodium is 154, 2 flacons of potassium is about 27, because each flacon contains 13.5. So that results in 181 millimoles per liter of sodium plus potassium, and that results in an osmolality of 362. It's an hypertonic solution. So, with regard to the treatment of hypernatremia according to body status, in cases with a hypovolemic hypernatremia and the extracellular, the effective arterial volume and extracellular extracellular volume is low, we have first to give normal saline solution, and after we restore the effective arterial volume, increasing the blood pressure, see that there is urine output, enough urine output, then we might go and correct the hypertonicity with hypotonic solutions, dextrose water, or 1/2 or 1/4. In euvolemic hypernatremia, we should give free water replacement or intravenous glucose solution if it is possible, if it's impossible to give water by mouth. And in hypervolemic hypernatremia, that is not so common. Free water replacement plus furosemide might also be used. Therapy should be guided by frequent monitoring of the plasma sodium and not by formulas alone. We have to send every 2 hours plasma sodium concentration in order to see if we have to get proper adjustment of the treatment schedule in order for the safe and effective management of patients with hypernatremia. The last question, we have a patient with a sodium level 168. It has been developed during the last 5 days, so it's a chronic hypernatremia, and we are ordered to start the patient on 0.45 sodium chloride, meaning half isotonic. What is the most important intervention? As we said, the most important intervention should be the not rapid correction of hypertonicity. So it is to insert the central catheter to give the solution rapidly, to reconfirm the order because hypotonic sodium chloride is contraindicated in hypernatremia, to give slowly and watch for signs and symptoms of cerebral edema, or to place a bladder catheter to monitor the output. I will go through this question very quickly because the time is not with us. So the right answer, of course, is to give slowly and watch for signs and symptoms of cerebral edema. And two more slides about 2 or 3 slides about our patient. Our patient was a hypovolemic hypernatremia, was associated with increasing session water losses, most probably because of a coexistent infection. You remember the leukocytosis, increasing FP. The total body weight was calculated to be 35 liters. The water deficit was 5 liters according to the formula shown before. And as we said, since our patient was accompanied by volume depletion, first 1 liter of normal saline solution was initially administered over 4 hours in order to restore, as we said, effective arterial volume, resulting in blood pressure elevation from 85 to 105/75, and there was enough urine output of 200 milliliters. Then we calculated for reduction, as we said, less than 10 millimoles in 24 hours. We had the plasma sodium, as you remember, 160. The total body weight was 35 liters. The renal water losses were calculated to be 500 to 600 ml. The insensible water losses to be 10 ml per kilogram per day so it was 70 kilograms, 700 ml. And because he was also febrile, there were also 270 ml added to this total. This total was 1.5 liters plus the 5 liters of water deficit. And I have created here according to the infusate that would be chosen, what would be the liters per day, first for dextrose in water, 5%. As you can see, it was 3.75 liters of dextrose in water, 5% in water, over 24 hours. That means 156. If it was chosen to give also 4 flacons of potassium chloride, then it was going to 4.91. If it was for half isotonic, it was 5.85 liters. And I have put here, just for your information, if we have chosen to restore the hypertonicity, to actually to reduce the sodium by 10 millimoles per liter per day, and we had to choose normal saline, we should have given to the patient 60 liters over 24 hours, meaning 2,500 ml per hour. As you can understand, this is unacceptable when the patient would have pulmonary edema. So concluding, hypernatremia results from a deficit of water in relation to the body sodium content, which can result either from net water loss or for hypertonic sodium gain. History, Physical examination and labs are guaranteed to uncover the underlying cause. The type and the rate of the infusion is of great importance, since overtreatment has been associated with increased morbidity and mortality. And the last but not least, treatment should be guided by frequent monitoring of the plasma sodium, and appropriate adjustment of the treatment should be mandatory to improve the outcome, especially in elderly and critically ill patients. I try to do my best to be as fast as possible, as quick as possible. Thank you for your attention.
Thank you, Professor Margaritsis, and this concludes our last session. Thank you very much.
Distinguished guests, ladies and gentlemen, and students, you are kindly requested to please take your seats. We will begin shortly. Faculty Inauguration Ceremony of the School of Medicine. Please remain seated at your seats for the Clinical Faculty of the School of Medicine processional. The clinical faculty to be inaugurated are now entering. The platform party of the School of Medicine is now entering. With Dr. Theodoros Litras, chairperson, Professor Anastasios Stefanou, Chair of Research, Dr. Stelianos Kokoulis, Chair of Clinical Training, Dr. Christina Kousparou, Dr. Panagiotis Economidis, and Dr. Katerina Menelaou, Clinical Professor Tassos Karandreas, Dr. Pani Christoloudis, Dr. Charambos Michaliloudis. The Senate is now entering. Please be seated. Please be seated. We're honored to have with us today Mr. Marios Themikleou, Deputy Minister of Health of Greece, Dr. Christoloudis Kaisis, Dr. Petros Agathigeliou, President of Cyprus Medical Council, Ms. Lukia Polygenius, Member of the Executive Committee of European University Cyprus. Distinguished guests, Member of the Senate, faculty, ladies and gentlemen, and dear students. Welcome to the first Clinical Faculty Inauguration Ceremony of European University Cyprus School of Medicine. We are proud to have you with us as we confer certification to our clinical faculty. I would like to invite the Rector, Professor Evstasiou, to the podium for a short welcome address.
Good evening, everyone. Distinguished guests, ladies and gentlemen, dear colleagues, dear students. It is my great pleasure and honor to address you this evening on the occasion of the organization of the Clinical Faculty Inauguration Ceremony by our School of Medicine. There is no doubt to anyone at European University Cyprus, but also more widely in our society here in Cyprus, that one of the most significant developments at our university in the last decade was the establishment of the School of Medicine. The school has already made a significant contribution in training the new generation of doctors in Cyprus, the region, and more widely the rest of the world. 3 years ago, our School of Medicine has expanded its activity to the heart of Europe, Frankfurt, Germany, to contribute further to the training of physicians across the whole of Europe. Our faculty, our professors, and our researchers are the driving force for the development of excellent academic programs, pioneering and responsible research and innovation activity, and service to our community. These are, in fact, the three main pillars of our mission as a university. Central to the mission of the School of Medicine and the success of its academic program for young physicians is our program of clinical training in hospitals in Cyprus and Germany. The new clinical faculty we are inaugurating today therefore have a very important role to play in the training of our medical students and their preparation to be the successful physicians of tomorrow. This year, European University Cyprus has many more reasons to be proud and hopeful for the future. We are inaugurating our School of Veterinary Medicine, which will be located in a newly reconstructed building on our campus. Furthermore, we will celebrate the first graduating class from the International Digital Economy College, a collaborative effort with Minjiang University in China. And additionally, we are thrilled to begin a new chapter with our European partners in the European Universities Alliance Sunrise. I would like to assure our new clinical faculty that they will have our full support throughout their tenure at European University Cyprus in order to best fulfill their very important mission for the benefit of our students. I would also like to take this opportunity to wish our new clinical faculty warm congratulations for their appointment and to extend our best wishes for success in all your endeavors and all your professional and personal aspirations. Thank you very much.
Thank you, Rector Estacio. I would like to invite Dean Elizabeth Johnson for a short welcome address.
I don't have my stool, so I can't see you. Distinguished guests, ladies and gentlemen, dear students, and of course our dear clinical faculty. We gather to celebrate a milestone event. Today, we're here to celebrate the inauguration of clinical faculty to our School of Medicine. Now, many of you may ask, what is in a name? What is a clinical professor, or what is sometimes referred to as a professor of practice? To answer this, I'd like to share a quote from Sir William Osler. Osler said that the student begins with the patient, continues with the patient, and ends his study with the patient, using books and lectures as tools, as a means to an end. Osler's greatest influence was to insist that students learn from seeing and talking to patients. As clinical faculty, you're called to bridge that gap between theory and practice. So you will play a very important role in our students to make that transition from the classroom to the clinic, to a totally different learning environment. As clinical faculty, you're called upon to make a valuable contribution to our students' learning process. More importantly, you're called upon to serve as a role model of what they aspire to be. Now, clinical education is at the heart of medical education. It is here that students are taught how to take care of patients by experienced clinicians such as yourselves. You're an important part, an important factor, so that we can achieve the highest level of clinical training for our students. You teach our students where medicine truly comes alive. As you treat your patients, you're actually also guiding our students with your expertise. It is always by your side that the student learns that patients don't always read the textbook. There's no general standard to follow, but they must learn to think critically, to talk to their patients, or rather to listen to their patients and consider all the signs and symptoms, even the ones that may not be so evident, but rather what the patient is describing, how they feel. So, ladies and gentlemen, at this inauguration ceremony, we must be aware of the momentous underscoring of the enormity of the responsibility of the appointment of clinical faculty brings. As clinical faculty, you're called upon to demonstrate many attributes: commitment, empathy, ethical standards, and of course, up-to-date knowledge and skills such as we were exposed during this Congress. You're called to serve as guides so that our students become tomorrow's leaders in medicine. And this is core to our vision as a medical school. So how will you, as our clinical faculty, contribute to the vision of our school? By inspiring our students, by serving as role models, by providing leadership, by promoting their professional development, and so much more. So as you embark on this next part of your journey with us as a clinical faculty member of our school, and as you prepare as your role as a critical player in the lives, in the professional lives of our students, remember that you take with you an amazing gift to offer society. Some of you will inspire our students by advancing our knowledge and understanding of medicine by discovering new things. Some of you will ensure the future by teaching others. And some of you will guide tomorrow's clinicians by attending to the very meaning of life, one patient at a time. Congratulations to each and every one of you, and welcome to the family of European University School of Medicine. Thank you. I'm going to interrupt the process a little bit to help out. I would like to announce that we have 3 clinical fellowships. These are very important fellowships that we're offering to our graduates. We have a fellowship in clinical fellowship in plastic surgery, cosmetic surgery, that was devised by Professor Neophytos Dimitriadis, as well as one in medical education, devised by Dr. Dourakis, an associate professor of ours. I would like to ask the president of the Cyprus Association to discuss the importance of these clinical fellowships and the meaning of having a clinical fellowship today as postgraduate education in Cyprus.
Good evening, honorable faculty, Dean of the School of Medicine, Deputy Dean, esteemed tutors, new clinical faculty. On behalf of the Cyprus Medical Association, I extend my heartfelt congratulations to all involved for all the programs, particularly to the Dean, Professor Elizabeth Johnson, and Deputy Dean, Professor Ioannis Patrikios, and the professors that are involved in the clinical fellowships that the Dean has just announced. For their dedication and their leadership has been significant all these years. The Cyprus Medical Association proudly supports the academic and clinical community of Cyprus. We firmly believe that the foundation of a strong healthcare system is built upon the pillars of robust education, skill training, and continuous professional development. This collaboration marks a vital step in setting new standards in medical education and clinical practice within Cyprus. Today, I want to particularly highlight the role and significance of the clinical fellowship. A clinical fellowship is more than just advanced training. It is a comprehensive, structured program that nurtures and certifies expertise within specific medical fields. This type of fellowship provides invaluable exposure to both patient care and cutting-edge research, whether through clinical or laboratory-based projects. It is a stepping stone toward mastery, offering healthcare professionals the opportunity to deepen their knowledge, sharpen their skills, and engage in groundbreaking research. The Cyprus Medical Association wholeheartedly supports clinical fellowship, and we are committed to ensuring their sustainability and expansion. We actively promote the importance of clinical fellowship at both national and regional levels, advocating for policies that recognize and encourage this advanced training pathway. In alignment with our commitment to lifelong learning, we award continuous education credits to fellows and tutors participating in these programs, ensuring that their contributions and achievements are formally recognized. We foster partnerships with international institutions, allowing fellows to gain exposure to global best practices, thus enriching their experience and broadening their perspectives. To our dedicated clinical faculty and tutors, I extend my sincere congratulations and appreciation and welcome to the European School of Medicine faculty. Your guidance and mentorship shape the next generation of healthcare professionals with skills and ethical foundations that are so essential in our field. Your role is impeccable and your impact is profound. The European University School of Medicine has already made a significant impact on healthcare in Cyprus. Through initiatives like clinical fellowship programs, we collectively elevate healthcare standards, create opportunities for our brightest minds, and retain them by providing education and career pathways that meet international standards. As we look towards the future, I'm confident that our journey together will continue to bring remarkable advancements in healthcare, academia, and research. With this, and the new challenges coming up along, we uncover opportunities to grow, innovate, and serve our communities for a better future. Thank you all for your commitment to the excellence and for your, I would say, unwavering commitment and devotion to medical education and the field of medicine. Thank you and congratulations.
Thank you, Dr. Agathangelo. The Dean is called to join Dr. Agathangelo to present the Clinical Fellowship Certificate in Plastic Surgery to Dr. Diana Tsantiti. Please.
Say it more slowly. Who are you asking for?
We need to present the Clinical Fellowship Certificate in Plastic Surgery to Dr. Diana Tsantiti.
And who's picking that up for her? Ah, she's here.
The Dean and Dr. Agathangelo will now present the Clinical Fellowship Certificate in Medical Education to Dr. Stavroula Bernitsa, which will be accepted on her behalf by Dr. Eva Tsvetanova. I think, unfortunately, Dr. Eva Tsvetanova, she is not here. She is not here. Dr. Elena Psara will also receive a Clinical Fellowship Certificate in Medical Education, which will be accepted on her behalf by Dr. Violeta Rafai. Thank you. Congratulations, Dr. Tsantiti, Dr. Bernitsa, and Dr. Psara on your achievements. I now call on Dean Johnson to proceed with the investiture on foods and conferment of certification to the EUC School of Medicine Clinical Faculty. Clinical faculty, please stand up. Distinguished guests, ladies and gentlemen, we are pleased and honored to present to you the Clinical Faculty of European University Cyprus School of Medicine. Each clinical faculty member will be hooded by a full-time EUC faculty member. By wearing the green hood of medicine, each clinical faculty member dedicates themselves to the vision, mission, and values of European University of Cyprus School of Medicine. Following the investiture of their hood, each clinical faculty will be conferred their certification by Dean Johnson. Members of the medical community who will receive certification as clinical faculty of European University of Cyprus School of Medicine are Eleftherios Anastasakis, clinical professor in obstetric gynecology, will be hooded by Dr. Charalambos Michailoudis. Konstantinos Gouzias, clinical professor in neurosurgery, will be hooded by Dr. Theodoros Litras. Argyrios Ioannidis, clinical assistant professor in general surgery, will be hooded by Dr. Stelios Kakakoulis. Angelos Kyriakou, clinical lecturer in endocrinology, will be hooded by Dr. Paniotis Economites. Andreas Sinetos, clinical associate professor in interventional cardiology, will be hooded by Dr. Katerina Manelaou. Deputy Minister of Health for Greece, Dr. Marios Themistokleos, clinical professor in neurosurgery, will be hooded by clinical professor Tassos Karandreas. Argyrios Sakalis, clinical assistant professor in primary care, will be hooded by Dr. Christina Gusparou. Congratulations, clinical faculty. No, it was Marios Trifonidis, clinical professor in trauma and orthopedics, will be hooded by Professor Anastasios Stefanou. Mhm. Stavros Tombris, Clinical Associate Professor in Maxillofacial Surgery, will be heard by Pani Christodoulou. And once again, congratulations. Distinguished guests, ladies and gentlemen, you are kindly requested to remain in your seats until the recessional is complete and the platform party and faculty have left. Thank you. To an end. Thank you for joining us on this very special occasion, and please join us for a small reception in the UC cafeteria. Thank you.